is try to find out the possible cause of infertility in that couple. Try to find out their emotional, sexual well-being and any chronic diseases that they are suffering which will alter our management. So with this aim, we begin taking the history, and first we will be starting with the name of the couple, and we have to cross-verify with their Aadhaar cards or any legal documents to confirm that they are husband and wife. And with that, next is about the age. Age of the wife about 35 and husband above 40, we need to underline. The cause everybody will be knowing, about 35 for the wife and above 40 for the husband. Then occupation is important to know because some occupational hazards, sometimes they'll be having a night shift. So this is important to note about their occupation. Next is about their educational status that will help us in counseling them. So next comes the chief complaints, whether it's a primary or a secondary infertility. Secondary, they would have conceived earlier, which may have ended up with an abortion or a live birth. And then, since how long they have been trying to conceive now. Now, once we know since how long they are trying to conceive, with what they have been trying. If they have tried with an ovulation induction drugs, if we have any records with them, which drug was used, what was the dose given, whether follicle monitoring was done, whether there was a dominant follicle, whether a trigger was given, LPS was given, whether they conceived or not, whether there was a missed abortion, this has to be noted. So that whether they have tried adequately or not, and then we can proceed. If they have tried adequately, we can go for the next second line of treatment. If they have not tried adequately, we can plan the same treatment in a better way. So this is important. And if they have undergone a previous ART cycle, what was the dose of gonadotropin given? How many oocytes were retrieved? What was the embryo status? How many embryos were transferred in each ET cycle? Which was the protocol used for embryo transfer and what happened? And whether there are any embryos remaining. So this data we have to collect in the column of about the past treatment history. Next, coming to their menstrual history, the age of menarche is important, and just like any other gynec case, whether they have a regular cycles, what is the duration of the cycle? Less than 21 days and more than 35 days. Now, the recent guideline is 24 to 38 days. Whatever it is, the cycle length is important, and how many days they have been bleeding for. That will tell us about the endometrium status, and whether they have a premenstrual spotting, dysmenorrhea. All these will lead us to a diagnosis, what could be the possible cause. Then the last menstrual period, because all our scan findings, everything will be dependent upon the cycle day. Next, coming to their obstetric history, whether what was their previous conceptions, whether there was an abortion, whether DNCs were done, because all that would have impaired the endometrial growth, and whether there was a cervical cerclage, all this has to be noted. Then their marital history, how long they have been married for, active married life, all this will have a bearing. And whether it's their first or a second marriage, if it was a second marriage, then whether there was any conception in the previous marriage, and whether it's a consanguineous marriage or not. Next, coming to the sexual history, how many times of intercourse they have in a week. There is no guideline as such that this is normal or this is abnormal, but we would like to elicit whether they have tried sufficiently before coming for the infertility treatment. Whether they have any sexual dysfunctions, whether it's a dyspareunia, vaginismus, or erectile dysfunction. This is important to elicit in the sexual history. Next, coming to their personal history, we would like to ask about their diet, whether we can modify it, and their sleep patterns, their constipation history, and habits, alcohol, tobacco consumption, smoking, all this has to be asked for in the history of the wife also. Then regarding their past histories, we have to note if they have suffered from any STDs, tuberculosis, or diabetes, hypertension, thyroid disorders, any surgeries in the past, HSG, what was the finding, if we have any records, how was the tubes, whether there was any hydrosalpinx, or whether the tubes are both patent or not, if any hysterolaparoscopy was done, what was the finding in the hysteroscopy, and laparoscopy, how are the tubes and all, and if any endometriosis surgery was done, what was the treatment given after the surgery, if any ovarian cyst excisions done. So all these surgeries have to be recorded in the past history. So once we complete the history of the wife, we next, and also family history, whether there is a history of twins, congenital anomalies in the family, cancers in the family, early menopause, fibroids in the family. So this will complete the history of the wife. Next, coming to the husband, apart from all these, we have to ask about STDs, diabetes, hypertension, testicular trauma in the past, recent fevers, and any chemotherapies they have received, or any antipsychotic medications they are on. So we have to elaborate upon any medications they are on so that we can modify them in the treatment time. So apart from this, in the husband, yes.
You are able to change
Yes. Also ask about any past surgeries for hernia, hydrocele, varicocele, any orchidopexies and orchidectomies. And even endourology surgeries, we have found that once they undergo any endourology procedure, sometimes they have erectile dysfunction, or sometimes even retrograde ejaculations also have been noted. Okay, sir. Okay. So next comes to the examination. So apart from the pulse and the BP, the initial measurements, we will also measure the BMI. All our treatment, the dosage is dependent on the BMI. And also the outcome of fertility treatments is also, BMI plays a large role. So we have to modify our treatments right from her BMI measurements. So BMI, that is the height upon the, weight upon the height in meters square. Then we would like to look for the thyroid breast examination, and then look for any features of hyperandrogenism like acne, hirsutism, and female pattern of hair loss. And we can even quantify it depending upon the scoring system also. If we don't remember the scoring system, even just a general examination itself, we can diagnose that she has hirsutism. But sometimes cosmetic treatment may alter our diagnosis. Next, coming to acanthosis nigricans can be noted in the nape of the neck and the axilla. Apart from this, the secondary sexual characters, the external genital examination, then per speculum examination, note for any vaginitis which has to be treated, and maybe there are congenital anomalies in the vagina, a septum in the vagina, all that has to be noted. Very rarely we may find endometriosis deposits, sometimes fibroid polyps from the cervix, cervicitis. All this has to be noted in the examination, and per vaginal examination, as in any gynec case, the size of the uterus, the adnexal masses, and POD, sometimes any granuloma is noted, we have to do. And even we can do a per rectal examination to look for the POD nodularity. This completes the examination of the wife. Then the husband examination, either the urologist does or we can do it. We have to note for the size of the penis, the opening of the external urethral meatus, whether there is any epispadias, hypospadias, and look for whether the testis is present or not. There may be a cryptorchidism, or the size of the testis has to be noted, the consistency has to be noted, and this is very important when we are treating a case of azoospermia. And whether the vas difference is felt on bilateral side, epididymis is felt or not, and transillumination, the hydrocele can be noted, hernias have to be noted, and varicocele, and the grading has to be done. That is, grade 1 is, it is visible, it is felt only on valsalva minima, grade 2 is even without valsalva minima, and grade 3 is even at rest. So this has to be noted. Per rectal examination, in case of obstructive azoospermia, we can feel for the enlarged prostate, or sometimes the enlarged seminal vesicle also. So at the end of the history and the examination of the husband and wife, we can diagnose what could be the probable cause. Thank you. Done.
So still we have 2 minutes. So basically,
Hello. So the whole idea of history, we all know, Madam has narrated all the points into detail. But I'm sure we may not be able to notice each and every feature unless we have pro forma made for the case paper, and that's a good idea. But suppose if you, that's a good idea. But the most important thing when we are examining the patient, what are the questions coming to our mind? What is the probable cause of infertility? Whether this patient require any further evaluation immediately, like tubal evaluation, HSG or SCOPy. And third, male requires further more invasive investigation like testicular biopsy or something. These are the three immediate decisions which we need to take. So after this decision, we decide the treatment, whether we want to go for time intercourse or IUI or IVF, whatever we want to do. So if you want to, decide the further investigation, you must assume that whether tubes are going to be at fault or not. So for that, most important thing is to ask for dysmenorrhea, dyspareunia, and chronic lower abdominal pain for the discharge from the private part. So that will give a fair idea about the PID and endometriosis. So at least this patient requires little tubal evaluation quickly. Do you agree?
Yes.
Yeah. And after that, we can go ahead, like galactorrhea to notice galactorrhea and hirsutism. That's the most important thing. So these are the important acne and saline features which practically we must notice. This should not go unnoticed. You have to always make a note whether she has dysmenorrhea, dyspareunia, and chronic lower abdominal pain. Because I take decision of going for tubal evaluation based on these symptoms. Is there any history of pelvic surgery? That's another important point. Okay?
Thank you, sir.
Any question from the audience? Or after 5 sessions we can have, right? Next, Arwa. So introduction slide, can you put, Arwa? Introduction slide, have you included? Not included? Fine. Can you introduce yourself, madam?
Yes, sir. I'm Dr. Nasrin from Chennai. At the outset, I would like to thank Dr. Rajesh Koredia sir for giving this wonderful opportunity. We all have come here to learn practical points from him only. So he has given to promote and to encourage the youngsters only. He has given this arrangement of topics. I'm talking about applied reproductive endocrinology. So the HPO axis is the mother axis or the central axis around which all the hormones of the female body revolve around. So we have the HPO axis in which the GnRH is secreted from the hypothalamus, which acts on the anterior pituitary to produce FSH and LH, which act on the ovaries to produce all the sex steroids, estradiol, progesterone and testosterone. All these are derived from the cholesterol. So through the steroidogenic pathway with the help of the insulin-like growth factors. Apart from this, the other hormones like insulin, AMH, relaxin, thyroid, prolactin, inhibin, activin and growth hormones play a major role in the control of the reproductive endocrinology of the female. So when we stimulate a patient, when we do the IVF or IUI stimulations, we need to know basic concepts about the hormonal interplays. So we have two-cell, two-gonadotrophin theory, so in which the early part of the cycle, that is in the antral and the pre-antral follicles, the LH acts only on the theca cell and the FSH acts only on the granulosa cells. So LH acts on the theca cells to produce androgen from the cholesterol, and this is transferred to the granulosa cells through the passive diffusion, and it is converted into estrogen. Whereas in the later part of the cycle, when the LH receptors are induced on the granulosa cells also, this process can be maintained only with LH. And we know the follicular recruitment happens in 2 phases. The long duration, which is gonadotrophin independent part, and in the current cycle where it is under the control of the gonadotrophins, so it is from the pre-antral stage. So while studying the reproductive endocrinology, we need to be thorough in certain basic concepts like LH threshold, LH ceiling and LH surge, FSH window and FSH threshold. So LH threshold, so at least 1% of the LH receptors on the granulosa cells need to be occupied for the initiation of steroidogenesis. So this has a clinical application in hypogonadotrophic hypogonadism and prolonged down regulation with the agonist, and also in usage of OC pills. So we have to supplement with LH or HMG from the beginning of the cycles for this LH threshold to be satisfied. So the value of the LH threshold is 0.8 international units per ml. So So second is the LH ceiling. This plays a major role in the PCOS endocrinology. So in PCOS there is a high LH levels. So this promotes the production of more potent 5-alpha reduced forms of androgen. So progesterone is not produced adequately. So this androgen is not convertible to estrogen. So the FSH induced LH receptor induction is impaired, and this results in follicular atresia in the PCOS patients. And also there is insulin resistance, and sex hormone binding globulin production is impaired. So there are circulating androgens, more of the circulating androgens. This impairs the estrogen and progesterone feedback, and more intra-ovarian androgens and disordered folliculogenesis happens. So this is the reason for the poor quality of eggs in PCOS. So next is the LH surge. We all know that LH surge happens following the estrogen rise, but the progesterone also has a major role in the LH surge. So this is the cycle, the endocrinology of the menstrual cycle, that is ovarian cycle. So from the previous luteal phase, when the negative feedback is lost, there is a slow rise of FSH, which causes a follicular recruitment, and estradiol production is happening. And once this estradiol levels are increasing, this causes the negative feedback suppression of again FSH. So, and this mitosis is sustained by the granulosa cells themselves. And once the estradiol level reaches the peak, it is followed by LH surge, and you can notice the progesterone rise is also accompanying the LH surge. So then ovulation happens, following which the FSH and the LH value falls, and there is concomitant rise of the estrogen and progesterone. If there is no pregnancy, there is fall of these hormones, and the next cycle is proceeding. So there is concept of FSH threshold. So the follicles with the follicles have differential FSH sensitivity. So those follicles with low FSH threshold, they grow faster even with low FSH doses. So mitosis happens in follicular growth, and more estrogen is produced, and this induces more LH receptors. So there is a concept of FSH dependency slowly changing over to LH dependency. So LH can itself sustain the steroidogenesis. So next is the concept of FSH window. So as long as the FSH window is open, there will be follicular recruitment happening. So when we push more and more gonadotrophins towards the end of the stimulation, the follicular recruitment may happen, but this comes along with asynchrony and more progesterone production. And to summarize the endocrinology, so we have seen the natural cycle, the processes, what all happening. In stimulated cycles, clomiphene causes central blockage of the estrogen receptors. So this lowers the FSH threshold, at the same time extends the FSH window. So multifollicular development happens, and there is a supraphysiological level of the estrogen levels. So this has a clinical implication to use clomiphene in the place of antagonist in low-cost IVF stimulations. Whereas in letrozole stimulation, there is no depletion of the central estrogen receptors. Inhibin production stops the FSH release. So the FSH window is closed faster. So monofollicular development happens. There is also a role by other hormones. Insulin is like a co-gonadotrophin. It increases the LH production, and it increases the androgen production also. So there is non-recruitment in the severe PCOS in early cycle in PCOS, whereas it causes premature luteinization in the late follicular phase. And also it has a practical application in obese patients, where there is a lipolysis and free fatty acid release, and more inflammatory markers are produced, and this adds to the androgen, and more insulin resistance is there. Also, the role of AMH is very important. It acts like a gatekeeper to stop the follicular recruitment, whereas in anovulatory PCOS, this effect is less pronounced. So there is increased early folliculogenesis and accumulation of the small antral follicles, which produce more AMH, and more FSH independent follicular recruitment is happening. So there is FSH-LH ratio reversal in PCOS. This is because more inhibin and estrogen, they cause the negative feedback of FSH and suppress the FSH, whereas there is no lack of progesterone, so there is more FSH pulse frequency and more LH is produced, so the ratio is reversed. So So we also need to be aware of the endocrinology of the endometrial receptivity and also the luteal phase. So if there is multifollicular production, because of the increased steroid release, this inhibits the FSH and LH.
2 minutes to go.
Yeah. So thank you.
2 minutes.
So I request you to add more points for the. Yeah. Yeah. So in the endocrinology of the fresh cycle, it has very important implications. When there are supraphysiological E2 levels, it lowers the integrins and alters the window of receptivity. So there is low implantation rate because of the altered gene expression and immunological profiles. So if you are planning for fresh cycles, you have to do a pre-trigger progesterone level. If it is less than 1 nanogram per ml, you to make it double sure that the ovulation has not happened yet. That is, it is ideal for the fresh transfer. You can do 12 hours post-trigger value also. It should be ideally less than 3 nanogram. If it is more than 6 nanograms per ml, it suggests endometrial advancement, so we can avoid a fresh transfer. That's all. Thank you, sir.
I think question we will take later on, after this session is over. Next speaker, please. Dr. Renu Gelot. She is from Kanpur, primarily great endoscopic surgeon, and not lesser IVF specialist. So she does both the things, very proficiently.
Thank you, sir, and good morning, everyone. It's really a wonderful platform for all of us to learn from each other, and sir and Sachin Dalal sir have definitely taken over this initiative benefiting us all. So, sir has given me 10 minutes, so it's going to be a Maggie sessions. Okay, the endometrial polyps. We have to understand why infertility is happening due to endometrial polyp. We all know it is happening. There are so many other things. I won't go in detail for dogs. Now, for investigations of endometrial polyps, the most important thing is to go for saline infusion sonography. Just put some saline in the cavity with the help of any catheter, and you will see a beautiful endometrial polyp. Otherwise, you can go ahead with 3D, which is again a good one. Now, again, how polyps affect infertility? It interferes definitely with embryo implantations, and they cause mechanical obstruction, and there is increased concentration of glycodelin in the proliferative and pre-ovulatory phase, and there are activated mast cells. So overall, it leads to increase in inflammatory mediators. Can I have the laptop? Can I have the laptop? Because if I have to play the video, they need to be played with the laptop only. Can anyone of you? Acha, you can play this video. Wherever this video is coming, you just keep on playing, okay? So, now the question comes, should all endometrial polyps should be taken out? I've gone through a lot of studies. Less than 10 mm polyps, they are basically suggestive of endometritis. So if you're doing a hysteroscopy, you're going to say just remove it and give long-standing antibiotics for minimum 2 to 3 weeks. And all polyps which are more than 10 mm definitely needs removal. Best is to go ahead with simple hysteroscopy with the help of scissor. I don't think any energy source is needed, and results are amazing. Now, now again this keeps on coming in IUI or an IVF. I think whenever you find a polyp, just remove it. Go for hysteroscopy, only a 5-minute procedure, and just go ahead. Whether it is a 10 mm, 20 mm, 30 mm, hardly matters. So this is again a conclusion which says the same thing. Next slide, please. Next presentation. Yeah. So only adenomyosis I'll talk tomorrow, otherwise rest other things will talk very fast. This thing keeps on coming, this. Yeah, endometrium. Then start with myoma. We'll see, we'll find it out later on. You first needs to close the previous one. And then the fibroid one. That is done. उसके बाद you can play. फिर से देखिएगा एक बार please. I have already checked, it's all working. Otherwise, I'll use my own laptop for the thing. I have brought my laptop also. Yeah. Yes, please do that. Thank you. Yeah. Now, for the myoma, whenever a patient with fibroid comes up, the most important thing is go ahead with the palm coin classification. We all know all myomas of grade 0, 1 and 2, they can be taken out by hysteroscopy. Now, all depends, size and everything, it all depends upon the surgeon who is doing it. 0 and 1 definitely needs a hysteroscopic removal, and 2 also, if it is more than 50% intramural, it needs a removal by hysteroscopy. And if you have some problem in doing a hysteroscopic myomectomy, if it's a large one like 3 to 4 mm, you can give 2 to 3 cycles of GnRH agonist for that, and then you can attempt a hysteroscopic myomectomy. But if it is more than 3 to 4 ml in type 4 centimeter in type 2-3, then you can go ahead with a laparoscopic hysterectomy, because the chances of adhesions are much less in lap myomectomy and results are amazing. And all other hybrid myomas, those who are really big ones, they need very good thing. Now, all investigations, we know TBS is a wonderful one, SIAS, diagnostic hysteroscopy and MRI are a good one. Nowadays, I think the 3D is a wonderful modality. The most important thing is you have to map the myomas, how many myomas they are there. Like in this particular patient, I definitely like to mention she had multiple submucous myomas, hysteroscopy was done. She was lost to follow-up as she was relieved. After 9 months, she came up again. The second this is the relook hysteroscopy after 7 months. Again, she was having lot of myomas, small one. They were removed, submucous, myomectomies was done. And then third relook hysteroscopy was done for her, and the PRP infusion was done in that. And thankfully, she conceived just July only. So this is something very amazing when she is having 13, 14, married life, 2 months, we kept on doing. Since 21 till 23, we are following up the patients and we got the results. And we all know why fibroids are affected. Now, the medical management. Whether to do a myomectomy or whether to go for an IVF is again a big question for all of us. So it is the basic concept I think we have to start as, if patient is having lot of pain, and lot of bleeding which is not managed by medical management in infertile patient, we have to switch over to surgery. But if the pain and everything is being managed by just medical management, other than type 0, 1, 2, okay, then you can just go ahead whenever there is an adenomyosis and multiple myomasis, seedlings and a subserosal myoma, serosal myoma, you can just go ahead with 3 months of GnRH analogs and letrozole, and then you can go ahead with the transfer. But now the studies, they say, amongst all the medications, progesterone, OCPs, NSAIDs, tranexamic acids, they don't decrease the size, okay? They do decrease the bleeding and they have got their own side effects. The best is GnRH agonist. It do decrease the size by 35 to 65% in first 3 months. Letrozole is a wonderful effect by reducing the estrogen concentration in the myoma itself. So the implantation thing, it helps in improving. Mifepristone and SPRMs we are not using as such. Hysteroscopic myomectomy, a wonderful surgery, have definitely improved results in everything. This patient again, a type 1 big 5 centimeter myoma. After 4 months, this was her uterine cavity, and after 3 months, she conceived spontaneously. So that great is when you do a wonderful surgery, but surgery has to be a perfect one. If you are not confident enough in doing this in 1 sitting, go ahead with 2 sitting, or refer it to your endoscopic person. So there are different things. Then there is one good thing I found when I went through this, the Wamsteker classification used by the European Society. It can be helpful in determining the probability of successful removal of submucous fibroids for hysteroscopic myomectomy. Or the STEP W classification. This is good if you have to explain what is going to the future in these patients. Again, the laparoscopic myomectomy. You can play the video, please. Yeah, the minimal, all these is when I have taken all these points from the recent guidelines. A minimal invasive surgical approach to remove symptomatic fibroids of type 2 can be done. Risk of complication, they do increase when fibroid is more than 5 or more than 3 total fibroids. And then important determinants of success as far as IVF patient is, is it depends upon the location, size and number of fibroids. Again, any myoma which is more than 5 centimeter needs removal, and it definitely, even if it is an intramural myoma, even on the ultrasound it is not very close to the endometrium, it will definitely affect implantation. There are very well proven studies for that. So all in all more than 5 centimeter intramural myomas also warrants removal, and the final verdict in these myomectomies is you have to close the base very efficiently with the help of base. You cannot afford to close it. Yeah, this is my second presentation. So you have to close it nicely. So to conclude, in myomectomy for submucosal fibroids, it improves outcomes in type 0 and 1. Administer gonadotrophin releasing hormone for 2 to 3 months when fibroid is more than 4 centimeter to reduce the likelihood of two-stage procedures. Type 2 fibroids of more than 4 centimeter, consider abdominal or laparoscopic myomectomy. Subserosal fibroids are unlikely to have any impact. Avoid surgery in presence of fibroids, intramural fibroid less than 5 centimeter when uterine cavity is regular, and offer surgery first to women with intramural fibroids more than or equal to 7 centimeter, but proceed with IVF treatment without surgery in presence of fibroids of 5 to 6 centimeter in first attempt IVF. This is important, and this is what this study is saying. They usually offer surgery for fibroids of 5 to 6 centimeter if the women had 1 or 2 failed IVF, and if there are difficulties with ovarian accessibility due to fibroids, definitely we have to prefer surgery over IVF. So this is a very important thing which we have to go for. All myomectomies, we know we have to wait for 6 months post myomectomy to go ahead with IVF and to ask them to proceed for surgery. Thank you. Yeah. Okay, for tubal factors, we all know it's going to start probably. It will take some time. Yeah. Can we go ahead with discussion, sir, if you want? No?
I want to say, what is
Acha, theek hai. So tubal factors, no? You're going to start that? Yeah, okay, fine. Slideshow, yes. So tubal factors we all know. One of the things which gives a straight away diagnosis of tubal factors, we usually either we go for surgery or we go for IVF. Again, it accounts for 30 to 40% of infertility. Tubal damage results in blockage in 12% of cases, and incidence increased 23%, as sir very nicely said. Ki kahin bhi if the patient is having any lower abdominal pain, any PID, it may be suggestive of tubal thing. And incidence will increase to 23% after PID, and infertility women with blocked fallopian tubes and hydrosalpinx, they account for 30 to 40% of entire infertility population. We all are seeing this. And 2 episodes, 1 episode of infection lead to 8%, 2 it leads to more than 20%, and 3 and more episodes of PID it leads to more than 40% cases of tubal infertility. Test we all know, HSD is a good one. Otherwise, laparoscopy and chemoperturbation if you are having any confusion in that, and it will be both diagnostic as well as therapeutic. Now the types of tubal blockade, it is very important to assess. You can assess it in the HSG or not, otherwise you go ahead with lab. Then it can be either proximal or distal, it can be unilateral or bilateral. Now this is very important. There was a very nice classification again given by Hurl and Rutherford regarding what you are supposed to tell to these patients. If you are subjecting these patients, like anything comes wrong in the tubal factor in HSD, now you are asking your patient, I'll go ahead with lab. Okay, so now what you are going to tell them about lab histro, what is the prognosis of having an open patency and infertility being treated by lab histro. So this is a wonderful classification, unilateral, bilateral, what is the position of obstruction and all that. You can go and read it. Then there are different causes, you have to inquire about them. About the spasm is a very important thing which gives a very differentiating factors. And then in the isthmus, there can be salpingitis ischemica nodosa, tuberculosis, salpingectomy, adhesions, fibrosis, infections, tuberculosis, and endometriosis. I think one of the most common things we encounter. Now, how the hydrosalpinx is occurring, we all of us are knowing that something is going wrong, and then those cilia and absorbing thing is going lost, they are lost, and the fluid is getting collected and it is not getting absorbed. It's not like that fluid was not being produced earlier, it was being produced, but it is now getting accumulated at one place. And there are theories which leads to detrimental effect of hydrosalpinx on IVF. They say they affect everything, though the disease is in the tube. It is affecting the ovary, it is affecting the endometrium, it is affecting certain nutrition thing, direct cytotoxic effect, inflammatory response. It leads to even mechanical washout and affects endometrial receptivity and inhibition of embryo implantation. Video please. So whenever you are saying now, again you have to decide what you are supposed to do. Fimbrioplasty have got wonderful results. Previous cesarean section, previous history of any surgery, you are finding a tube block at the proximal line. Very beautifully you can open it up, just give a cruciate incision on the fimbrial side, put some saline, do this thing, and patient usually conceive. These are all those surgeries in which the patient have conceived spontaneously, and adhesiolysis, believe me, in endometriosis patients and previous surgery, previous LSCS patient, it works wonders. So when you are supposed to go ahead with IVF, when you are supposed to give this verdict, yes, I am going to go ahead with IVF, there is no point in going ahead with lab. When you are expecting extensive pelvic peritubal adhesions, age is more than 40, impossible tubal reconstruction, when it is more than 3 centimeter of block, there is extensive tubal damage, failed tubal surgery, and hydrosalpinx ka diameter is more than 3 centimeter, nothing to do. And existence of other infertility factors like adenomyosis, male infertility, and other things. Now, salpingectomy is the most commonly used treatment for hydrosalpinx, and the pregnancy rate increased to 31%.
Can you conclude?
Yes, sir. Sure. So things to ponder is diagnostic laparoscopy followed by lysis increases the conception in following 6 to 12 months. Thank you, sir.
Now what is question answer next?
Sir, one uterine anomaly thing, you only gave it. Anomaly, last one. Sir. Last one, yes. Adenomyosis, I take it. It's not working? Okay. We'll see later on. Otherwise. So uterine anomalies, again I would like to say we have to go ahead with the ASRM classification. We can take up that presentation if you want later on. Because it contains wonderful surgeries showing for the uniconvate, biconvate, Robert uterus, and other uterine congenital anomalies. Probably that's why the file is heavy. So we have to, first of all, whenever a patient comes to us in HST, we see a uniconvate uterus or a septate one, then a 3D ultrasound is a wonderful diagnostic modality to differentiate what exactly it is. Nowadays, we have diagnosed lots of acums with 3D, we have diagnosed lots of accessory horns, we have diagnosed Robert's uterus with 3D ultrasound, and then accordingly you can counsel the patients, and definitely the prognosis of infertility and pain is great. So you have to diagnose, and then you have to designate which classification this particular surgery belongs to. And we all know septoplasty and all those surgeries, they increase the conception rate by 50 to 60%. You have to keep the patients on estrogen and progesterone for cyclical 3 months. To prevent adhesion, you can put an intrauterine Foley's for 2 to 3 weeks. And then you can go ahead with a relook hysteroscopy to prevent adhesions. This is all. Thank you so much.
Thank you. What is next session? Question?
Question answer for 15 minutes.
Okay. Question answer for
15 minutes.
15 minutes. Okay. So please feel free to ask the questions. Please. Those who want to ask the question, please make it here. Please keep the assurance pertaining to these whatever topics are discussed. Please.
Dear Renu, if the fibroids is on anterior wall as well as posterior wall, and the size is like we can remove it by hysteroscopy, then what you are doing, first you are removing anterior or posterior, and how you are preventing. I think interseed is working very well in these cases to just prevent the this thing adhesion, and how you are going with anterior and posterior?
Yeah, ma'am, for anterior and hysteroscopically you are asking me. So better is whatever you feel comfortable. If you feel operating anterior first, it all depends upon the size. And ma'am, anterior is also quite a long word. Whatever you feel comfortable operating upon, just do that. And just to prevent the adhesion, we have to believe in simple thing. I have never ever put a single interstitial lap or hysteroscopic myomectomies. I find it very expensive thing to put a 5,000 thing. You can just put a simple intrauterine Foley's for a 1 week and put the patients on estrogen. That is it, ma'am. And it works wonderfully until date by God's grace. Nothing, no adhesions usually happens.
And one more question, if the fibroid is not more than 5 centimeter intramural fibroid, then sometimes what happens if we are not, and it is not encroaching the endometrium also, we are not removing, sometimes implantation failure occurs. So how the myoma affect the implantation, please?
Yeah, ma'am, there was a long list of theories which now suggest if you are encountering a patient with recurrent failure, it's better to go ahead with myomectomy then. Right.
So, regarding the question, anterior or posterior myoma. So, if you notice carefully when you are doing hysteroscopy, when you are manipulating or doing anything on the anterior wall, lot of bubbles keep coming. So you have to, keep the outflow open many times when you are dealing with the anterior wall. So suppose if you have done myomectomy, hysteroscopic myomectomy on the anterior wall, first the posterior wall, and then while doing the anterior wall myoma, when you are deflecting the uterine cavity, the bleeding from the posterior wall starts coming. So it is always a good idea to deal anterior wall first and then posterior, logically. Second, regarding the cutoff size of the fibroid. So if there is no implantation failure, I believe 4 centimeter is good enough. There are a lot of studies which has proved, and the lowest they suggested whether the myoma or fibroid is problematic or not. If it is more than 2.85 centimeter, that was a cutoff decided in very large study. So approximately 3 centimeter, more than 3 centimeter, you should have tendency to remove. But if it is not disturbing the endometrial cavity, you can give one try of embryo transfer. And if that fails, I think you should think about the myomectomy. Because fibroid, especially when it is a type 3 fibroid, type 3 fibroid there are various conclusions. The effect of type 3 fibroid again depends on the age, how age of the fibroid is away from the endometrial margin. If it is say less than 2 millimeter, then on the contrary it is beneficial. If it is more than 2 millimeter, if it is less than 1 millimeter, then it affects according to the study. And it has been noticed that even in the fibroid, type 3 fibroid, which is not actually encroaching the endometrial cavity, but if type 3 fibroid is on the anterior wall, the integrin expression which are important for the implantation are getting affected from posterior wall also. So doesn't matter fibroid is in the anterior wall or posterior wall. The overall cavity's implantation potential is reduced. That you have to always keep in the mind. So don't be too conservative. When it comes to IVF and implantation failure and fibroid is concerned, don't be too conservative.
Okay.
Another point is that if you have a fibroid which is 3 to 4 centimeters, but if you feel it's in the lower segment, whereby you might be having a problem navigating the intrauterine catheter, the FET catheter, you might probably want to get the fibroid out. Other thing what we've commonly observed is you have a fibroid which is 3 to 4 centimeters. If she becomes pregnant, the uterus is going to grow, the fibroid is also going to grow commensurately. So my cutoff is 3 to 4 centimeters, I don't go up to 5 centimeters. And if more so, if it's an elderly woman, if she's got only 2 or 4 blastocysts, आपने 2 blastocysts डाल दिया and वो fail हुआ, then what? She cannot afford a second cycle. So best thing is to get the fibroids out, restore anatomy, and then go with the FET.
Thank you.
Thank you.
I have 2 questions with my patients. Whenever we see hydrosalpinx, we do a diagnostic laparoscopy. Patient is 35-year-old. There was a big hydrosalpinx, but not willing for clipping in the first go. Internally, we were thinking that we'll motivate her for IVF. didn't get motivated for IVF. We did whatever we could. With IUI she conceived, she aborted. Then after 3-4 months that hydrosalpinx again started showing in the ultrasound. We motivated her again for laparoscopy and that clipping. Patient is still not ready. How do we proceed?
Hello? Hello? Patient is having
Hydrosalpinx, big hydrosalpinx.
Now,
Patient is 35-year-old.
Hello?
Conceived with IUI. Patient is very positive that even if you do IVF, I will conceive. I don't want my tube to be clipped.
See, whenever there is a hydrosalpinx, you have to counsel the patient. That message should not be given to the patient that if there is a hydrosalpinx, there is going to be 100% implantation failure. It reduces the implantation by 10%. Suppose she has chances of successful pregnancy, say for example 30%. Then if there is a hydrosalpinx, it will be 20%. So if she is okay with the reduced implantation rate and more effort, more trial, more cycles, then she can keep the tube. But you have to explain then what is the use of keeping the tube? If the tubes are damaged, the integrity, functionality of the tube is not gone. So I always, explain to my patient like this. Suppose you have got, you can see I have got two hands. Two hands. And if you sit and if you observe me working, so you understand that these two hands, this is useless. So tubes are like this. So this to be explained to the patient that if the functionality of the tube is not there, because sperm is going to get the nutrition, the egg after release is going to get the nutrition, zygote is going to get the nutrition. So if the functionality of the tube is not there, which is supplied, the nutrition is supplied from the endosalpinx, and in hydrosalpinx it is damaged, badly damaged. So this point you have to explain. And second point you have to explain, I always tell them that both the tubes are like two sisters. If one sister is affected, another sister is likely to be affected. So always when there is a hydrosalpinx, even if it is a unilaterally detected, sonographically detected hydrosalpinx, always have doubt on the functionality or performance of the another side fallopian tube. So these patients should not be given too much long trial. And whenever you opt for salpingectomy, even if opposite side tube is not good, apparently good, you after counseling you should bilateral and opt for the IVF.
Okay. And there's another patient. She had very bad endometriosis. We removed the endometriotic cyst, did an IVF.
Endometriosis, have you recovered? No.
No.
It's left, no?
So maybe later.
Can we take the question?
But very small question. Practical.
Yeah, please.
So the patient is 32 years. Good blasts are with us. 2 remaining now. 2 transfers we have done. I think we missed on the adenomyoma, 2.5 centimeter posterior wall adenomyoma is there. She conceived once, missed abortion was there, twins were there. And now, whenever we tell her that you get this removed, she is apprehensive. So we should go ahead with the transfer or not after down regulation.
If there is endometrioma,
it's adenomyoma in the posterior wall, 2.5 centimeters. And the cavity, hysteroscopically, the cavity is okay.
Yeah. So regarding the oocyte quality and embryo aspect is finished.
Yeah.
Now we are worried about the implantation potential in the presence of adenomyoma and endometriosis, right? It's a rule. Whenever you want to do a transfer, embryo transfer, in presence of adenomyosis and endometriosis, it should be always down regulated. Number 1. Number 2, no fresh transfer in presence of endometriosis and adenomyosis. These are the 2 basic rules to be followed. Now, what are the problems with the implantation in presence of adenomyosis and endometriosis? The first, there is excessive aromatase expression, there is excessive inflammatory markers, so which reduces the implantation potential and the expression of the molecules which are important for the implantation. So you have to take care of the inflammatory markers, and you have to take care of the excessive expression of the aromatase. So how to take care? Agonist is a wonder drug. Agonist depot, if you down-regulate, it will take care of everything. If you add letrozole to that, it will further help. So if you do a down-regulation for 2 months with the letrozole and
quickly,
transfer,
can you tell the regime quickly?
so down-regulation for long down-regulation for 2 months. So there are various ways. You can start from the second day, on the second day of the period, give first dose, repeat after 28 days, again repeat after 28 days, and continue letrozole. Now, whenever you want to, a very practical point I want to add, when you give a first dose of agonist depot, in case of endometriosis for long down regulation, there is an initial flare effect. So at that point of time, if you start letrozole right from that point of time only, then there are very high chance of cyst formation. So please do not start letrozole immediately, simultaneously with the agonist depot. Wait for 6 to 8 days. Suppose even if you want to give letrozole with the agonist depot, please wait for the flare effect of the agonist depot to subside and start after 7 to 8 days of lupron depot. Then probably you will not have the cyst formation. So letrozole to be continued, 2.5 milligram is good sufficient, and up 2 months it should be continued, and following which withdrawal periods, withdrawal, once he gets the withdrawal, and if he doesn't get withdrawal, you can give the small dose of estrogen and progesterone. Once he gets the withdrawal, you can or without withdrawal even, after 2 months of down regulation, if everything is endometrium is fine, then you can start preparing the cycle.
Now,
with
one of my patients has got
the query is whether this endometriotic cyst requires to be removed and adenomyomectomy is to be done before transfer. No. If the endometrial line is okay and there is no too much disturbance of the endometrial myometrial junction, I think you need not to do anything except down regulation.
Yeah, and I was not knowing. I started letrozole. Patient has had a cyst. Another patient. Now what to do?
Normally after
she has a very big cyst. She has.
Fine. So that cyst will become dysfunctional. Maybe after
Yesterday was a day
2 weeks.
So I sent her back. I said I'm
2
going
weeks.
for a conference.
After 2 weeks, that cyst is going to be dysfunctional. It is no more functional.
After
but
how
still,
many
that
weeks?
is going to be disturbed.
How many weeks, sir?
2 weeks.
So I'll wait for 2 weeks.
Yeah.
Okay. Thank you.
Thank you.
Can I just add, in case you have that cyst on day 2 and you are waiting it out, just give her one course of Overall L as well. Overall L is a good estrogen progesterone combination OC pill, adequate dosage, not very low dose, not very high dose like Overall G. But one thing is certain, once you give her Overall L, her cycles will be normal, her FSH, LH both will come down to normal baseline levels. And most likely when you see her again post-menses, the cyst would have gone off.
And then we can start the...
Absolutely, because your overall is also going to help in down regulation. Secondly, regarding the clipping patient, what I advise my patients is the fluid is going to come through the proximal end and is going to wash out the embryo.
This is what I tell them. I show the video.
Right. So in spite of that, if they are not willing, just take a negative consent and let them be. And thirdly, when we are doing a surgery, I prefer salpingectomy to clipping because then the fluid keeps on accumulating, it forms a big cyst, it causes abdominal pain. When we are doing the surgery, the incision and the cut should be very near the tube and not near the ovary in case if you've not done a oocyte pickup. Because what happens is if you are near the ovary, you might reduce the ovarian vasculature, thereby reducing the number of follicles. At the same time, so you have to see to that you are very near the tube. You can just touch the tube and get the tube out. And you have to go right up to the myometrium, because sometimes what happens is if you left a stub behind, inadvertently a patient might have a cornular angular pregnancy. So just go deep into the myometrium and cut it out at that point and cauterize it after that.
Yeah, very well. we can take one of the
Sir,
questions.
can you please explain the pre-trigger and post-trigger progesterone level once again, please?
This is not related. Okay.
Sir, she...
I'm going to cover in my talk,
Okay,
for sure.
thanks.
Sir, role of unipristol in submucosal fibroid.
Unipristol in?
Submucosal fibroid.
In?
Submucosal
fibroid.
See, submucosal is any fibroid we don't have, there is no drug which will wash off the fibroid.
Whatever drug we have, it will just reduce the size of myoma. So submucous myoma may already it is going to create that mechanical hindrance and so many inflammatory mediators which will be there. So anyhow, any submucous myoma have to be removed for infertility. Even for a IUI, even for a timed intercourse, you have to remove it. There is no doubt
any
about
size or every...
No, any submucous myoma. Just imagine we have just a 3 ml की uterine cavity. Just 3 ml uterine cavity is there. And उसमें अगर 2 mm का भी fibroid है, 1 mm का भी fibroid है, हम कह रहे हैं कि 10 mm का भी even if you have endometrial polyp you have to remove. Polyp तो थोड़ा फिर भी it has got like that. Myoma itself have got lot many other things to do with the inflammatory mediators and other things. So any submucous myoma of any size, whatever it is there, you just remove it. It is always good.
Can I just add a point about ulipristal? The problem with ulipristal is we had that report saying that it is liver, not liver friendly. So that is one thing. Secondly, ulipristal will only show effect after 3 months of administration. In first month you will not see anything because I have used that when it came and then stopped using because it was thoroughly useless. So the dose prescribed then was 3 months you give ulipristal, stop for 1 month, later have a breakthrough bleeding and again you start. So only after 3 months of ulipristal you might see a 25% volume reduction. And once you stop the ulipristal, trust me, it will go back to where it was. So patient has wasted time, she's wasted money and she's wasted hope saying that it is going to go off. So best thing as Dr. Renu said, all submucous fibroids have to be removed. Now if it is type 0, type 1, hysteroscopically, type 2 to 3 depending on the skills and depending on the size of the fibroid.
So one word about adenomyosis. If there is a large adenomyosis and if we want to down-regulate it for a longer period like 6 months to 9 months, we can put that LNG IUD. It works, Mirena, it works wonder for patients, those who have very big adenomyosis, especially even in infertile large adenomyoma patients when we get and they are having lot of pain, it do work. So there is no need to do any surgery in such big adenomyosis also. Even when we have to wait for 2 years, 3 years or 7 months, 9 months before transfer, you can just put that LNG IOCD, it works best. And so one word about that hydrosalpinx, when patient is not getting ready, you can just give an incision in laparoscopy on the anti-mesenteric border and do some ablation so that at least new hydrosalpinx is not being formed and probably if she wish, she can conceive by time window.
And in hydrosalpinx, when you are doing ovum pickup, suppose your patient is not opted or you are not opted for salpingectomy, when you are doing pickup, after finishing pickup, it's always a good idea to drain the hydrosalpinx. Although it recurs, but still it's a good idea. That's one thing. Second thing, in adenomyosis, it's not necessary that agonist downregulation only will reduce the inflammatory markers and all the ill effects of adenomyoma. As Sachin suggested, OCPL is good enough, I tell you. So continue OCPLs for 2 to 3 months, 2 months, at a stretch 2 months. 2 packets of OCPLs. We'll also, following that, you can go ahead with the transfer. And third thing, Dr. Renu, regarding the polyp, you said that it is suggested that more than 10 millimeter polyp requires removal. Is there a role of looking for the vascularities, the supply, the blood vessel which is feeding the polyp? Is there any significance?
Of course, sir, because polyp will definitely, that's why it is like.
That's why for endometrial polypectomy it is recommended to go ahead hysteroscopically only because we have to cut that feeding vessel. Because if you are doing a blind DNC, probably some mass of endometrial polyp will come down, but that feeding vessel will be there, and then that is the cause for the recurrence of polyp. So it's always recommended to go ahead hysteroscopically to cut that feeding vessel or just go ahead like that. If you are not comfortable enough with that, then you can use that loop also for that.
So even if it is a borderline polyp, say for example 8 millimeter polyp, but that polyp has got feeding vessel, I think it's a good idea to remove. Because there are different studies which says that forget the size of the polyp. Whenever you can, if you document the polyp will be removed if there is an implantation failure.
Sir, regarding myomectomy, conception after myomectomy, my understanding is that if you open the cavity, then you have to wait for 6 months. But if the cavity is not opened during myomectomy, you could try for pregnancy after 3 months.
3 weeks?
3 months.
3 months.
Am I correct, sir?
Yes.
Because madam said to wait for 6 months.
Yeah.
You want to ask if the cavity is open, that's fine. Let discussion go, because we are here for that only. Yeah. So if the endometrial cavity is open, what to do? What is your take on that?
See, it again depends upon the size of myoma which you are removing. If it is a small myoma, 3, 4, 5 centimeters, it's fine. But like if we have done a 10 centimeter myomectomy, we have done a multiple myomectomy, hysteroscopic myomectomy, you are not supposed to wait. Yes, you can go ahead after 3 weeks, 3 months, no issues, because we are not breaching, though we are there in the endometrial cavity, but we are not breaching that myometrium. But in intramural myomas, in very large myomas, when you are breaching the complete myometrium, in spite of endometrium, I think, see, endometrium heals beautifully. We are not worried, and it is not giving strength to the uterus. What is giving strength to the uterus is the myometrium. So why we are asking the patient to conceive after 6 months? Because we want that uterus to be good, to have a nice integrity, even if the patient conceive. And recently I had a patient which I operated for interstitial ectopic pregnancy after adenomyomectomy done by someone else 8 months back. Wonderful surgery, patient conceived, but then she has an interstitial ectopic pregnancy just after 8 months. So all these things are important learning point for us also. The patient was having ectopic just at the interstitial end of that thing. So it's better to let her, and anyhow, whenever we are doing a large intramural myomectomy, a relook hysteroscopy is must after that. So 2 months, 8 weeks, so you ही चले गए आपके, even just 2 months, 3 months have gone. And let the patient uterus be healed. Do a pickup by that time. Keep the embryo frozen. Let the cavity heal, and after 6 months, definitely you can go ahead.
Normally, if after polypectomy, the endometrial takes couple of, see, if it is an endometrial scratch, it takes 10 days for endometrium to heal. If it is some polypectomy, it takes few weeks, 2 to 3, 3 to 4 weeks. And if it is a myomectomy, normally it takes 8 to 10 weeks. So this is, but when the endometrial cavity is open, I think within 3 months, definitely it should get healed. And one should not face any problem in going ahead after 3 months.
One thing what I do after a large myomectomy, there is a lot of myohyperplasia that is there along with the fibroid that is there. So what I give is, after doing the surgery, the same day I give 1 dose of Lupron. So that reduces the myohyperplasia, that reduces the vascularity, and the healing is much better. And then I wait for 2 to 3 months and ask the patient to conceive naturally if everything is open. Otherwise, go for IVF after 3 months.
And another very important, and another very,
another very important thing, please cultivate a habit of doing second look hysteroscopy always. When you operate on hysteroscopy, any hysteroscopic surgery, may it be a polypectomy, may it be adhesiolysis, may it be a septum resection, may it be lateral metaplasty, may it be a myomectomy. If beforehand, if you have counseled about the second look hysteroscopy, patient will get ready. You may do a discount rate, concessional charges. Don't charge, only charge for medicine. But second look hysteroscopy is very important because there are very, very high chances, 20 to 40% chances of forming adhesion, whatever you do, whether you put IUCD, whether you put balloon catheter. But and if you do second look hysteroscopy within 2 to 3 months, those adhesions are quite flimsy. Even just by pushing the scope or something, it will break, and then it is not going to reform that fast. So my strong recommendation is to go for second look hysteroscopy. Dr. Renu, do you agree?
Absolutely, sir. It's mandatory in all patients whenever you do any operative hysteroscopy and laparoscopy for example.
Second is regarding tubal block at the ampullary site. So should we go for surgery or direct for IVF?
IVF with the ampullary, and how you are going to, what you are going to do with that. First we have to understand
What is the reason for
Distal
ampullary
tubal
block?
problem? IVF.
Only the fibroplasty it works wonder, or the distal one, proximal ends.
Regarding fibroid, I have 2 cases. Very small fibroid, 1 to 2 centimeter, but the site is at the endomyo junction, that too in the posterior endomyo junction, 1 centimeter from fundus. In hysteroscopy, the cavity is normal, sir. No protrusion of fibroid into the cavity. On laparoscopy, the fibroid is sitting deep inside the myometrium at the endomyoid junction. It's very difficult to identify the fibroid. Patient also having failure in IVF. What to do for that?
So type 3.
Any medical management regarding that, or any surgical technique we have to alter and to do?
So these fibroids are difficult to access, and if the fibroids are not accessible internally or externally, there is no point in digging in the uterus because you are doing more harm. So what you are worried about is the change in the integrin levels and the molecule which are important for the implantation which are altered, and because there is no tremendous change in the vascularity of the uterus. So you are worried about the just implantation potential because of the presence of the fibroid. So please down-regulate well this patient and then do the HRT life cycle.
Thank you.
Ma'am, as you just now we discussed that whenever we do a hysteroscopy, we have to do a relook. Actually, I did a polypectomy on day 2.
Sorry, all the delegates who are coming forward for the question, one line introduction. Who are you? So just so that we become a customer.
I am Dr. Neelu Kaura from Moga, Punjab. So, ma'am, I knew that there is a polyp, and we did a on day 2, a polypectomy, and we used an energy source just at the base and a crisp cut of the polyp. And then on the next menstrual cycle, I have started preparing her for embryo transfer. So should I cancel that HRT cycle and do a relook and then plan because
see, if you find a nice triple layered endometrium, it's fine. That's okay.
That's okay.
For a single endometrial polyp, that's perfectly okay. That's fine. But for submucous myomectomies and other large myomectomies, but ideally it is good if you do a nice relook hysteroscopy just after the second cycle.
Even if that energy source was used, although it was very focal and
it hardly matters. Kuch nahi karega wo. It hardly matters.
And there was another patient. We did a laparoscopy for TO masses and ovarian cysts of cystic structures in the ovary of around 6 centimeters. But when we went inside, there were signs of tuberculosis. There were those caseous tubercles all over the uterus, adnexa, and even the peritoneal cavity. The tubes were stuck, ovaries were not visualized. So I did adenolysis, and then I could see the ovaries, which were cystic, and there was clear fluid in the cyst, which I aspirated. So will this total damage of the tuber-ovarian relation and everything which has happened, will anti-tuberculosis treatment heal everything and patient can conceive, give a trial of natural conception, or what should we do?
Dr. Neelu, there is no role of empirical AKT.
Not empirical, it is proven tuberculosis.
उसका लेकिन active है कि passive है? Is it a healed tuberculosis or active tuberculosis? If it's an active tuberculosis, see, you put a laparoscope inside and you're seeing that active tuberculosis there, you are not supposed to do anything. Just take a biopsy, come out. Because whatever you are doing, you are just spreading the tuberculosis further. The guidelines are very clear. You put a scope, you seal, take a biopsy, send it for TB-PCR, send it for gene expert, end of the story.
But like in this patient, sir, there was cystic.
Don't do anything, because with your AKT, after 9 months of AKT, everything is going to go. With more of laparoscopic intervention, you're just spreading it further. You might want to do something, aggressive about it, but you might just inadvertently cause more harm. So just stop it, call the husband, show him everything, document it well, take a video, take photographs, give it to the patient, because she's the patient who's going to go from one doctor to another. So there is a proper documentation. Secondly, give a proper AKT for 9 months to 12 months as recommended, and after you finish the course of AKT, do a relook histolaparoscopy before planning for anything. Usually in such cases, you will be finding that the fimbria are going to be occluded completely, it's going to be bald, there might be hydrosalpinx, you might want to just do a salpingectomy and go in with an IVF. Thirdly, if you put a laparoscope inside and you see there is PID, one thing which I have told to the groups time and again, something that works wonders is injection placentrex. The dose is 21 days. I am daily for 21 days. You got two brands, Placentrex from Albert David, Flaconta from Corona. Both is the same manufacturer. But trust me, when you have this proximal tubal obstructions, unilateral proximal tubal obstruction, mild PID, cervicitis, just that, and so many patients just conceive on their own after a course of Placentrex.
So I little bit I differ. I am believer of empirical AKT, because in many cases, just by based on the suspicion, whenever I started AKT, spontaneous conception rates are very high. Do you agree? How many of you agree that? Yeah. So it's a similar experience of a lot of people. Definitely, I believe, even the guidelines doesn't say, I believe that if you have strong suspicion, you should give empirical AKT.
And Dr. Preeti from
Yeah, that's an important question. So, how do you suspect tuberculosis? So, when you're doing transvaginal scan, you typically find increased vascularity. These are the features where you can suspect tuberculosis, and it is mainly a subserosal increased vascularity. There is always persistent free fluid in the pouch of Douglas. 2. 3. The endometrial proliferation may not be optimum. That's another 2. And when you are doing hysteroscopy, the cavity has got typical look, the pale cavity, maybe some patchy inflammatory, some granulomatous type of tissue, if it is a long-standing tuberculosis, there is a contraction of the cavity. The cavity becomes narrow. You feel that it is a T uterus, or you feel that what has gone wrong. So in such patient, you can suspect a tuberculosis.
So I have a patient 45 years of age in whom ovum pickup
Sorry,
is done.
what is age?
45 years.
45.
Ovum pickup is done and she has adenomyosis uterus. And before planning for embryo transfer, which method of down regulation will be better? Is it with agonist or with ossicles?
She is donor eggs. She is going for donor eggs.
She wanted to conceive with her own eggs.
Donor eggs.
So
She
we
is
have
regularly
done
menstruating. Regular menstruating.
Yes, she is regularly menstruating.
According to the regulation, you can go. Why? What is the doubt in your mind? Why there is a dilemma? So what is the dilemma? Agonist and ossipils, these are the only two methods. If you go with the agonist plus letrozole, it's always better. Combination of agonist and letrozole.
Okay, if she is not regularly menstruating, then we have to use the ossipils.
Yeah, then ossipils is fine.
Okay. Sir, after the third dose of agonist, like when should we start the endometrial preparation?
You can start endometrial preparation. If endometrial is non-functional thin, after 2 months of down regulation, you can start endometrial preparation anytime. You don't have to wait for getting withdrawal bleeding, give estrogen, because if you give progesterone, she is not likely to bleed. Because to have a progesterone withdrawal bleeding, the estrogenized endometrium is needed, which is not there. So with the simple progesterone, you are she is less likely to bleed. And if you give estrogen plus progesterone, again you are reducing on one side you are reducing the aromatase expression and the estrogen related effect, and again you are giving the estrogen. Of course, for endometrial preparation we have to give estrogen. So by discussing this, again another point which came into my mind, while preparing the endometrium for when there is a case of adenomyosis or endometriosis, you have to always consider two things. They have excessive aromatase expression. So always start with the lower dose of estradiol. Please do not bombard. Start with the lower dose because they have got excessive aromatase expression. And second, this patient requires higher progesterone, which we are going to discuss in my talk. So this just is a side talk. So you can go ahead with the...
So immediately, if I am giving the third dose today, can I start tomorrow itself?
Surely. Why not?
Yes, sir. Thank you, sir.
Even with letrozole, we need not wait for withdrawal bleeding.
Yeah, you don't. Because letrozole you have given for reduction of the aromatase expression at the local level. It has not affected pituitary because pituitary is already down-regulated.
Sir, I have seen few video of laparoscopic pro-surgeon. They going to coagulate, not clip, uterine artery from base in myomectomy. is there any role in implication of this point in fertility point of view? In further, we should ideally coagulate uterine from base or clip, which is better?
Sorry, can you repeat? While doing myomectomy,
few surgeons going to coagulate uterine artery before myomectomy, not
okay, at origin. Yeah.
Is there any implication of this coagulation in further fertility point of view?
See,
hamper fertility, hamper the implantation?
If uterine is ligated at origin before myomectomy, I don't think it affects a lot of collaterals, and the supply will come from ovarian vessels also. But if it is a really internal is ligated or something like that, anti-division, then there is it's a concern. But after ligation of the uterine at origin, I don't think any problem. Anybody can throw some lights?
Why do you have to ligate the uterine?
Please use the mic. Please take care.
Yeah, why you have to do anything? See, nowadays we have got a shoelace technique and we have got temporary clips as well. If you really want to do that, believe me, in only my 10% of my myomectomy cases, I'd go ahead with these cases. Because anyhow, if myoma are so many and they are so big, then accessing that uterine artery is again a difficult thing. Pelvis utna hi hai and you have got a big myoma, it's very hard to get uterine artery ligation. But even if you want to do it, just please, temporary ligation, cauterization, it is not at all recommended. Why unnecessarily the one vessel which is very pertinent to the uterus, why we should do that? We can do all our myomectomies with just simple vasopressin injection, and if you have to do it, just do a shoelace technique, temporary ligation or clip, and just remove it after the surgery is done.
A very recent study I came across. They use some Foley's catheter and tighten around the cervix, and which gave, I have never tried, but it's a recent study, I believe.
That can be done only for the fundal myoma or the subserosal upper myoma.
Give the mic.
There are studies also which shows many we do uterine artery embolization for the AV malformations. They also shows that the fertility is reduced in those patients. So in that way we also should think of this uterine.
Very valid point. Yes, yes.
In a case for the tubal clipping, we wanted to do laparoscopically, but because of the previous adhesions and previous surgery for intestinal obstruction, it was not possible. So hysteroscopically, we blocked the both ostia. That's the right thing we have done.
I mean, you can do that. There are papers which have done hysteroscopic coagulation at the cornua and block that. But what usually happens is that the fluid is going to keep on accumulating and
causing a problem. That is one thing. Secondly, is if it has been done excessively, you might probably injure the endometrium by doing the cauterization.
Not it was done nicely.
So then I don't think so should be a problem.
So for FET, should I wait for 1 month or 2 months? 1 month only. Thank you.
Please make a queue. And please try to be very brief rather than case discussion. Whatever relevant point if you want to ask that point only. That will save a lot of time.
I'm Dr. Selvi from Salem. I've got a patient who's
Please speak loudly.
I've got a patient who's 37 years old, adenomyosis. But in her case, we are not able to see even the endometrium at all. Probably I could see very difficulty 1 or 2 millimeters. I think probably I'm assuming that's endometrium. In that case, what are we going to do for embryo transfer?
So it's basically thin endometrium. We were going to discuss
The
separately.
uterus is around 14, that's the size of the uterus.
Endometrial problem, how to deal thin endometrium with adenomyosis, we are going to discuss.
So I've got one more thing. Madam was saying about relook hysteroscopy after this. I've got a patient who's having we did 2 times polypectomy. Then when we're preparing for FET, again it's coming. So we just did the relook 1 time and then transferred after probably 7 days. Is it okay? Can we do the transfer in that cycle itself? Will that water, I don't know about that, but we went ahead because we didn't want to go for the 3rd time.
So there was one
I'm not sure about transfer after doing hysteroscopy, transferring in the same cycle. people do endometrial scratch in the same cycle and transfer. As I said, any form of mild endometrial injury takes 10 days to heal. So if you done hysteroscopy very carefully, not digging too much, and after 10 to 12 days, I think logically you should be able to transfer. I have never. What is the take on?
Sir, while I was preparing the slide, I have gone through one study. They say the see and treat approach, whenever this thing is coming up, if the duration between the, as the sir rightly pointed out logically, if you are doing endometrial polypectomy and there is a difference of 10 days between polypectomy and transfer, there is a huge success rate been reported. This is one of the study. Because of lack of time, I could not know.
So take home message, yes, 10 to 12 days, mild endometrial injury, you can go ahead.
Dr. Chandrasekhar Kharge, in history taking, HB electrophoresis and rubella vaccination.
Ideally, it should be yes. Rubella, normally then there is a recurrent miscarriage, then we are more worried. Personally, I don't go for rubella IgG in all patients. That's what I do, I'm telling you. But if you ask, yes, it is better to do. And regarding HB electrophoresis, surely, it's a part of the investigation panel when you are doing IVF, not for a routine infertility.
Vaccination about?
Rubella
vaccination. Rubella vaccination.
If the IgG is negative, then she should be vaccinated. If it is positive, there is no need.
And on TBS, if we see a lot of hyperechoic spots, bright spots.
Where?
In uterus, intrauterine. While doing TBS, when we see hyperechoic spots
in the
endometrium.
In the endometrium,
yeah.
Okay.
This suggestive of chronic endometritis. Or
yeah, it's a suggestive of maybe calcified return product of conception, maybe adhesions, or maybe healed endometritis.
Okay, sir. Thank you.
Parin, mic ऊपर करना जरा, please. सबको bend होना पड़ता है. Mic को ऊपर करो थोड़ा सा. Mic को ऊपर करो.
Sir, good morning. I'm Dr. Saini from Mumbai. I just wanted to know as to how to deal with a patient who is posted for frozen embryo transfer. She is a case of recurrent implantation failure, and she.
Please ask relevant question to this topic.
Yes, sir. She has.
This related to.
It is related to the polyp thing.
Fine.
Yes. So she has undergone a previous 2 times hysteroscopic polypectomy, and every third after this she has failed to implant after 2-3 cycles of embryo transfer. But after I start preparing, like if I do the hysteroscopy now, remove the polyp, again after 2 months she is developing another polyp. So now the patient is very reluctant for undergoing a third hysteroscopic polypectomy. So as first I wanted to know what is the reason for this repeated development of polyps, and second how to deal with this particular patient.
Excuse me, we are actually running very late. 10:30, in 2 minutes we'll have to start the next PPT. Because otherwise the whole schedule will delay.
What do you say? We should, for discussion, all the queries should be solved, or we can go according to the schedule later on?
So
fine. Little bit extension of the time is okay. But if it is extending too much, then later on, after the finishing the session, let this finish. Okay. So, I'm not very sure. According to me, if there is a recurrent polyp formation, it's an aberrant reaction of the endometrial receptor to the estrogen. What to do? I don't know. Anybody can take on this?
Maybe he has answered.
Yeah, please.
She only answered when the feeding vessel is not cut properly, maybe there is chances of recurrence.
No, madam, the feeding vessel and the polypectomy has been done very appropriately because it has been done by me myself. So I'm sure about it.
The pathology is hyperestrogenemia, which leads to increased endometrial polyp. So we have to decrease the estrogen, put the patients on OCPs for 3 to 5 months. That is 3 months probably.
That's a good idea to suppress the endometrium.
Yeah, you have to suppress the endometrium and estrogen level. From somewhere that estrogen is coming in, which is leading to hyperestrogenemia and polyp.
Actually, for this patient, I thought that because of putting this patient on HRT, wherein we are giving a little higher doses of oral estrogens, I tried doing a modified natural cycle for this particular patient. So maybe a little lesser dose of estrogen, but again she is developing polyps.
try doing just a letrozole cycle, no HRT at all?
Yes, sir, that is what modified natural cycle.
So in modified natural cycle, there is no estrogen.
Sir, letrozole will itself do the follicular development and intrinsic estrogen production.
Yeah, but then the letrozole is going to suppress the estrogen as well. So in such cases where we know that the polyp is an estrogen based mass that is coming up and again and again. So 1 month of OCs down regulate completely.
Okay.
See her on day 2, day 3. There is no polyp.
Yes.
Start her with just plain letrozole. Nothing else. Do a proper modified natural cycle with letrozole, no estrogen at all, and see probably the polyp might not recur.
Okay, thank you.
Because following letrozole, the estrogen level is never crosses 200. It's somewhere around 150.
Yes, that is what I tried, just a letrozole cycle.
Or we can do just a natural cycle transfer. Follow on day 2, follow her.
Yes.
Good idea.
Because this recurrent polyp I have observed when irrational use of tamoxifen, which is very common, very common. Tamoxifen is suggested for 5 days only. There are a lot of people, those who have started getting good result, endometrial thickness with the tamoxifen, they have courage to extend for 10 days. Then this problem starts.
Sir, good morning. I am Dr. Vijay from Telangana. If you put Marina for prolonged period, does it cause any endometritis? Because we have to prepare the patient for FET afterwards.
Nothing happens.
No.
Nothing.
Just a couple of points I wanted to share regarding history taking. One, you might find when you are an IVF practitioner, a couple might come to you with a huge bunch of files on Monday in a very busy OPD. And you might not go through all the things. So what I usually do is tell the patient to keep the file and come back on a Wednesday or Thursday when the OPD is light and ask somebody to go through the file. So probably you might not overlook. A lot of times the patient does not know treatment kiya hai, but what is the treatment they don't know. Whether it's IUI, whether it's IVF, IUI, khud ka sperms, donor sperms, IVF, self eggs, donor eggs, nothing is documented by a lot of our colleagues. So just you might get some hint somewhere which might aid in the further planning of the treatment of this patient. So there is a few points about history which I thought are relevant. Secondly, something which a lot of gynecologists have completely stopped is doing a good speculum examination the first time the woman comes. So make it a habit that before putting a sonography probe, you will put a good speculum and see. You might find erosions, polyps. You might want to treat that. If you have a patient whose tubes are open, everything is fine, but she's having a bad erosion, just treat the erosion, give a course of Fastriq to the couple, give a course of Placentex in case you want, it's a young couple, and just ask them to be together for 3 to 6 months and they might just conceive on their own because you've taken care of the cervical erosion and the cervicitis. So just a few points I thought that crossed my mind. I think we'll take the next session. Asim, who's the next speaker? Dr. Shekhar Amle from Nagpur, from Nashik, sorry.
I think your area of interest is endoscopic primarily.
Yes, sir. I asked you for endoscopy lecture also. Certainly, you should. Okay, anyways, good morning all of you. My topic has been designated as laboratory investigations. I was wondering whether it is relevant or not because lab investigations, all these lab people are also putting that strips in front of you and just taking that this is investigation, infertility investigation panel, this. But it is very relevant. Somebody asked right now whether electrophoresis should be done or rubella it should be done or not. So whenever the patient comes to you, your first impression is your last impression, and when you are suggesting investigations, you cannot go after IVF failure again and tell that patient that this test has not been done. So whatever investigations you are doing and whatever confidence you want to earn in patient mind is when you are asking patient for investigations. Next slide. One more thing, as Dr. Sachin said, a patient is having huge bunch of file, never repeat investigations. Whatever is not done, those investigations you should ask for the patient, your couple to investigate. There is a huge list of investigations, right from hemoglobin to the ERA test. The cost is also huge for ERA test. So what investigations you should ask patients preliminarily? Categorically, I divided them in preliminary investigations, then IVF specific investigations, then some investigations which are done in a specific conditions. The conditions, specific conditions, investigation which are done in specific conditions, those will be discussing later. ERA test and that is a totally different thing. Preliminary, we go for hemogram, PT, PC, then bleeding time, clotting time, then urine routine examination, then blood group. Blood group, so many times we see it is missing when the patient is for some investigations or for some surgery. That time you come to know that blood group has not been done. Then HIV, serological markers, then VDRL, then BSL, vitamin D3 levels and vitamin B2 levels. These are the preliminary investigations. The red one, which are the investigations, I think you should do them first, means they should be given preference. Vitamin D3 levels and vitamin B12 levels, nowadays there is a boom, everybody is doing vitamin B12 levels, vitamin D3 levels. But the cost of the investigations and the treatment, it is one on the same thing. Vitamin D3 levels, B12 levels, you never start patients on the first day for IVF. There is always time, 2-3 months at least. So in that period, you can give patient vitamin B12 or vitamin D3 for 2-3 months. So there is no need doing these investigations primarily. Then comes IVF specific investigations, that is AMH. I have given 3-star for that. Then FSH level, LH, T4, T2, T3, T4, TSH, dihydroepiandrone sulfate levels, testosterone levels, then husband semen analysis, TVS, serum prolactin, HSG, and inhibin B. We'll come one by one with this. Okay. So if I have asked what investigations you will ask at a first visit, then I will prefer doing hemogram, then serological markers, AMH, husband semen analysis, and a good transvaginal sonography, serum prolactin levels. HSG, it is not a laboratory investigation, but it is pertaining to this topic. It is very important to do HSG. And the third column, I will prefer doing only when there is a recurrent implantation failure. So anti-Mullerian hormone, it is very important. Why it is important? Because the level, they never change. Means if you do investigations at any time of the menstrual cycle, the levels are same. It is static and the biological, it gives a good idea about ovarian reserve. So the values are, and how much response you are going to get, that is I have put on the tables. That is 0.5 to 1 nanogram per ml. One should remember the values, whether it is a nanogram or picomole, because the values change. It is almost triple time when you go pico. When it is lab instructions are given in a picogram. If values are 0.5 nanogram per ml, you predict that response will be poor. And on transvaginal sonography, you will get 2-3 follicles after stimulation. That is a poor responders will be having 0.5. Then 0.5 to 1 nanogram, it hardly matters whether it is 0.5 or 0.4. You should remember it is something low. For remembering this, I have taken as 0.5, 1 to 3.5 and more than 3.5. According to the consultants, they may take it as a 1.1, 3.8 or 4 also. So AMH is very important, and that you should do primarily in all IVF patients before starting any treatment. Then nowadays there is a it is for basic gynecologists. They do day 3 FSH, LH, E2, P4. It is not investigations to be done routinely. It is done for to confirm down regulation. So if you do day 2, day 3, it is not going to give any information because FSH, LH ratio is changed. It is PCOS. That time, if you are doing a TVS, that is also good enough. So not necessarily you should do routinely day 3 FSH and LH levels. Only thing is, if P4 level is less, then that means you will have to add LH activity for that patient. That one should remember. Then serum prolactin definitely causes menstrual irregularities and hamper ovulation. Serum prolactin, usually the patient will not complain about her breast engorgement or she is having galactorrhea. Then T3, T4, TSH. Is it necessary or not? According to me, thyroid hormones act on each and every cell of body and it affects all stages of reproduction, so it is recommended. It will not cause infertility, but if patient becomes pregnant, then her pregnancy, for taking care throughout pregnancy, we should know her thyroid status. So it is important to evaluate T3, T4, TSH.
2 minutes left.
Okay. Then testosterone levels, then HSG, hypoxia and SSG. These are recommended to diagnose septum, polyp, fibroids, isthmusal, Asherman's, adenomyosis and T-shaped uterus. Nicely, a lecture before me, the speaker has spoken about indications for hysteroscopy, laparoscopy. Again, I have to give stress. Then abnormal HSG or ultrasound. Then young woman with history of symptoms.
We are going to cover separately the tubal evaluation.
Okay, so I'll just enumerate investigation wise whether it is needed or not. A prolactin should be offered only when who have an ovulatory disorder, galactorrhea or pituitary tumor. The value of assessing ovarian reserve using inhibin B is uncertain and is therefore not recommended. Women with possible fertility problems are no more likely than the general population to have thyroid disease, and the routine measurement of thyroid function should not be offered. Means the infertility is women who are not known to have comorbidity should be offered HSG to screen for tubal occlusion, because this is a reliable test for ruling out tubal occlusion and it is less invasive and makes more efficient use of resources than laparoscopy. So HSG should be preferred to laparoscopy. It is not cost effective to do diagnostic laparoscopy as per initial infertility evaluation when history and physical examination of TVS, HSG and mid-luteal progesteron are normal. That time this laparoscopy should not be done. Thank you very much.
Thank you. So basically everybody would like to know whether you should advise prolactin for everybody or not. That's the question. And what are the bare minimum units? Meanwhile, second you can announce next speaker to come. So what are the bare minimum basic investigations? TSH must for all. Prolactin in the presence of irregularity cycle and galactorrhea, otherwise not.
Dr. Vijay Pawar. Dr. Vijay Pawar.
AMH, obviously when interfollicle count is less, patient is elderly, then we definitely advise. But now I have started advising them in PCOS also, because I want to understand, okay, yes, come. So we'll discuss later on.
Dr. Vijay Pawar, gynecologist and IVF specialist from Singapore.
Very good morning to the August gathering here. I would like to present my topic on endometriosis. So as sir has advised, we'll directly go to the important aspect. I'll finish it within 5 to 6 minutes, my presentation, so that we can have more time for the discussion of the topic. So we all know about the different theories of endometriosis. We know about retrograde menstruation, hematogenous spread, the stem cell theory, the coelomic metaplasia, and the genetic and epigenetic theory. So, why this slide is important is because we know endometriosis is a game of theories. So nobody knows exactly how the endometriosis comes. There are a lot of theories that come. So different places where you can get endometriosis, we'll have a different theory to explain that particular disease in that particular area. So endometriosis, we all know, can be present in all the different sites in the body. So this is a very important slide when we are going for the investigations in the case of endometriosis. So coming to the infertility part of the infertility part, we all know that endometriosis will cause infertility, and how it will cause, it will affect different parts. If you see the fertilization aspect, it will be linked to the oocyte link reduced fertilization rate, poor sperm binding, reduced sperm motility because of the increased ROS. So that also damages the sperms. So that is a problem. Then it will also affect the implantation of the embryo because of the poor embryo quality and early embryo arrest. In the implantation, because of the receptivity affection, the implantation will also be affected. In the ovary, there will be impaired folliculogenesis, fewer follicles. A lot of patients, when they come to the IVF center, they are already been operated 2-3 times. We will have a low IMH, diminished ovarian reserve. So all those problems are there. And of course, ovulation will be affected. Luteinization, unruptured follicle is very common with endometriosis. And because of the inflammation, recurrent miscarriages and preterm losses is also known. And because of anovulation, there is chance of altered pituitary ovarian axis and altered LHS. So this slide is very important again because it is, endometriosis is going to affect all the different aspects whenever the pregnancy is supposed to happen. So now coming to the diagnosis. So in the history taking, it is very important that we take proper history. We should think about the gynecologist symptoms. All the gynecologists are very well versed about the symptoms of dysmenorrhea, non-cyclical pelvic pain, deep dysmenorrhea, infertility, fatigue. But always look for the other symptoms. So look for cyclical symptoms like dysphagia, dysuria, hematuria, rectal bleeding, shoulder pain. So especially in cases of deep infiltrating endometriosis, these symptoms, many of us sometimes, patient gives you vague symptoms. Whenever there are vague symptoms, always suspect endometriosis. Whenever there are no symptoms, then also you should suspect endometriosis. So you will have to investigate it in different ways according to the symptoms. So coming to the clinical examinations, if the patient is, since the topic is about endometriosis, if the patient is adolescent or not having a sexual intercourse, then of course per rectal examination will be important. And otherwise, we all are very good in ultrasound examination of the endometriosis. I think the next speaker will talk about that regarding the ultrasound part, so I'll skip that. Ovarian endometrioma also, we should be very suspicious whenever you are doing transvaginal sonography. We know the different features of ovarian endometrioma and always be that whenever there is a cyst or in the ovaries, adnexa, always suspect of endometrioma, which you can confirm by laparoscopy. Now coming to the scoring system, this is the American fertility scoring system. There is an Enzian system for deep infiltrating endometriosis. So many scoring systems, so many things. So I'll make it very simple. You always remember that there is divided into 4 parts: mild, moderate, minimal, mild, moderate and severe. So according to the score, any score more than 40, this is the way your laparoscopy report should go whenever you are doing a laparoscopy. But many a times you find that the reports are incomplete. We don't use the scoring system. So this is what is recommended by the American Fertility Society. And coming to the diagnosis of management of the endometriosis, so there is a medical line of management and the surgical line of management. So first thing that we have to see is what the patient has come for. If the patient's main complaint is pain, then the treatment will be more related to surgery, which will be laparoscopic part. If the patient's main complaint is infertility, the patient wants a child, then you will have to go for the ART type of treatment. The medical management will have a conservative role because as far as infertility is concerned, because all the treatment drugs available like your GnRH agonist, methotrexate, DMPA, progesterone, danazole or you are using the Dynogest, all these drugs are going to cause amenorrhea, and those are not going to help us in getting the patient pregnant. So the main treatment in endometriosis is to get the patient pregnant. So once the patient gets pregnant, the endometriosis is going to reduce physiologically. So what we have to see is that the patient gets pregnant early. So we have a concept of time to pregnancy in ART. So that means when the patient has come to us and when the patient has become pregnant. So that time to pregnancy should be, when we are treating the patient, it should be around 6 months. 6 months to 9 months. So it should not go more than that. So it is very important that when the patient comes to us, we go in a proper way as far as fertility is concerned. So in the stage 1 and stage 2, if you find the diagnosis in stage 1 and stage 2, always go for a timed intercourse or IUI, that will be the option. If it is stage 3 and stage 4, and if there is pain, then there is a role of laparoscopy. If there is no pain, and then you can directly go for the ART. So where we will go for ART directly, where all the patients of stage 2, 3, long-standing infertility, the male factor infertility. So we'll have to take an individualized approach in each case, and according to that you will have to manage. So the different protocols we will be discussing in next talks about the which protocols we are using. So here generally what we use is either a long protocol or antagonist protocol. All the protocols are equally effective. Depending upon every 2-3 years you will get a different article going for either long protocol or antagonist protocol. Those who are practicing in the periphery and doing batch IVF, most of them, 90% of them will go for the antagonist protocol, which is very safe. And as sir has already suggested that we do the pickup, do the embryo freezing, go for down regulation with 3 agonist depots, and after that you put the patient on a FET protocol. The FET protocol generally, when if you are doing in a batch IVF, it will be a HRT with down regulation agonist, and that's it about the endometriosis part in the IVF. And for the timed intercourse and IUI, it will be same, immediately after the laparoscopic surgery, you go for it. And if you, during the surgery you find that tubes are blocked, obviously the patient will directly go for the IVF. I thank you for your patient hearing.
Thank you, sir. Next speaker. So, in endometriosis diagnosis, very typically, if you have observed minutely, when do you suspect endometriosis? When you are doing transvaginal scan, all cases of endometriosis, I would say 98% of the cases, if you observe carefully, there will be some amount of free fluid in the pouch of Douglas. So whenever there is a persistent free fluid in the pouch of Douglas, 2 possibilities should come to in your mind. One is endometriosis, and second is tuberculosis. That's one thing. Second thing, the displaced ovarian position is very important. You have to notice that the ovaries are not in position and it is displaced posterior to the uterus or something, then that should click that probably you are dealing with endometriosis. And third is a sliding test. We are doing transvaginal sonography, and if you are not able to slide, probably you are dealing with the deep endometriosis. That was the third thing. Thank you.
Good morning to all. Today I present with recurrent implantation failure. Time is very short, so I finish as early as, and topic is large. First, the definition. What is recurrent implantation failure? 3 things it is covered. To achieve a clinical pregnancy after transfer of at least 4 good quality embryos in a minimum of 3 transfer, either fresh or frozen, in the age under the age of 40. That is a clinical definition. Why we have to discuss this RIF? Because nowadays so many patients coming with RIF. So first we look what is the reason. Patients have first question, why sir I have failed? Why failed? So first we find out what is the reason. And once your reason is clear cut, then you find what is the treatment solution. So we discuss the reason in 3 ways. First, in IVF, either mostly 3 reasons. Either one is the maternal factor, means mostly the uterine factor, and second one is the embryo. Embryo is faulty or uterus is faulty, and third is multifactorial origin. So discuss one by one. For maternal factor, already we have discussed in previous speaker. Anatomical problems in uterus, either polyp, fibroid, adhesion, adenomyosis, septum, Mullerian anomalies, and also with impaired function of the endometrium, means thin endometrium, endometritis, and thrombophilia, acquired congenital Epler syndrome. Immunological factors, means embryo is foreign to mother also, because embryo contains 50% maternal side, 50% paternal. If maternal immune system is not compatible with that, then it will reject. So it is also covered in immunological factor. Now these are maternal factor. Now what are the problems with embryo? Is there any problem with embryo? So we discuss one by one. Is there any problem with this? Then there will be the poor embryo. First, paternal chromosomal anomaly. Any of the mother and father have genetic problem is there. Poor quality oocyte. When there is a quality poor, then you have to compromise. Poor quality sperm, zona hardening, suboptimal culture in lab, and suboptimal embryo quality, and suboptimal ET. These are the reasons to decrease your outcome on embryo side. Multifactorial means your stimulation. If there is a defect in your ovarian stimulation, then it will create all the cascade to harmful. Another endometriosis and hydrosalpinx. And how we can find out? Already all reports are discussed, but for me, for my clinical practice, once I start for IVF, any patient, these 5 things is must: age, AMH, AFC, and BMI. This is a must. Just even first stimulation, I will check it, and then accordingly I will decide my dose. Because you start your IVF journey from this only, right? So you start with, you take time on day 2 or day 3, check out everything, then you will decide your dose. Otherwise, you have something you take, you go wrong and do the adverse outcome. And another is another accessory hormone, E2LH is also important on day 2. TSH, prolactin, all mentioned. And for the previous failure, ultrasound is must, and you are expert in ultrasound, 2D, 3D, and Doppler. Because so many things are diagnosed on sonography. Then anything abnormal on sonography, then you go for a hysteroscopy, laparoscopy, HSC. When your USG is good, then it will be easy for you. Karyotype if needed, and if recurrent implantation failure, sperm DNA fragmentation is also good. And for recurrent ERA test for receptivity, Epler test, and immunological. Now we discuss everything regarding the treatment option. Embryology, start with your lifestyle modification, stop smoking, alcohol, BMI correction, and stress management. And first, I already described, improve your stimulation protocol. So day 2, you everything check clinically, right? Age, BMI, and everything. Also, you do your modification. If you have a history of previous failure, then what is wrong with you have to document everything. Previous protocol, why you have something wrong. What? You dose, your increase, your starting dose is difficult, you have not added LH, HMG, if it is poor responder, you have to check. If it is still, then you go for a double stimulation. So it will improve, your stimulation protocol is improved, then your quality of egg is improved, right? So to improve your quality of eggs, okay? Once your stimulation is good, and also if your trigger is not good, then you have phase 2 problem. So go for a dual trigger in normal responder and poor responder. And in PCO and hyper responder, you go for agonist trigger, right? Dual trigger is always beneficial. And now you done your pickup, a good oocyte you have selected. Now you have to look for a sperm quality. You have to watch for a sperm. And for sperm, if morphology is severely altered, then if recurrent implantation failure, you go for a sperm DFI test. If it is abnormal, more than 25%, then you go for a 3 to 6 month antioxidant and directly go for ICSI. Also, I am using sperm technique, IMSI and PIXI. All this max and sperm fluid. I am more comfortable with IMSI and PIXI. IMSI is an intracytoplasmic morphologically normal selected sperm. It zooms sperm picture 6,000 times. That is in ICSI only 600 times, right? So it is more. So big vacuoles, nucleus, your embryologist can identify very well, right? Because eggs are limited. What you want to change? Sperm. Sperm is more in millions. So we have, if you select better sperm, then your embryo quality is good, right? Also PIXI. PIXI means physiological ICSI. It is a hyaluronin binding assay. So morphologically good DNA sperm contains sperm is identified in PIXI. And also, not we have to talk about stimulation, everything. Also, your lab environment, lab culture, your quality control, and who is your embryologist? It is senior. If you have 4 egg and who are doing your ICSI, so senior embryologist is needed because you have only 4 egg, 3 egg, recurrent implantation failure. So now expertise coming. So you have to improve your embryologist work also. Also gynecologist also. If you difficult pick up, then no fresh gynecologist doing this, right? So you senior gynecologist also. And laser hatching. I also mentioned thick zona. Everything fine, embryo fine, endometrium, then also fail because of zona problem, thick zona. There is no implantation, right? So you have to use laser hatching, thinning. It is mechanical, then it will also, I am also using laser assisted hatching in my recurrent IVF failure and it will improve my success. And if everything all fine with morphology and still you fail, then you go for PGTA, PGS and PGD and it will improve lots of in this recurrent implantation failure because these are the improving for your embryo. Everything fine, embryo fine, PGS, laser hatching, and what is your final step? Embryo transfer. If you are doing embryo transfer and if any difficulty and your heart says there is everything fine, but I am not satisfied with my embryo transfer. Why? Because if you have previously documented your previous ET is difficult, then you have to document what is the problem, internal negotiation, any internal blood with inner catheter, what is the problem, very large uterus, adenomyotic uterus, you have to think about why I have failed. If you have properly maintained documentation, then it will, if you see the records and you improve. So if previously difficult, then go for mock ET. Also double transfer, sequential transfer may help. And ERA of course for personalized embryo transfer if previous to failure. So these all factors, these all treatment options improve your embryo parts.
2 minutes.
Yeah. And now the maternal side or uterine factor. These already almost discussed. For if you are improper ovarian stimulation, then you have to personalize ovarian stimulation. Each and every patient have different anatomy, different hormone, everything. So you have to calculate. It is individualized approach for ovarian stimulation. If any associated adenomyosis or endometriosis, first I make for stimulation, make the embryo, freeze it, and then down regulate, and then the transfer. Hydrosulfics must for hydrosulficectomy. Endometritis evidence, you treat it by antibiotics. Fibroid all you surgically remove. Thin endometrium, I think it will be later on lecture, but treat the cause. If needed, increase estrogen dose, add sildenafil, GCSF, PRP, stem cell, natural modified. I have tried and it will help you in thin endometrium. It's good. Immunological therapy, LIT therapy, immunoglobulin and intralipid. This also useful for this immunological factor. So these again the same thing. If there is a thrombophilia, you start with heparin and low molecular, and all other things should be, I think, covered. Everything. Thank you. Thank you.
Thank you.
Now we can have a question and answer session.
Yes, the previous speakers can come. Pankaj, please be here. Dr. Vijay and who was Dr. Sekhar, please.
Hello sir, my question is that if there is everything is okay and there is implantation failure and we are just thinking about immunological factor, how you are diagnosing it and how you are treating it, please mention.
Immunological factors comes last. Once you rule out everything, then
Yes, we have ruled out each and everything. There is no uterine factor, there is no sperm problem, embryos are good, they are blastocysts, morphologically it is looking okay, and even ET is very nice, it is done very well. There was no problem while doing ET, and we are thinking there may be immunological factor. So what tests are available in India and how you are investigating and treating it, please?
One, everything is ruled out, then by doubt of mind, immunological factor you have to work out, right? For that, only limited test is available, right? That is the natural killer cell blood, you can do it. And that is only immunological. And also nowadays, I am not doing this immunological therapy, but I have sent to another clinic for the immunological therapy, because everything I have covered. Right, and still patient not getting the result, and that patient I have do for this LIT therapy at another center, and they have do the husband and wife cross lymphocyte test first. If the test is negative, and also they have done the lymphocyte antibody test. If it is negative, then they do for a lymphocyte immunization therapy. In that, husband's blood is collected, and they do some filtration process and identify some lymphocyte solution, and that will inject to maternal's forearm, and then it will create maternal immune response.
Dr.
So
Anupama is going to, I think, who is going to take LIT? So let that topic.
Right. So LIT therapy will improve in that patient. Also, some evidence says that if there is a high natural killer cell activity, so intralipid may be role. I have also tried in some patient with intralipid on the day of transfer and on the day of result, and it will also useful. It will suppress some NK activity in that patient, and yes, that's all.
And
So keeping theories apart, practically speaking, the role of immunological testing thrombophilia is not established. So you cannot just, it is in the research setting, if you do all these tests, it's fine. Practically speaking, am I right? How many of us are doing this? No, we don't do. Rather than we Indian people, we are more concerned about the cost of the therapy, cost of the investigation, and we are result oriented. So those tests where the efficacy, where the interpretation doesn't guide us proper treatment, then we have to work empirically. But still, if you are asking what are the tests, I would prefer autoantibody tests should be done. Antithyroid, it's good idea to do antithyroid testing because that will give, and it is good idea to do antiphospholipid antibody. So this will give fair idea about the autoantibodies. Natural killer cell and all those things practically we don't do. Rather than, as he suggested, better to treat, incorporate intralipid, some couple of measures which we do in the immunotherapy to be included, which are easy. See, LIT and all those things are not that easy. So instead of that, the things which are more easy to implement, that should be implemented. And at last, recurrent implantation failure. Now there is research, beautiful research paper has come. You should not worry too much about the recurrent implantation failure, because ultimately, if embryo is of good quality, it absorbs a lot of things. And if the endometrium is excellent, that also absorbs the suboptimal embryo. So it has been said, it has been proved that if you transfer a single euploid embryo 3 times, single euploid embryo transfer, only 5% of the patient they are left who do not become pregnant. So ultimately, good quality embryo, euploid embryos are most important than endometrial factor. We are thinking too much about the endometrium. We are thinking too much about the other things. But the most important thing is the dialogue between the endometrium and embryo should be improvised. So this is possible if one is excessive. So suppose husband and wife, one is silent and one is too much talkative, the dialogue is established because one is more talkative. It's exactly like that. Thank you.
All these
So I wanted to add a point here.
I'm sorry about that. Just because you have given me this topic of immunotherapy, I wanted to add here that routinely what we talk about immunological treatment is something in dilemma. And what I read and learned is that there is something known as immunomodulation and there is something known as immunosuppression. So there are two different things. So immunosuppression comes when we give therapies like intralipid, where we are rather suppressing the macrophages, the capacity of the macrophage to kill something that is killed. So intralipid is one therapy which is working on that line. And tacrolimus is one drug which is very routinely used all over India, which is very cheap, and that drug is routinely used for organ transplants. So that is another drug which can be very easily used. So we should not empirically use, as sir has said that, most of the times when the embryo is right and the endometrium is right, the pregnancies would implant. But there are still a chunk of patients, and especially this is true for that recurrent pregnancy loss patients, that 50% of unknown group of recurrent pregnancy loss, they are probably, most of them, some genetic defect which we are not able to identify, or it is some immunological defect which we are not yet identifying. And the work which is being done in recent years is going to clarify it later on, what all immunological factors are there. And actually there are natural killer cells which we are actually looking at the periphery. But it is not the routine peripheral NK cells which are to be identified, it is the uterine NK cells which are to be identified and which is not easily done right there in our country. So there is a test known as TNF-alpha and there is a test known as IL-10. मुझे ये सब कुछ अभी ही पता लगा है पिछले 2 महीनों में सर के द्वारा ये पढ़ने के वो देने सिग्नल्स देने के बाद में, बट मैंने इस पे बहुत रिसर्च करी है पिछले 2 महीनों में, and I realized that these are being done in our country, and I have got it reported in 2 patients of mine in last 2 months. They are not that costly जितना मैंने सोचा था. टोटल पेशेंट का TNF अल्फा का आई थिंक 1500 का कॉस्ट था, उस पर उसका इन्वेस्टिगेशन हुआ, एंड जिन पेशेंट्स में ये पॉजिटिव आया उसमें IVIG.
Please speak in English,
okay.
Because a lot of people there from south and
I understand that there are many of us who do not understand Hindi. So IVIG was one treatment which was in one of my patients. It was just by chance, I am agreeing to that. It is just by chance that she became pregnant. She had 4 losses earlier, and every time her heartbeat used to stop after 6 weeks, and this time heartbeat would not come, and this is the first time that we have reached to 9 weeks with IVIG. I am not at all endorsing it, please don't take it that way, but I am saying that there are a chunk of patients in which we are not knowing the cause, and probably this is one of the reasons where we can find out when nothing else is working and the patient can afford, we can probably get these tests done. And in those group of patients, maybe we can go for lit therapy, or these are all immunomodulating therapies. IVIGs, lit therapy, these are not immunosuppressive. But immunosuppressive therapies, they have their own chunk of side effects, like tacrolimus is in long term. When you give it, then it can cause kidney problems, but we are not giving for long term. So tacrolimus is pretty much safe and not costly at all. And there is second drug which is intralipid, which many of us I'm sure are using. HCQS is one more drug which very commonly many of us are using. And these HCQS I would say is more of antibodies when they are present, as sir has been saying. Those antibodies in that chunk of patient HCQS is okay. So there are, probably tomorrow I will give the whole list of what all immunotherapies are there. But of the lot which I think are not costly and are acceptable should be these intralipid therapies, especially in those patients in which we are not knowing the cause and you are thinking on immunological lines. Thank you.
So first we should try empirical treatment, and then if that cycle fails, there are a lot of, see, if we are cooking a dish, the routine masala we are putting, and if it doesn't become tasty, then you add basam masala or something else, and still it doesn't work, then you start thinking why it is not become tasty. So you start. So it's like that. So first, one implantation failure, I'm going to discuss that in my presentation, where I'm discussing. without much investigation, how to deal with thin endometrium, implantation failure, recurrent implantation failure without thin endometrium, and recurrent implantation failure with thin endometrium.
So hi sir, Dr. Abdul from Apollo, Chennai. I just want to ask about a set of patients like very severe PCO. They form a lot of eggs but few embryos, and the embryos are euploid but still they fail. They have 2-3 transfers. You know, this classical patients, like they form a lot of eggs but very few embryos, euploid embryos but fail, no matter how many transfers you do. So am I missing something here is what I would like to ask.
You see, in case of failure, you have to really go through the whole exercise. You have to repeat, because everything plays a role. Everything plays a role. Your media, culture, transfer technique. See, earlier we used to transfer.
No, but all the other patients, the laboratory side is okay, because all the other patients can't see.
So you mean to say why euploid embryo transfer fails? You mean to ask why euploid?
Especially in this set of patients, severe PCO form a lot of eggs, very high estradiol levels, very few embryos, but they are euploid. Few are euploid, and then you transfer and it fails. 3 transfers, 4 transfers, they fail. Cannot find any reason at all, because I don't believe in ERA, but otherwise all the other investigations are normal, hysteroscopy is done normal. So
only practical solution I would suggest is go for more natural type of or simulated type of cycle rather than HRT cycle. Because
could it be
when
something
you give
inherent in the PCO somehow?
that much research we have never done. See, we work empirically. So suppose this happens with me, I would live HRT cycle. Definitely I would start thinking about the stimulated cycle, heterosis cycle, or modified natural cycle if the cycle was regular. Because you have to understand that lower estrogen level gives a wider window of implantation. And if the estrogen levels are high, the window of implantation becomes narrow. So that becomes more difficult. Second, when the estrogen levels are high, all the markers of the implantation becomes resistant. They are resistant to react. So when there is a implantation failure, you have to make sure that you are not bombarding with too much of estrogen. So that's the reason why the more and more papers are in favor of using modified natural cycle or stimulated cycle for better implantation potential. Because embryo part is because you are transferring euploid embryo. So what is left is transfer technique, laboratory, and endometrial part. If endometrial proliferation is good, everything looking fine, endometrial cavity is good, I mean, it's now difficult. It's a research-oriented question, I would say.
It's something that I think.
Can I just add a couple
Even
of
the
things?
BMI of the patient.
Chronic endometritis, whenever you find something is missing, the first doubt should go to the chronic endometritis, because in recurrent implantation failure, 17% up to 17-18% of the cases are because of the undiagnosed chronic endometritis. So it's good to give a good course of antibiotic, prebiotic, probiotic, improvise the vaginal flora.
Yeah, I do that routine for all patients.
So you have done everything.
No, so just one suggestion. Usually what we also see is a lot of PCO women also have coexisting endometriosis. So if you've not done a laparoscopy for this particular lady, you might want to put a scope and see if there is endometriosis and try to correct them. That is one. Second, for women who are absolutely hyper-responder, AMH 15, 20, 25, you might want to do a drilling MR. That might also help. Thirdly, if this woman has not yet been started on a combination of metformin, minoxidil, or plain metformin,
embryos are formed.
Yeah,
Now
so for this also, sir, it will help the implantation part.
So that is my that is what I meant to ask. Will all this influence the embryo also?
Yes, definitely. It will
Surely.
help you the implantation part. Certainly.
Pankaj, Dr. Pankaj, you would like to add something?
In this case, embryo is everything fine. So we have to look for endometrium. In so many severe PCOD patient, there is a thin endometrium also. It hardly reaches up to 7. Okay, so we have to work on endometrium. Also, I prefer MNC cycle in this patient, right? Stimulate either with letrozole and if needed hormone stimulation and go for a ovulation and then go for a transfer. So that will improve. And also I have tried in severe PCOD, I have do the down regulation and then prepare the endometrium.
Yeah, that is also something I wanted to ask. Down regulate for how many months?
Same like adenomyosis.
3 months.
Down regulation.
Okay.
Yeah.
So
And
that
then
might help.
because we have to work on endometrium more.
One of your question was regarding the number of eggs. The number of eggs in PCO, the stimulation, you are saying that the number of eggs are, the number of embryos formed are less. That
Yeah,
is one question.
we usually collect 30, 40 eggs and then only 3, 4 embryos.
So one thing very important that we have to, like sir has rightly said that you have to go back to the table, check where you are going wrong, right, from your history taking and everything, and are you missing anything. Sir has already said about the endometritis part, laparoscopy. Sometimes these patients do have tuberculosis. So if you put a scope, you will find tuberculosis in there. Another important
Beautiful
what is your
very beautiful endometrium.
what is your stimulation protocol? What gonadotropins have you used? So sometimes if you shift to recombinant FSH, you will get more number of M2s. So that also sometimes helps. We find this usually in our cases also a lot of time because we are doing batch IVF. By batch IVF, we all have to by rule we have to put them on OCPs before. Otherwise, there is no option to do IVF in peripheries. So you have to go for the batch IVF. Sometimes the patient get too much down regulated, and this thing we sometimes happen to see. What I generally do in such cases is I give them a break of 3 or 4 months and put our all drugs for the coenzyme Q10 and everything, antioxidants, and call them back after 2-3 months for the BMI also to reduce their weight. If they are on the obese side, it definitely helps you to reduce the weight by 5 to 10 kg. Very, very important. Your counseling part also plays a very important role. Another important thing I do is do their blood karyotyping. So in the blood karyotyping, you will sometimes find subtle problems. They are actually mentioned as a normal variation of the chromosomal, minor subtle variations are there. That is because now in research they have not yet found.
Do you do karyotyping or have you gone to this whole exome and all that?
I go only till I don't do too many investigations.
Because they come and tempt, if they come and tempt us, you get more information,
I think in IVF you have to, we are thinking too much, and like in RIF also we are thinking of so many blood tests and everything that sir has already said. It is not required to do so much of research and everything. We are clinicians, we have to treat the patient and make them pregnant. So if the patient is not conceiving with their self eggs, you can, the option of donor is also there, so you can go for that also.
Yeah, next question.
I wanted to, you said, no? Is it based on your embryo?
Can we have a discussion later on that? Yeah, you can.
Mike.
Yeah.
Sir, good morning. Sir, in sequential transfer, when we do transfer for the first time, it won't hurt the endometrium for second time. I mean, what is the rationale behind sequential transfer? It won't damage the.
Yeah. Sequential transfer, I personally use. I don't know the window of implantation, right? If I previously failed 2 to 3 cycles in good blastosis, so maybe some mistake. I have not done the ERA test. So what ERA done? Either pre-receptive, receptive or post-receptive. So you do the double transfer, right? I on P5 and P6, and I do the first one embryo transfer, and I make the position where my embryo, right, and mark from the fundus. It is up to 5 mm. And second time transfer, inner catheter goes away from that.
Below that?
Below that, yeah. So I will not any damage or touch this. And in second time, the endometrium, no anything issue, I think. So
And so in sequential transfer, whether it is day 5, day 6, or it can be done like day 3, day 5?
I am using day 4, day 5, day 5, day 6, day 6, day 7. Whatever previous my record showing I am failed, that I will change. If everything is fine,
So her question is, what is the rationale of sequential transfer? One, as you say, to take care of the altered window of receptivity, and second, when you transfer the first embryo, it initiates the cascade of implantation. So that when second embryo is transferred, then the endometrial becomes more receptive or more easy to accept the embryo. That's the second result. And I believe, rather than sequential transfer, I believe in double embryo transfer. Whenever there is when I'm thinking about everything else is fine, still I have got adequate number of embryos, and still the implant is in place. So I would prefer to transfer double embryo. Means I will transfer after 5 days of progesterone, or one blastocyst and one day 3 embryo. So now I have stopped keeping more than 3 embryos in one stroke. I keep only 3 embryos in one stroke. And so that, and day 3 embryos. So whenever I want to do double embryo transfer,
So can you repeat? It is not clear. You do day 3 on day 3 or
on day 5, 1 blastocyst and 1 day 3 embryo.
So on day 3
On day 5, on day 5 only.
Day 5? You
One
do
embryo,
day 3
mixing
transfer
2
on day
embryos, mixing 2 embryos, mixing
On
2
day
embryos. On day 5.
5. Day 3 plus day 5 embryo.
Yeah. So,
that means day 3
so
embryo
if the
and blast.
endometrium is pre-receptive, then it will accept day 3 embryo.
Okay.
And if it is
all the area will get complete.
And normally blastocyst, the window of receptivity does not affect blastocyst too much.
So role of Y chromosome microdeletion, whether it should be done in all the cases of oligo and like
That I think separate when we are
different talk, I think.
Yeah, different talk.
Thank you.
We will discuss at that time.
Good morning, sir.
Dr. Bharti Bansal.
Yeah, I'm Dr. Bharti from Rajasthan. Sir, I wanted to know when should we operate in case of isolated endometrioma in a young patient? What should be the cutoff we should take? Should we operate it or should we go for ovulation induction with time in
Next
dose?
topic is the left, Dr. Renu. Endometriosis is going to take.
And sir, my second question is how should we read APLA report? Because many a times we see only one value is coming positive or it is borderline. What should we interpret by that? And as books say that we should repeat the APLA test 4 weeks apart, there should be 2 values positive. Is it practical to do so, or should we start heparin? And
They have mentioned standard deviation, some mention, I never follow that. 40 GPL, 40, more than 40 GPL should be there. On theoretical aspect, we never look into that. If it is antiphospholipid and antibody is present, or lipase anticoagulant present, we consider it as a immunological factor and we start low molecular weight heparin. We would like to give not this thing, we give Barglow to that patient. And that is what we do.
LS should be more than 1.5.
1.5.
More than 1.
Sir, I have 2 cases. The first patient is a case of 2 ED cycles which I have done, and in both the ED cycles.
ED how it is? It is not allowed.
Sir, that was previously. Yes. So now the patient is not coming to me because she has failed for both the 2 ED cycles. And the first ED cycle, it was a blastocyst. 2 blastocysts I had transferred. They were all good blastocysts. Even the second transfer was with 2 blastocysts. And then I had investigated this particular patient for anti-thyroid antibodies. Now routinely I do give these patients Visolon 5 mg before transfer. So anything else? Yeah, routinely I give. So anything else that needed?
How many days you give Visolon? How?
I give I start before adding progesterone. I start for 2 or 3 days before adding progesterone in the HRT cycle, and then I continue it till beta HCG. So anything else like for this? I mean to say whether these anti-thyroid antibodies were responsible, could have been responsible for this particular patient because the endometrium otherwise was having good vascularity, triple line endometrium above 9 millimeters, and the blastocyst biopsy was not done, however, so I don't know about the euploidy status. So what could I have missed or what I could have changed?
What do you think is the success rate of a IVF cycle?
For an ED cycle, it will not.
Official genuine success rate of a IVF. I'm not talking of the centers where they have 100% success rate. In general, what is the success rate of IVF?
Please let us concentrate on the question.
If the success rate is, if you see the take-home baby rate is not more than 25%, 30%. So it is just by chance that your cycles must have gone, no, they have just by fluke, it has not happened. So I think the multiple times you have to try, because I assume you have investigated everything. You assume whatever sir has already mentioned about the recurrent implantation failure.
No, I have not done this TNF alpha, all those things I have not
It has failed by chance.
By chance.
Okay, what is your opinion, Dr. Pankaj?
Antibodies is positive and do your pre-T3, pre-T4 and TSH. If anything alter, then you start L-toxin.
She is already on L-toxin, sir.
If TSH is less than 3, then no need of any treatment. If only thyroid antibody is present.
You have already given a low molecular heparin, steroids,
Yes.
all masala, the dydrogesterone, everything is
Yes,
good.
I had,
Only thing remaining is you have to try again, that's all.
So my take
I
on
had
this.
one query whether the
My take on this, I am quite skeptical in starting prednisone, I tell you. Why? Because implantation is a balance between pro-inflammatory cytokines and anti-inflammatory cytokines. There is a role of inflammation when embryo is getting adherent and getting invading into the endometrium. And then the role of immunotolerance, or you can say TH2 type of response, anti-inflammatory response comes into the action. So whenever you give prednisolone, that suppresses the inflammatory markers, which are very important in initiation of the implantation. So in some of the cases where I think that I should start prednisolone, or patient was already on the prednisolone, on the contrary, I would stop when I start the progesterone, because progesterone is already does the immunomodulation, TH to TH2 response. So no more further suppression of the inflammation is required at that point of time. And I start after maybe 1 week, 1 week of gap, I would prefer to start prednisolone again. I have never read anything, this type of treatment anywhere, but this is my practice. This is based on whatever I know. So prednisolone should be stopped when you start progesterone, and maybe for after 1 week gap you should start.
1 week of embryo transfer.
1 week of every
No, after stopping. Because once the once the implantation window is over, then anti-inflammatory action are okay.
so these antithyroid antibodies are per se not responsible for causing this recurrent implantation failure.
Yes, it is the right. Anti-thyroid antibody is not reason for your failure. Okay.
I have another patient who is right now with me. She is a case of low AMH. I had used recombinant FSH during the stimulation, and I could get 4 blastocysts which I had frozen for this particular patient. 2 transfers she underwent, BMI of 31 for this patient, and 2 blastocyst transfers I had done, both have failed. So my question is whether I should invest in laser so as to try laser assisted hatching for this patient, whether I should invest in lasers for doing an embryo biopsy the 3rd time maybe if she comes back to me, or I should go ahead for an empirical treatments with this, all this intralipids and everything for her 3rd transfer. That is all. That is if she is willing to go ahead for another cycle.
So you mean to ask role of laser hatching in implantation failure? One question
Yes,
was
one
that.
question.
Any take on?
She didn't have a thick zona.
Because you
on
do
the
laser
fifth
hatching.
ring.
You do laser hatching. So what is your experience? Do you think that laser hatching should be done?
In a recurrent implantation failure, it's a role, and it will improve my success.
So what is the criteria when it is absolutely indicated laser hatching?
Laser, if there is a
Do you look
previous
at
failure-
the zona thickness?
Yeah, I zona thinning at the time of transfer, just before transfer.
But if the zona is
Zona
already
was
thin,
not
then would you-
thick, sir.
If zona is thin, then there is no. But if we do the laser hatching, then it will be very easy, because we have done also the PGTA, PGS. So in hatching, it is every time useful. If in 1 day before I do the laser hatching and next day I want to go for a PGS, then it will be hatched at the same place and it will be easy for me or my embryologist to take out the biopsy. So even if thin, then it is also helpful. It's my experience.
So according to my thinking, if you are doing technically the hatching process properly, it doesn't harm, it helps. Some isolated cases of increased thinning is noticed because of that, but it helps in thinning the endometrium, zona pellucida. It helps in the hatching of the blastocysts, and third, it provides a very good channel for the transportation of the nutrients. So it is, but then same time there are chances of damage also. So depending on your technical expertise of the embryologist, you can try hatching. There is no problem.
And sir, for the third, means now I will have to undergo repeat stimulation for her because my embryos are all exhausted. So for the next cycle, if I plan, then do you suggest doing an embryo biopsy? Like I will have to first take the cycle till day 5, do the embryo biopsy after the
PGT you want to see?
Yes.
So
for checking the aneuploidy status, the euploidy status basically. So.
See, if you ask me in implantation failure, what is your preference, ERA or PGT? My preference is PGT, not for ERA. Because euploidy of embryo is most important. That's the one answer. Second answer, non-invasive versus invasive PGT. So now non-invasive methods and people will become more and more expert, and non-invasive diagnosis is matching more or less to the invasive diagnosis. Maybe up to 70% they have reached. But you are saved, your embryos are saved from the damage and all. So I don't go for invasive PGT, but I have started advising non-invasive PGT and getting reasonable good result in recurrent implantation failure.
Okay, sir. Thanks a lot.
Mike?
I want to know from both of you, sir, how do you deal with the recurrent implantation failure? And practically, how you both are doing it?
My lecture, I will.
Yeah. And Sachin, sir?
Yeah. Let us go. Forget everything.
The tea, coffee and refreshments are ready outside if anyone wants to take a break.
So 5 minutes, I think after this discussion we'll give 5 minutes break, washroom break and tea, coffee or whatever you want to.
So please repeat the steroid, when do you start and what dose?
The patient who was on steroid, I stopped before starting progesterone for 1 week to 10 days maximum, and then again restart. And if I want to freshly start the steroid, I start after, transfer maybe after 4 days. I normally do 80 hours transfer. So maybe after 4 days of transfer, where inflammatory part is over, then I start steroid.
What dose?
5 milligram per day, 10 milligram per day. 10 milligram per day.
So you do 80 hours of transfer per day, 3 embryo or day?
80 hours. Most of the transfers are 80 hours.
Irrespective of the embryo age, irrespective of the embryo
We
age.
normally freeze at cleavage stage. And then suppose you are frozen at maybe 66 hours or 68 hours, then we thaw and extend for next 12 hours. So we will have a short break, precisely 5 to 7 minutes. Please all come back.
तो मैं बोल रहा
Yes, Dr. Friend. Meanwhile, you settle up. It's the same. Meanwhile, you settle for the next.
So for adenomyosis and endometriosis, we are giving a long down regulation along with letrozole. So is there any minimum duration we keep between the stopping of letrozole and starting the estrogen? HRT, starting HRT. So should we keep any gap between?
Why you want gap? Because why we are using letrozole and what is the effect on endometrium? You must understand. Letrozole we are using to reduce the aromatase expression. That's the only one criteria. I mean, one intention. And second intention is it helps in improving the receptor markers, integrins like beta integrins and those. So for these two purposes we are giving letrozole. Now, letrozole is not the adverse effect on the endometrium. The moment you start estrogen, the letrozole is not going to antagonize the action. And half-life of the letrozole is short, it's not long. So, after stopping the letrozole, definitely you can start
The right next day also.
Because logically, why I am saying, because there are protocols, there are studies which suggest after letrozole, even if you are getting a thin endometrium, you can add estradiol. There is no problem. You can add estradiol. See, that will definitely increase the endometrial thickness. Whether it is translated into increased pregnancy rate, that's a different thing. But it is not worsening the pregnancy rate. So there is no antagonism between letrozole. It can be started immediately.
Okay. And if the patient is not having any withdrawal after down regulation, we can start directly the HRT. So in that case, is it better to do scratching and then start HRT? If the patient is not having any withdrawal bleeding and having thin endometrium?
No, it's not needed. Because the moment you start the estradiol, the endometrium, all the proliferation starts. Proliferation of the endometrium starts. And what is the role of estradiol? One, proliferation of the endometrium, increase VEGF and proliferation of the endometrium, and most important is induction of the progesterone receptor. So these two functions are taken care whenever you start estradiol, and there is no withdrawal bleeding is not needed.
Because the patient has not been bleeding
the
for...
withdrawal bleeding is in our mind.
Okay. Thank you.
Dr. Mama, do you agree or do you differ? Both Anupama. Sir, both Anupama should not sit together. It is confusion.
So one patient who is adenomyotic, also she has a small uterus. So now how much we have to wait after giving the down regulation by agonist? Then for transfer, how to develop for the small uterus?
So you mean to say adenomyosis plus small uterus?
It is not endometriosis, sir.
Endometriosis?
She had chocolate cyst and the uterus is small.
Why uterus is small? I mean, it's congenitally small or
congenitally.
She is spontaneously menstruating every month?
But she has scanty menses.
Scanty. So whenever in IVF, the size of the uterus is not that important. If the endometrium is proliferated, it is achieving optimum thickness, it is achieving the adequate optimum endometrial volume, that is more than 2 ml. Then you should not worry about the size of the uterus, because myometrium has nothing to do with the implantation. Everything is to be done by endometrium and embryo. So there is no role of myometrium. So size of the uterus doesn't matter, provided endometrial proliferation in the term of thickness and volume is adequate.
So if
anybody is differing from whatever I say, I will be more than happy to listen that comment. Please, do not hesitate. Do not be hesitant. You can, because it's a bilateral. Even I will learn something.
So if the endometrium is also not very good on her scans, do we keep her 3 months of estrogen to build up the endometrium also?
Obviously, yes. Because the more estrogen you give, there is upregulation of the estrogen receptor. And there is a Chinese study where there was a persistent thin endometrium, resistant for everything. So what they tried, they give very high dose of estrogen, 16 milligram, for 2 to 3 months, continuously, till patient achieved the endometrial thickness. And they claim that, I have not tried this, but they claim that 85% of the patient of persistent thin endometrium, they achieve the endometrial thickness. Only thing, you cannot transfer in such cycle. So what they advise, after that they brought the progesterone withdrawal bleeding, And in the next cycle, they started with the moderate dose of the estradiol, and whatever endometrium was thickness achieved, maybe 6 millimeter, whatever, even 5.5 millimeter, 6 millimeter, 6.5 millimeter, they hypothesize that once the estrogen, high estrogen has been given and estrogen receptors are upregulated, in the next cycle, even if with the lesser thickness of the endometrium, if you transfer, you get a good result.
Okay, sir, this point you told yesterday also, and sir, no withdrawal in between the 4 months of estrogen, high estrogen, no withdrawal will be given.
No, progesterone withdrawal was given and then fresh.
But the 4 months, the high estrogen, 4 months, no bleeding in between.
No, absolutely no.
Okay, sir. And the last question, sir, that's Lupride, which I've already given 3 months. Will we have to repeat it for the transfer now? This 3 months now for Lupride, then 4 months for estrogen for 3 months. Will it work now for the endometriosis?
Now what is the rule? High rule we have given Lupride. So we have given Lupride not to down-regulate the pituitary.
Yes.
We are not stimulating. Stimulation is not there. We have given Lupride to reduce the estradiol aromatase expression and reducing the inflammatory markers. So that has been taken care once you have prolonged down-regulated. Following that, no need to give further Lupride. You can straightway treat that as a HRT cycle.
And to the transfer, sir.
Yeah.
After the.
Yes.
Thank you so much, sir.
Sir, in the endometrial preparation, when to start the steroids?
First of all, I do not believe in starting steroid in endometrial preparation. But if at all, if you want to start, if you ask me what literature says, literature has suggested various doses, right from day 2 till beta-HCG positive, 10 milligram. Some studies said they have given a high dose 4 days. Some studies after transfer. So there is universal conclusion about the using prednisone or steroid while in embryo transfer cycle. But logically, as we know, it's a combination, it's a balance between pro-inflammatory and anti-inflammatory cytokines implantation, and that dialogue only happens in such fashion. So if you give steroid, if you suppress the pro-inflammatory markers, then you are going to disturb the implantation. That's what I believe. So I always, if at all, this question comes in my practice where the patient is already taking steroid for some other reason, for many months or whatever. So then definitely I stop the steroid for 700 days.
So digogestrone is serving the same purpose.
Yes, as far as the immunomodulation is concerned, that and response to Th1 to Th2 conversion, dydrogesterone plays a very important role. Of course, all progesterone does the same thing, but dydrogesterone immunomodulation is better. The immunomodulatory action of the progesterone is achieved only by two ways. The best immunomodulatory action, and which is important for the implantation failure. One is dydrogesterone, and second, start using more and more injectable progesterone. Because for immunomodulation, the steady serum level is more important rather than endometrial level of the progesterone. So whenever there is implantation failure, always think about dydrogesterone and injectable progesterone. So can we move to the next topic? Dr. Fazlul Nissa.
Good afternoon to the whole auditorium, such enthusiastic audience, and I'm so thrilled to stand here, and thank you, sir, for giving me this opportunity. So we all know how different, and we have done a lot of study on PCOS. I'm just going to concentrate on the latest guidelines that have been this is an international evidence-based guideline of 2023. 2018 was the last which we had. Now this is like the 2023 guidelines. So the most important thing, as we all know, the Rotterdam's criteria, anovulatory cycles, irregular menses, along with the PCOD morphology on the ultrasound was the guideline. But now they say we have to test the serum testosterone also, the free testosterone, so as to we get a clear idea of not only from where the ovarian androgens are coming, or if it is too high, maybe we have to even exclude the congenital hyperplasia, Cushing syndrome, and hypothetical ovarian masses, all of that. But free testosterone has to be included in your PCOD patients. And the next important thing is ultrasound polycystic ovarian morphology. Before we used to count per follicular rate used to be around 10 to 15 per oocyte. Now they have diagnosed it as 18 to 20 follicles of 2 to 9 mm antral follicles on day 2 of the cycle. That should be the criteria, because most of the time when we see those, at least even I find people where they are normal responders around 8 to 10 mm, they give it as a PCO morphology, most of the diagnostic centers. But for them to exclude it as a PCOD, it has to be more than 18 to 20 follicles, antral follicles on day 2 of cycles of 2 to 9 mm. So another one more feather in the cap, AMH, we all do it, but now they say AMH is mandatory for PCOD patients, and it can vary in this, the AMH value can significantly vary along the cycle. That's what they say. If we are doing it on day 2 and if we are doing it on day 21, they say there is a variability, so it is better to do the AMH on day 2. It should not be used as a diagnosis itself, but we all know that if AMH is more than 8 or 10, we are skeptical to start even ovulation induction. We rather give them COPs, OC pills for a couple of months, like Diane or Yasmin, and then we can start. So now they have made it mandatory. AMH also should be included in your panel of tests. So not to forget the cardiovascular risk factors and the endometrial carcinogenic factors for untreated or people who are more than 40 years, had previous history of PCOS, have delivered kids, then again they come to you with bleeding risk. So we have to take care of those patients. It's not just the infertility part, but also the premenopausal and postmenopausal women who are having higher risk of cardiovascular diseases as well as endometrial carcinoma. And OGTT is also included in the list of the test. 75 grams of OGTT is mandatory for all the PCOD patients that we have to do on day 2. The day 2 of panel of tests for PCOD is what I'm... So impaired glucose tolerance test with type 2 diabetes risk, of course, and insulin resistance. So metformin, somebody was asking, that they have, just now, they had euploid embryos, but, they were not still able to implant. Maybe all these, inositols, metformins, or ocipils, or whatever, all these will interplay a lot of, implantation factors. So metformin, as they say, can be continued even in pregnancy. It can help in decreasing your diabetes mellitus, late miscarriage, hypertension in pregnancy, preeclampsia and macrosomia. Before we used to stop it as soon as the heartbeat comes, but now we can continue it even after the heartbeat, because there's a study which says there are no congenital anomalies because of the metformin that we use in pregnancy. And of course, for the fertility, all fertility treatment in PCOS should be guided by the all these factors, and the prenatal vitamins, supplements, folic acid, all those will go on. And the most important is how to start the ovulation induction. Now they have decided that the letrozole is the single and the foremost important drug that we have to start, not the clomiphene citrate, because some of the countries have banned, like US also doesn't use letrozole. But now after all these studies, they have made letrozole as a first line drug. We have to use letrozole for at least 3 months after ovulation induction. Only then, if we doesn't get any result, then we have to go for gonadotropins and everything else. Letrozole should not be given when there is a possibility of, of course, before giving all this, the pregnancy should be excluded. And so the gonadotropin releasing hormone is a second line agent. The most important one is letrozole. And the trigger type, as we all know, we tend to use antacycle, and we would like to give a GnRH agonist just to overcome OHSS. And the choice of FSH, I think the protocols and all, in that we would have a better discussion which FSH to use or which HMG to use. But most of the time they would say it would be better to use a recombinant follicular stimulating hormone for PCOS patients with controlled ovarian hyperstimulation. And of course the adjunct metformin also has a very good role, especially when the patient is obese, more than 28 BMI. And so as we all know, it can also rescue us from a part of OHS. Commence metformin at the start of GnRH agonist treatment, gradually titrate metformin up to around up to 2500 mg is the highest that we can give, and stopping metformin therapy at the time of pregnancy or late. But the latest guidelines have said that metformin can be continued even after pregnancy. And IVM is one more, I have never used the IVM, but a lot of centers do use all those premature follicles which are not extending up to the M2 size. They go for IVM, in vitro maturation as well. I have never used it. So the summary, this is the summary of the guidelines that we have, the latest ones, in which specifically diagnosed recommendations include AMH, and ultrasound should be more than 20, and sleep apnea. Yeah, and the most important thing is PCOD patients, we tend to, the mental stability is very less. Either they are too depressive or too anxiety. It's not because of them, it's the hormones that are interplaying. And the mental health also has to be taken care of, just not the physical PCOD thing. Like the holistic approach is what the consensus has declared, and information, and it also includes TLC, tender loving care, whatever. And so these are few points, and this is one future perspective of PCOS. It has not been invented. I think phase 2A study has been done for neurokine 3, which is a NK3 receptor antagonist. Fezolitant, in the fezolitant has a sustained effect of suppressing the hyperandrogenism. I think this is still in the phase trial. Sir would be able to throw more light. It's a kispeptin acting drug, sir. Yeah.
Two minutes left now.
Yeah. So in addition, kispeptin treatment increased oocyte production by more than 60% of IVF. So these are all the future prospects that we would have in PCOS. These are still under the trails. So would you be able to throw some light on kispeptin and the action? Thank you.
Hello, thank you. Kispeptin को कभी kiss नहीं किया है.
I have found this drug, sir, fezolitant, on the internet. It says 32,000 for 20 tablets. But it helps in decreasing the LH. All those people who are worrying about high LH and they don't have time, there were a lot of cases like that. So I think fezolitant, I mean, half of the cost of your IVF cycle maybe. So yeah.
So before the question comes, couple of comments, so that probably it may reduce the number of questions. Number one, as per the new, because with the better improvement in the accuracy of the ultrasound, and when we are using 2 to 9 megahertz frequency probe, transvaginal probe, they are increasing the number of the minimum follicles per ovary for the diagnosis of the PCOS, if it is based on enteral follicle count only. So the best, more practical way is FNPS. एक ही plane में, if you get more than 10 follicles in a single plane, it's diagnostic of PCOS. That's more simple rather than counting all the follicles in the ovary or something.
But most of the diagnostic centers, sir, as soon as the patient goes, we get the report. PCO morphology, clinically correlate. So इसके वजह से I think they have to increase the criteria from 15 to 18.
Second thing, as she pointed out, the AMH, many would think AMH का क्या काम है? What is the role of AMH? Why want to do AMH? But I believe AMH should be done because AMH guides us in a couple of ways. For example, as he said, the MH is more than 8, then these patients are mostly CC and letrozole resistant for shorter duration. I'm not offending on extended protocol, but
So, but guidelines have made letrozole as #1 drug as of now.
so if you do 5 days letrozole or 5 days clomipene, mostly it is resistant if the MHS level is high. So mentally you should be ready that this patient may require gonadotropin. That should be counseling. That helps in the counseling. And second, suppose if you are doing IVF in situation where basal AMH level is high, because AMH and LH, they goes hand in hand. These both the hormones, they goes hand in hand. So if the AMH is high, basal LH is also high. And when the basal LH level is high, these are difficult to stimulate PCOS. So you need to have a higher starting dose of gonadotropin. They are, because these are poor responder PCOS, I would say. So a little higher dose is required, some other manipulation is required.
And one more point I just forgot to answer. Inositol, they say, have not got a good role. That's what the conscious says. But we all know we use myoinositol, D-gyricistol with all the khichdi masala and all that. I feel it has somewhere some role along with metformin.
Dr. Asa is there and Dr. Rupama is there. So they are going to throw more lights on the adjuvants, right?
Okay.
And third, lot of things they have described in chronic low dose protocol for severe PCOS. It's not practically usable because the expenditure is so high. What are you gaining after giving thousands of rupees of gonadotropin? If you are aiming only single egg, and that too the pregnancy rate somewhere around 10, 12%, 15%, max 12%. Then it's and that if that cycle fails or if patient loses the patience, then, and most of the time that happens, either patient loses the patience or clinician loses the patient. So chronic low dose protocol is not favorable after we all have tasted the fruitful results of extended letrozole protocol. That is one thing. Second thing, FSH versus HMG. If you start FSH in PCOS, it's fine. But suppose because of some constraint, if you want to use HMG, there is no problem. For PCOS, it is gonadotropin only. Because after giving HMG, there is hardly any difference in the serum LH level. So LH activity is not tremendously increased because basic LH activity in HMG is especially in highly purified HMG. So you should not be hesitant in using HMG in PCOS, for sure. Then somewhere I read, I have never tried, but they tried TVOD, transvaginal aspiration of the, drilling, before starting the stimulation. And that gives immediate result. I have not tested.
Which one, sir?
TVOD, transvaginal ovarian drilling, just before starting the stimulation. So if you still want to cut down the cost, you can do that because the research papers had shown tremendous better result. So if any of you have tried any time, would you like to say anything?
Laparoscopic drilling means
TVOD. I never tried because I felt that unstimulated ovary is difficult to manipulate. That's the only reason why I did not try. But one day I definitely will try.
Can I just add a few points about PCOD? See, what usually happens to a fertility consultant is when a patient comes for seeking fertility, we immediately want to put her on some cycle for IUI or IVF. In PCO, I would recommend, or normally that is what I do, is optimize the PCO. We have a problem where the FSH levels, LH levels, there are disparity. The LH levels will be 2 to 3 times. The definition was 2.2 to 2.6 times FSH. So ideally give them a course of OCs, and the best course would be something like OC with cyproterone acetate, which is an anti-androgen. Sorry?
Spironolactone also is.
No, the best is cyproterone, so something like dial 35, because the safety issues are there with drospirenone related OCs. So one, give them a couple of months of dial 35, 2 to 3 months before that. Second, metformin mandatory for all PCOS. And third, while waiting out, there's a nice RCOG patient
information booklet which is available for easy download. It's a 5-page booklet. Take out printouts, keep it in the file, and all your PCO patients, you give them a copy. So what I do is there is endometriosis, there is a PCO, and there is a gestational trypoplastic tumor. So all these printouts, I keep it in a file, and all patients we give a printout and tell them to read it. Rather than going on the net and reading some random blog, it is better the patient reads the RCOG guidelines, and trust me, their compliance is much better after reading the RCOG guidelines. And after doing this pre-treatment with 2 to 3 months, then go for whatever you want. And what you need to do in such women, if you've not put them on OCs, from the perspective of regularizing the cycles, you know, I mean, she is saying that मुझे IUI नहीं करना है, मुझे IVF नहीं करना है, just give me some natural cycle. So now a lot of these PCO women are deficit with the luteal phase. So just give them a luteal phase progesterone support. So I ordinarily give them just natural micronized progesterone from day 18 to day 27. 2 advantages: 1, the luteal phase will get supported, and 2, she'll get regular cycles. And while waiting for this, you know, there are a lot of women who just conceive on their own with just giving the luteal phase progesterone treatment. Thank you.
Thank you, sir. One thing, a couple of sentences about the role of IUI in PCOS. So when I was following the SPEROF, in SPEROF it is clear written. Treat the cause. If anovulation is caused, there is no role of IUI. Those who have read SPEROF must be knowing. So SPEROF clearly mentions that there is no role of IUI in anovulation PCOS. Practically it is not correct. Even in PCOS, the IUI results are much better than control ovarian stimulation with time intercourse. So IUI can be used as a step-up treatment if oral drugs with time intercourse doesn't work. You can always resort to IUI. Dr. Momo, what do you say?
In my experience, PCOS has been the easiest infertility problem to treat. I'm very happy if the diagnosis is PCO, because in 1 or 2 cycles they conceive, but once she walks in, I start metformin. 250 mg TID 10 minutes before food. So by the time 1 or 2 months passes, by the time she's ready for her IUI or TI cycle. So by the time metformin would have acted. And also her BMI, I give them advice about their diet and exercise. So the metabolic syndrome has taken care, and LH would have come down by that time. So the stimulation becomes easy, and I do combination of letrozole with gonadotropin. I maintain the follicle size and the endometrium, I maintain the growth pattern, and then do an IUI with the luteal phase support, and the first or second cycle they conceive.
Any question, please come. Those who want to ask a question, please make it. Speak loudly.
Good morning, sir. Sir, I have one question that suppose the PCOS patient, they have already high LH level. So instead of giving HMG, if we give Recapacet, the results are good. Because one of my patients, 2-3 patients I use chronic.
I disagree with the sentence. Where it is written, Recapacet's results are better in PCOS, where it is written. So me.
You should actually read up the Megaset HR trial. For anybody who is wanting to do anything in fertility, there are 2-3 trials which are mandatory to be read. One is the Merit trial, second is the Megaset trial, and third, the latest one is the Megaset HR trial. Read that up, then on the group we'll discuss about that, and that will completely change your perspective about not using HMG for PCO women. On the contrary, what usually happens is when you have PCO women, when we are giving Recapacet 150 doses for 10-12 days, you are seeing a lot of follicles which are just 10-12 millimeters but not growing. Replace Recapacet with HMG 225 or 300 and you will see everything growing. So even though the baseline LH levels are high, but HMG is needed, LH is needed for the growth of the follicles. Yeah.
So there is a well-designed study conducted by Dr. Abha Mazumdar. She mentioned something about FSH resistant PCOS. There is a group of the PCOS which are resistant to FSH, and once it was switched over to HMG, the growth of the follicle started. So what hypothesized by them was if you, in PCOS also, if you start HMG, it increases the sensitivity of the follicle towards FSH, because LH or LH activity in HMG increase the sensitivity of the follicle towards FSH. So then the stimulation becomes more easier.
So instead of antagonist, we use clomiphene to prevent premature rupture sometimes in...
Not in PCO.
Yeah, so why not in PCO?
The guidelines are very clear. The 2018 and the 2023 guidelines that letrozole should be the first line drug in PCO women. See, what will happen is with your just 5 day standard.
No, I mean in stimulation. When you do for...
See, you want to ask the adjuvant, oral adjuvant, letrozole versus clomiphene in PCOS IVF stimulation.
IVF stimulation, sometimes we use clomiphene and continue the clomiphene till the day of trigger for IVF. Yeah. Most commonly we use it for normal responders or poor responders, but what if we use that clomiphene as instead of antagonist in PCO? Would that be detrimental in terms of, or would the incidence of rupture be more if we were to use clomiphene?
No. Definitely you can use clomiphene as adjuvant in even PCOS IVF stimulation.
Instead of the antagonist.
Yeah. So in my talk, if I get the time, I'm going to discuss the universal protocol, which works for all. So in that, I combine clomiphene in all my...
So I have used for a patient like
because
that
now you have opened up the discussion, so I would like to say a few points which are quite relevant.
I just finished this question.
Yeah,
also,
please.
This patient is on clomiphene and HMG 225. She's a PCO, severe PCO, and she is on. I didn't use antagonist till day 8 of stimulation. On day 8, I added the antagonist because I was scared when I saw the LH. It was 27. But then I remember that even though LH is high, it will not rupture. But then the antagonist is also there, but I didn't understand why, but I had that information, so I would like you to explain.
Okay, now there are 2 points. Does high LH in PCOS cycle means threatened rupture? No.
The LH was 27. No.
Because the LH surge, how it is initiated, that concept is changed totally. What was our learning till now was when there is the E2 level crosses 200 and it persists for maybe 50 hours, then LH, because it converts the LH positive feedback, initiate the positive feedback, and LH surge is initiated. That is our standard understanding till now. But now they found out that the reason or mechanism of initiation of the LH surge is different. Unless the follicle, progesterone coming from follicle, modulates the pituitary, LH pulsatility, change the amplitude, and then how the LH surge is initiated. How? So when the follicle is mature, means oocyte is mature, there is a spontaneous luteinization of some follicle. That's one theory which produces progesterone. Second, when the follicle becomes mature, there is increased inflammation, increased vascularity, which we all have noticed around the follicle. So because of this increased vascularity, there is increased endothelin level marker, which inhibits the progesterone inhibitor. So the progesterone level is increased, and that acts on the pituitary receptor, LH receptor, modulates the pituitary LH frequency, and that's how the LH surge is initiated. In nutshell, to understand, rather than going into all jargon, the follicle, when it is mature, it gives a signal to the pituitary in the form of increased progesterone level. If you observe, before initiation of the LH surge, there is a rise of the progesterone. If you notice the graph which was shown in the morning, there is a little rise of progesterone before initiation of the LH surge. So it is not estradiol peak which initiates the LS surge. It is estrogenized follicle harboring mature oocytes secreting progesterone, giving signal to the pituitary to initiate the LS surge. So, in this case, even if the follicles, if this would be a scenario where the follicles are more than 15, 16 millimeter, then the things would be different. It is a threatened rupture. But otherwise, there is no problem. And another thing you are forgetting, when you are giving clomiphene to the patient, clomiphene blocks the pituitary estrogen receptor. So pituitary does not recognize the estradiol level. So this receptor remains blocked, and after stopping the last pill of the clomiphene, next 4 days, you are immune for LS surge. LS surge will not be initiated. I have tried many cycle
in PCOS.
Many cycle using just clomiphene and HMG. No antagonist, no progesterone, and I have rarely found a rupture or premature rupture of the follicles. So clomiphene, you can definitely rely on clomiphene as far as the prevention of the LS surge is concerned.
But then even if the LS is 27,
because unless the follicle gives the signal,
thank you.
Sir, but then we say we have
because it is not only LS level, the amplitude, that type of amplitude, frequency, everything has to be changed. It is not reflected in the level, it is not related to the level.
So I just panicked.
That's the reason. What is the definition of the LS surge? If you want to make it simple, single measurement of more than 20, we believe. Some paper, single measurement more than 70. But what is the ideal definition of the LS surge is 180% rise from previous 3 days of LS level, average LS level, which should be more than 17, and it should be next day followed by 30% fall in the estradiol level. That's the definition. So suppose the day the LS level is 20, for example, next day 22. On the day of 20, the estradiol level was 1500. Next day, LH is still further rose, but estradiol fell down by 30%. So which will be LS surge? 20, not 22. So it is not only a LH level. Fall in the estradiol level is also important.
Sir, but then they say that we have to start antagonist a little earlier also in PCOS patients. But according to that, progesterone, if there is progesterone rise only, then LH surge will occur. The luteinization should be there for the this LH surge.
The spontaneous luteinization is a theory. There are two theories put forward. Why estrogenized follicle harboring mature oocyte secretes progesterone. So there are two theories. One is spontaneous luteinization of the some of the few granules or cells when the follicle is mature and harboring mature oocyte. That's one theory. And second theory is endothelial theory, inflammatory markers that reduces the destruction of the progesterone.
Can I just give a separate viewpoint, sir, before the question? Doctor, sorry, I don't know your name. What usually happens in PCO women? Let us now just have a dialogue, okay? How are the follicles in PCO? More or less? So what is going to be the estrogen level, more or less? When the estrogen levels, we are talking about a non-stimulated, completely non-stimulated, you've started the stimulation, but the follicles are still 8 to 10 millimeters. The growth has not yet started. So what is going to be the E2 level in such a woman, in a PCO woman, compared to other women? Agree? Everybody agrees? Now if we see the chart, if we see that standard chart of estrogen, progesterone, FSH, LH, a higher estrogen is going to bring about a LH surge and a progesterone elevation as well? So in a woman with PCO, where your baseline E2 levels are high, before initiating cetronidase, in a normal patient we would want
to initiate cetrorelix when the follicle crosses 13-14 millimeters. So would you be doing the same in PCO? Am I clear? So in such women, you have to follow the fixed cetrorelix protocol. 5 days of gonadotropins, 6th day we have to start cetrorelix, followed by an agonist trigger. In PCO women, never use a dual trigger. It's always an agonist trigger, and as I mentioned on the group, please use Lupride. It's cheaper, more convenient because patient gets a single drop prick compared to decapeptyl, where a patient has to be given 2 to 3 pricks. Clear?
Please.
Sir, when the initial A2 level is high in PCOS, there are some papers, I don't know, I have not used it, CC plus letrozole combined given for stimulation. Any experience about this?
Yeah, I totally agree. There are papers. Upon that paper, I did not have access to the full the paper, but whatever I read, they use combination of the letrozole and clomifene for resistant PCOS. They say that resistant PCOS compared to the singular drug combination is better, because both the mechanism it takes advantage of both the mechanism. Letrozole's positive effect on the endometrium, and both inhibits the pituitary, and the FSH and LH secretion happens. So synergistic, basically it is hypothesized that it synergizes because of the synergistic action, the results are better, nothing more than that. It doesn't create any magic. If you compare with the extended letrozole protocol combination, I would prefer extended letrozole rather than combination. This is not I'm telling to please Sachin. Please, can we?
So, sometimes the AMH and LH doesn't correlate. The LH is high, AMH is around 2.3. It's like that in the PCOS patient. What should we do? Go along with LH or? Because the ovary also looks very, the stroma is more in those type of cases.
In the PCOS, the ovulatory effect of AMH on ovulatory PCOS and effect of AMH as a gatekeeper on anovulatory PCOS is different. Same way, the LH correlation with the AMH is different in anovulatory PCOS and ovulatory PCOS. I said the LH and AMH goes hand in hand, that is for phenotypic A and D, anovulatory PCOS. I am not talking about ovulatory PCOS. So milder PCOS, this can be true. AMH is high, but still the LH, basal LH level is less. It's good. It's good. I think they are more friendly PCOS rather than the PCOS having high AMH and high LH level.
Sir,
last question for this session.
Sir, when you use clomiphene citrate to prevent LH surge, what is the quality of the oocyte and embryos? Is there any change or no?
No, no change. In fact, I have started a new protocol, trying a new protocol, where I use clomiphene for 5 days. And on 6th day, medroxyprogesterone plus gonadotropin continue. So I'm trying since a couple of weeks. Let's see how results are, because that saves the cost. The problem with the progesterone prime protocol is too much suppression of the LH plus increased doses requirement, so which is taken care by the clomiphene. And the problem with the clomiphene is very high LH level. If you give a higher dose, all throughout the stimulation, the LH level is quite high. So pituitary, the progesterone helps in curbing that.
So clomiphene citrate stimulates the ovary in the first part, and progesterone suppresses the LH surge.
So by the time progesterone start taking action, because whenever you give progesterone takes 5 days to inhibit the pituitary. After 5 days, we can be rest assured that now LH surge will not happen. So clomiphene, and good thing about the clomiphene, after the last week of the clomiphene, next 4 days, there won't be LH surge. So that by the time the clomiphene effect wears off, the progesterone effect goes off. Medroxyprogesterone, as per the study, 4 milligram. They have all the medroxyprogesterone prime protocol. They have studied the 4 milligram is available there. It's not available in India. So we use 10 milligram. Please.
Good afternoon, one and all present here. I first of all thank the organizers for giving me this opportunity. My topic is on evaluation of male infertility. Why to evaluate a male? Whether he is the reason for infertility. If he is the reason, then what is the reason? If reason is being found, whether it is treatable or untreatable. So finally coming to a conclusion and giving a solution to the couple, that is the motto of evaluation of the male infertility. So before going to the main talk, there are two basic things to remember. One, the pituitary, it secretes two important hormones. One, the FSH, it acts on the Sertoli cells to produce the sperms, which is essential for the reproduction. And two, the LH, it acts on the Leydig cells to produce the testosterone, which is essential for the sexual function. Second basic thing we need to remember is the semen consists of two important parts. One, the sperm, which is produced in the testis and is maturing in the epididymis. But the sperm is constituting only about 5% of the semen. Remaining 95% of the semen is produced by the accessory male glands. One important gland is the seminal vesicle, which is producing about 45 to 80% of the seminal plasma, which is alkaline in nature, which contributes to the alkalinity of the semen. And second, the prostate. Prostatic secretions are about 25 to 30% and is alkaline and acidic in nature, which is essential for the liquefaction of the semen. So having this in mind, so the evaluation starts from the basics, like important is the history and the examination. In the history, we should not forget to take the history of cryptorchidism or its childhood surgeries or any maldevelopment in the pubertal age group or his present sexual history, his lifestyle, occupation, environmental exposure to toxins, etc. And in the history, local examination and general examination. General examination, body habitus, it gives a clue about genetic syndromes like Klinefelter syndrome, and weight is important because weight is directly proportional to male infertility, and also hypertension. And local examination, we should see the scars in the abdomen, previous history of any retroplacental surgeries. It can lead to retrograde ejaculation. Also scars in the penis, previous history of any surgery for the hernia, hydrocele, and presently we need to examine any hypospadiasis or phimosis or undescended testis or any scars for the undescended testis surgery. And importantly, we need to feel for the testis for its volume and the consistency. And epididymis also, vast difference we have to feel. And rectal examination we have to see for the prostatic and seminal vesicle enlargement. So the semen analysis, it mainly consists of two major portions. One is the macroscopic and the microscopic, and the parameters are given here. So the semen parameters given by WHO 2010 and WHO 2021 are illustrated here. Majorly there was no difference, but one important thing they are telling is whatever kept as a threshold to distinguish a male between a fertile and infertile, it's being removed now, and whatever the semen parameter is there, that man can conceive. That is the important message we have to get. Why? Because almost 14% of the men with semen count of 1 million per ml, they are conceiving spontaneously. So, how to interpret the semen analysis? First, we'll take the macroscopic parameters. One, the volume. The volume should be greater than 1.5 ml. If it is less than 1.5 ml, things we have to, it comes to our mind are first, lack of sexual drive. Commonly, many women in a crowded place could not produce the semen in a proper way. So if that is the case, we have to comfort the men and produce a next sample to confirm the diagnosis. Then if the man is having the sexual drive, then retrograde ejaculation should come to our mind. In that case, any history of multiple sclerosis or diabetes should be ruled out. In that case, post-vital urine sample should be examined for the sperm. Then important cause for the less volume is the seminal outlet obstruction. That is the vas deferens aplasia or ejaculatory duct obstruction. Because the seminal plasma majorly it is produced by the seminal vesicle. Then the color of the sperm. Color, it is white and opalescent. If it is watery, it indicates of lesser sperm concentration. pH, it should be greater than 7.2. If it is less than 7.2, it again indicates any seminal vesicle infections or any obstruction in the pathway. That is the vas deferens absence or seminal vesicle agenesis. So if we get a very low volume seminal volume as well as an acidic pH, we have to rule out vas deferens aplasia by means of physical examination and ultrasonogram. In that case, we need to do a cystic fibrosis transmembrane regulator gene mutation checking. And liquefaction. Liquefaction, it should be between 15 to 30 minutes. If it is greater than 60 minutes, it indicates prostatic infections and prostatic acid protease deficiency. Then the microscopic factors. Concentration should be greater than 15 million per ml. If it is less than 15 million per ml, it is called as oligospermia. Motility, grade A and grade B. Grade A is progressive motility and grade B is non-progressive motility. Total should be greater than 40 and progressive motility should be greater than 30. So these are all the situations where like varicocele, infections, inherent sperm defects, also anti-sperm antibodies should be ruled out. Morphology, if it is greater than 4%, it is normal. If it is less than 4%, it indicates some problem. Agglutination, there are two types of agglutination. One, specific agglutination in which the sperm to sperm will be bound. In that case, we need to check for the anti-sperm antibodies. And also non-specific agglutination in which the sperm will be bound to a non-sperm particle. So in that situation, seminal infection is the cause in which seminal culture will help the patient. And other cells like leukocytes should be examined. If more than 1 million is present, then semen culture should be done for the patient. So evaluation of the oligospermia, mainly 3 categories are there. 1, mild oligospermia. 2, moderate. 3, severe. Mild is between 10 to 15 million per ml. Moderate is 5 to 10 and severe is less than 5. Mild cases, immediately hormone assays are not needed and we have to rule out varicocele or infection or systemic diseases, or if the patient is obese, we have to advise him to reduce the weight, give him some antibiotics as well as antioxidants, tell them to have a sexual life for 3 months. If the patient is not getting conceived, then we can reassess the sperm analysis after 3 months in cases of mild. Moderate, we need to do a hormone assay. Main hormones are the FSH and the testosterone. If the FSH is low and the testosterone is low, it indicates of hypogonadism. If the FSH is normal and testosterone normal, then testicular causes to be ruled out. If FSH is high and testosterone is also very low, then it indicates severe testicular problems. And in cases of severe oligospermia, apart from hormonal testing, we need to test some genetic testing. Basically, there are only 3 genetic testing in male infertility. One is the cystic fibrosis transmembrane regulator gene mutations. It has to be seen only in obstructive azoospermia. Then 2 other tests. One is the Y chromosome microdeletion test. Y chromosome, it is having 3 important regions. That is azoospermic factor A, azoospermic factor B, azoospermic factor C. If microdeletions are present in A and B region, no point in doing micro TCA for these patients because sperm recovery will not be possible in those patients. But in microdeletion C patients, it is the commonest microdeletion and we can retrieve in about 50 to 60% of the patients. So this other genetic analysis is the chromosome karyotyping. In chromosome karyotyping, in cases of severe OATS, we are having autosomal variations like deletions, balance translocations, etc. But in non-obstructive azoospermia, we can get cases of Klinefelters, that is X-linked disorders. In Klinefelters, we can be able to retrieve in about 25 to 30% in microteasum. And when we could not come to a conclusion with all these reports, these men are categorized into idiopathic male infertility, where these patients are subjected to other tests, extended tests like sperm DNA fragmentation test by means of Tunnel or Comet or SCSA, etc. And also reactive oxygen species estimation is important. So this comes the final end of my talk, and thank you very much for your patient listening.
Thank you. So, madam, when do you indicate testicular biopsy as a part of the male evolution? Any indication of the testicular biopsy?
Testicular biopsy, if the testosterone is normal and FSH is normal and vas difference is absent, in that case we need to do a testicular biopsy for in the name of teasers. If also in cases of non-obstructive azoospermia, when the patient is willing for their own sperms, then we need to do.
Well, lastly, can I say that when you are not sure whether it is obstetric azoospermia or non-obstetric azoospermia, when there is a borderline case, hormone levels are borderline, testicular volume is normal, vas difference is also there. So you are not sure, then you want to rule out hypospermatogenesis or which are maturational defect or something which are quite amenable to the treatment. So these are the case I think where you can think about a testicular biopsy. But only thing, if you are planning for testicular biopsy, you should be ready for sperm vitrification at the same time. Second thing, morphology. Nowadays, because in IUI, morphology doesn't play an important role as per the study. And in ICSI also doesn't play. So now importance to the morphology is given less and less, I believe, if all agree. If somebody has anything to say, you are welcome. Because the motility is the most important criteria of the sperm, I mean semen analysis and fertilizing capacity of the sperm. And during ICSI, we select a sperm which are apparently looking normal. Morphology, similar to DNA fragmentation. It's still in the gray area, not to be considered as a routine test. Similarly, morphology also should not be considered as a routine test, I believe. Any comments? Welcome.
When we are doing PISA or ICSI with less counts, when we are doing TISA or we are doing ICSI when less number of sperms are available and we have to actually choose which sperm to be inserted inside the zona. So in that case, what are we actually looking at? I mean, I wanted some embryologist's opinion about this, that how do they select the sperm? I think it is the morphology there rather than the motility part, because you know, in TISA I'm getting 10 sperms lying there. Which one of them to insert? This is a very common dilemma in my mind when I don't understand. All of them are just wriggling there, and which is the good sperm? How do we assess that?
The sperm having a normal size of the head and having a curvilinear velocity and curvilinear movement are supposed to be a good sperm. So
in
ideally,
TISA they are not actually really moving. They are just wiggling.
But the movement, the curvilinear type of movement is that sperm should be picked up and immobilized for ICSI.
And there is nothing important to be seen at the mid-piece or the...
That is not actually, while ICSI, mid-piece and all those details are not seen. What we can appreciate is a shape and size of the head. Yeah, please. Sir, please. I forgot you are here.
yeah. I actually wanted some embryologists also to comment on that.
Your question is very well justified because, to be frank, morphology is the backbone of sperm selection. Howsoever people, because from the day ICSI has been invented, people are just skipping near zero attention to the sperm as such. Because what happens is, first I'll just highlight the importance of morphology. Now sperm is a globoid. On it there is an acrosomal cap which is pyriform in shape. So when the oocyte reaction takes place, the sperm attaches it at an angle. It doesn't go straight. So there is a typical area which comes in contact with the oolemma, which triggers off the reaction and which forces the sperm to enter into it. So the acrosomal pyriform shaped cap is of utmost importance. So as far as your procedures like natural conception, IUI, IVF are concerned, morphology does play an important part. And coming back to Dr. Futela's question, that when we harvest a TISA sperm or a PISA sperm, remember these sperm are younger in age compared to the ejaculated ones. The TISA sperm is something like 15 to 17 days younger. Sorry, the PISA sperm is younger and TISA sperm is still younger. The only what we justify is the twitching pattern. Because the only thing which has been well developed is the head part and the acrosomal part and the DNA content into it. The rest of the modification takes place subsequently as the sperm matures. So sorry to say, it's just a gamble. Let me be very frank about it. And over there, when we use IMSI and all, we are just justifying a little improvement in its morphology as such, because in embryology, remember, there is no criteria which deals with the genetic aspect. What all we are doing, whether it's an embryoscope or whether it's a 1.5 crore of an equipment, we are just justifying every gamete by its morphology appearance. We are not touching the DNA aspect at all. So we cannot say with impunity that this is the right sperm or the right egg. Of course, it takes time for the embryologist to scan the better looking devil from the devils. So it is just like a tic-tac-toe what we harvested. So it depends upon how the aspirate is done, how the aspirated sperm are cultured, that's equally important. And plus, in such cases, how delicately and properly is the ICSI implemented. That's what I wanted to say.
Sir,
otherwise,
the morphology was playing such an important role, then why IMSI is not well accepted in unselected case?
First of all, IMSI doesn't increase your result. Period. What IMSI does? IMSI is responsible for bringing down the abortions in those ladies who have been impregnated with embryos using OAT sperm. Remember that. IMSI doesn't jack up your success rate. It drops down the abortions done. That's the most important part. So it is also giving us a number of parameters. Few vacuoles, multiple vacuoles, large vacuolation, mix, decondensed head, or maybe a little membrane trauma. So what IMSI is doing is when we have no choice, at least let us try to filter out the best of the best sperm. But again remember, it is not touching any more biological aspect. So we cannot say with authenticity that this is the one which is bound to give me a fertilization. The only test which has just touched the frontiers, or I would say the portal, is DNA fragmentation, which also has its own ups and downs. You got my point, that this is the only one which has touched the more biological aspect. Otherwise, it is just appearance, morphology, shape, size, fragmentation, blah, blah, blah. Thank you.
Thank you, Sir.
So if we are doing a testicular biopsy and sperm vitrification, what will be the outcome? Like if you are doing a ICSI with the vitrified sperms, is it better to do the ICSI immediately with that sperm, or should we freeze and use those sperms?
If it is possible, always fresh ICSI should be done. But it is logistically, if it is not possible, then you don't have option. Suppose patient has been stimulated and accepted that okay, if we get the sperm, we'll do immediately ICSI. And if it doesn't get sperm, then those eggs he is ready to be vitrified. So anyway, fresh ICSI is always better. And if you want to vitrify the isolated sperm, the special device and this agarose type of this thing. I think Dr. Kirsi will be able to tell for the vitrification of the single sperm.
Vitrification of single sperm, especially in normospermic sample, if at all you want to do, results are always better. But if you do vitrification of sperm in a compromised semen sample, the recovery is quite wishy-washy. Let me be very frank about it. Because even prior to this vitrification, when we used to freeze the semen samples in professional biological freezers, where they have got separate programs for testicular sperm, epididymal sperm, and the ejaculated sperm. Because that was a fantastic way, because it used to control the drop rate of temperature. And after the starting of this vitrification, due to the time saving factor, it was an instant cutoff where the temperature drops to 60,000 degrees per second. Okay, so the survival rate of testicular or epididymally aspirated sperm post-vitrification is less, because what you will be seeing is, you are happy when the sperm moves. That's the kinetomatics you are taking care of. But you are not sure about the DNA damage inculcated, what is the DNA percentage recovery rate in the acrosome. And when you are doing ICSI, definitely you get good fertilization because you are breaking the membrane and you are inserting the sperm per se manually into it. So don't get alarmed by the FERT rates post ICSI when they are very high. What we need to see is the viability and what we call it as the control embryological time scale, that hour at which the subsequent progression of embryogenesis takes place. And final cake on the icing is pregnancy.
Thank you. Okay, can we...
Does AI have any role in sperm selection or sperm sorting in ICSI?
Recent procedures like SQA, it is utilizing AI only. Like it can assess the sperm parameters within 45 seconds. So 16 parameters will be assessed. So it produces a standardization in technique. So we can interpret the result better.
What about the role of microfluidics, sir, in assessing the sperm quality? Microfluidics?
Basically, if you just try to go and see the definition. See, microfluidics is a physics term. Micro is in a very small area, under greater pressure, any object is supposed to move. Right? So what does basically take care of? It takes care of the motility as such. So what the people apprehension is that the sperm which moves the best is supposed to be the best. Without having a little realization, even if the shape of the acrosome is perfect, the morphology is perfect, we are doubtful about the DNA content. So maybe it can help you solve your queries, say 5 out of 10, but the rest of the 5 is completely in a limbo.
So we should be using in the cases where the count is less than 2 million? In those cases?
Ideally, yes. But again, in microfluidics, it is what to select, when to select, where to select, and how to select. That's the logic.
So that itself goes and attaches, right, in the microfluidic. The sperm itself.
I have never used it. Let me be very frank about it. Because by the time this thin technologies came, it was a post-COVID or semi-COVID time, and by that time all those peripheral things were literally on the downtrend. So it's better never trouble till trouble troubles you. It only doubles trouble and troubles others too. So
very good movie dialogues, sir. Thank you.
Okay. So can we move ahead? Arwa?
Good afternoon. Azoospermia investigation and treatment. The part of the topic has already been covered by the previous speaker and also with the discussions. So we'll see only the relevant discussion. So anatomy of the male genital tract and spermatogenesis is very, very important while we assess the male regarding the sperm problems. So the spermatogenesis happens in the testis, in the seminiferous tubules. It crosses through the multiple stages: spermatogonia, primary spermatocyte, secondary spermatocyte, then the spermatid, and it undergoes a post-processing in the epididymis, and it is released into the vas, where it collects the secretions from the seminal vesicles and also the prostatic secretions, and it is released as the ejaculate. So while we so the evaluation of the azoospermia is very important. You have to rule out collection errors and also retrograde ejaculation before you label the sample as azoospermic sample. So you have to centrifuge the sample and see the pellet, and if there are no sperms in the pellet, it is azoospermia. If there are any sperms found, it is cryptozoospermia. And again, you have to repeat the test after 4 weeks before declaring. And of late, some of the nuclear stains like cytosine and nuclear fast picroindigo-Carmen tests are used if we don't have time for 4 weeks to reconfirm the azoospermia. Even in the azoospermia cases, varying levels of sperm production are possible in the different areas of the testis. So causes, we know it is obstructive and non-obstructive. Evaluation of the patient prior to the surgical sperm retrieval. So all this has been covered by the previous speaker. So examination, if it is a small testis along with the raised FSH, it is possibly non-obstructive azoospermia. The testicular failure is the possibility. Whereas rectal examination, if it shows a cystic dilatation of the seminal vesicles, it can be ejaculated duct obstruction. So additional tests like hormones, all these genetic tests can be used, and if it's still in doubt, we can go for testicular biopsy. So indications, if obstructive azoospermia, in cases of reconstruction failed or not possible, or the patient is going in for ART procedures, so we will do a surgical sperm retrieval. Whereas in non-obstructive cases, it is challenging because it is of heterogeneous causes. So other indications are sperm retrieval in ejaculatory failure, severe oats, and sperms with high DNA damage. So basically in obstructive azoospermia, we can get sperms either from vas or from epididymis. If it is from vas, it can be percutaneous or with the help of an incision. And the testis is applied a pressure, and the more mature sperms we get. Whereas in epididymal sperm retrieval, it can be a percutaneous aspiration, which is a PISA. The epididymis is held between the thumb and the index finger, and a butterfly needle is introduced into the caput of the epididymis. In PISA, senescent degenerated sperms we get, and they have high DNA damage. Whereas in microsurgical epididymal sperm aspiration, it is an atraumatic technique. Single epididymal tubule can be sampled and sequential aspiration done. So in this we get sperms with maximum motility. In non-obstructive azoospermia, we do percutaneous testicular sperm aspiration or needle biopsy, testicular FNA, and also micro-TCA. Single seminiferous tubule extraction is less traumatic and it gives better outcomes. In cases of previous failed micro-TCA, we plan rescue micro-TCA. In these cases, testicular mapping with FNA can be done. So post-op care, we have to give ice pack, analgesics, and scrotal support because hematomas are very common, and in long-term testicular atrophies are more common. Lab processing of surgically retrieved sperms, mechanical mincing is possible. We have to do a retrieved, the retrieved tissue is placed in a buffer medium, and then it is placed with the RBC lysing buffer, and the sperms are retrieved. In enzymatic treatment, it is placed with the collagenase DNase and calcium chloride solution. The non-digested tissues are suspended and the sperms are obtained. For selection of the viable sperms, we will do mechanical tail stimulation and motility enhancers like a pentoxifillin, laser activation, hypoosmotic swelling test, and bifiltrance polarization microscope. So cryopreservation of the surgically retrieved sperms generally has poor outcomes, as Sir said, especially in non-obstructive azoospermia because of the cryoprotectant effect. Non-biological device called a cell sleeper can be used for extreme small number of sperms, and single spermatozoa freezing is also possible, as Sir said. So I will have just a few words about the male infertility also because Dr. Anuradha is not here. So the scope for medical management is as discussed by Dr. Kavita madam. It is general health conditions you have to optimize like diabetes, hyperthyroidism, and all these autoimmune disorders, and you have to evaluate inflammatory bowel diseases, etc. And if the patient is already on medications for any other conditions, you have to optimize the medications and change the doses, and you have to use maybe biologically if the patient is on methotrexate, etc. And endocrine disorders have this is the only area where we have the role of medical management in male infertility. And we also have to treat subclinical genital tract infections. And in ejaculatory disorders, retrograde ejaculation, erectile dysfunction, ROS and idiopathic male infertility, medical management has a role. So if the testosterone level is more than 300, we don't have any role of medical management. If the testosterone level is less than 300, we see the FSH and LH levels. If FSH is more than 7.5, it is hypergonadotrophic hypogonadism. So we don't have any scope. If the FSH is normal, then we check the T by E ratio. If T by E ratio is less than 10, we can start anastrozole 1 mg for 2 to 3 months. Whereas if the T by E ratio is normal or if it is more than 10, we can use clomiphene citrate 25 mg for 2 to 3 months. Because this is just to increase the FSH availability for the Leydig cells to produce and the granulosa cells to produce sperms. So coming to hypogonadotrophic hypogonadism, it can be congenital or acquired. Congenital causes these Kalman and Prader-Willi, etc. We have to rule out acquired causes, pituitary tumors. We have to take a MRI of the brain, and history of radiation, any steroid abuse. Testosterone replacement therapy is very important, and also we have to work up the patient for inflammatory processes like sarcoidosis, autoimmune hypophysitis, etc. Adult onset hypo is little easy to treat, can give just a HCG around 2000 units twice or thrice weekly, whereas in congenital hypo and adult onset which is not responding to HCG alone, we have to use HMG maybe along with recombinant HCG 250 international units weekly once. Resistant hypo if there is a history of cryptorchidism, because when the newborn is the new baby is born, there is feedback, the placental and the maternal steroids, they have been playing a feedback mechanism to the when the baby is in intrauterine life. So when this feedback is cut off, there is rebound secretion of gonadotrophins from the newborn. If the hypothalamus is not working properly, there is a failed secretion of the gonadotrophins, which is the reason for the cryptorchidism. So while treating hypo, we have to monitor the treatment by serum testosterone levels and semen analysis once in 2 months. More physiological treatment is pulsatile GnRH pump, which is not available practically. So the rest are subclinical genital tract infections. We have to diagnose the things with a history, culture, nucleic acid amplification test and immunoassays, and broad spectrum antibiotics are given. And if the leukospomia is present, we have to do peroxidase test and treat the patient with the doxycycline, maybe 6 weeks also needed. Then retrograde ejaculation, sympathomimetics are used. Imiprimine 25 mg BD is practically used. If still we are no improvement, then urine is alkalinized, or if ineffective, empty the bladder and filled with a buffer medium before ejaculation. For erectile dysfunction, combination of a 5-alpha reductase inhibitor and selective serotonin receptor blocker is used. Idiopathic male infertility, we use a lot of a combination of antioxidants, anti-estrogens and multiple vitamins. Vitamin C 500 mg, vitamin E 400, folic acid 2 mg, zinc, selenium, L-carnitine, melatonin, beta-carnitine, these are all given empirically. So zinc, lycopene and coenzyme Q is broadly used. Thank you.
Dr. Nasir, the most important question comes in mind. What is when the patient of azoospermia coming to you, patient and you advise for TESA, for example, you think that okay, TESA is going to work and you're going to retrieve the sperm. The most important question patient is going to ask, doctor, what is the probability? Are you sure we will retrieve the sperm and which will be used our own, we will be able to use our own sperm. So, what do you think? What are the cutoffs in your practice which you keep for counseling purpose or to the patient?
The chance of retrieval basically depends on the cause of azoospermia. If it is obstructive, there is better chance always, around 50 to 60%. If it is non-obstructive, then the testicular failure is the possibility, so we have to counsel accordingly. If the patient is, if the male is still skeptical regarding whether the wife to be stimulated or not, we can do a OP FNA, testicular FNA, and just check whether sperm retrieval is possible or not.
Any FSH level can prognosticate?
FSH more than 7.5, it indicates less chance of retrieval.
I mean to say, if the FSH is more than 7.5, there are less chances of sperm retrieval.
Yes, sir. More than 13 indicates like a high failure rate, but more than 7 itself.
What is any audience would like to say? Its level is little higher. Cutoff level should be kept little higher. Even with the 20-25 FSH level, you can retrieve the sperm, but the probability is quite less. And if you use microtesa, it increases the chances of sperm retrieval.
There are high lengths of spermatogenesis happening even if FSH is elevated.
Yeah. Second thing you said, flatly you refuse that, okay, there is no role of medical management when the FSH level is high. A lot of studies are coming up and a lot of people, they keep trying the empirical hormonal treatment like clomiphene, SCG, FSH, etc. Even if they want to opt for TESA also, before TESA. And there are many studies which says that even if you empirically give clomiphene or SCG for a couple of months before trying for TESA, the sperm retrieval rate is improved. And especially I was hearing Dr. Nagori from Ahmedabad. He has got a very good series of the empirical gonadotropin treatment for male infertility, and he was quite happy about the results. So sometimes, but you have to be patient when you are using gonadotropin empirically in male infertility when oligoasthenospermia is there or maybe azoospermia. You have to be very patient. You have to use for 2 to 3 months, and then you can expect some improvisation in the results.
So, but this is like giving medical treatment is not a replacement to exceed. Like, not a replacement. For oligoasthenospermia or azoospermic cases, medical management is only done to improve the retrieval of sperm in IVF. It cannot be a replacement.
Yes, I agree. What we have in poor responder, what happens? That all the follicles are having very high FSH threshold. So if you give very high dose of gonadotropin, the follicle starts growing, but most of them are harboring bad oocytes. It gets stimulated, but harboring bad oocytes. Similarly, something is done better. I mean, if you start give gonadotropin in compromised male, it definitely improves to some extent.
But even in oligospermia cases.
Yeah. See, when you, yes sir, when you give clomiphene, the criteria will be, if you give, for example, clomiphene. If you give clomiphene, after giving clomiphene for a couple of weeks, if FSH level is increased or testosterone level is not decreased, both the things, then you should continue. But if the FSH level is not increased and testosterone is getting reduced after starting clomiphene, it's a time to stop the clomiphene and switch over to gonadotropin. Similarly, in gonadotropin, when you are giving empirically, first you should give SCG. Once the testosterone level is built up, you should add FSH. Never stop SCG, you should add FSH. And such way, if you patiently give for a couple of months, then you are likely to get a better result. Sir, Dr. Kirsi.
It's my general request to all is that sometimes when we don't see a sperm in the ejaculate, we brilliantly bland the person as azoospermic, right? But ideally, you should not do this. Because there was a lot of issue at one place which had happened. Because in case of severe OAT, the sperm have a habit of skipping a sample. So many a times 2 or 3 samples are skipped in which we don't see a sperm. So many a times what we do, we centrifuge the sample, if we see a lot of premature cell, pus cells, other debris, we have a gut feeling that there's a Charlie hidden somewhere in the corner. So what we do, this process is called cryptozoospermic. Now, believe me, all of us in our dear friends or families 15 to 20 years back, we must have known some person who didn't conceive for 5 years, 7 years, 10 years. Suddenly one fine day they give us, I'm pregnant. Because what happens is, the seminiferous tubules are meters long. And at one place suddenly, at any given time, there is a spurt of spermatogenesis. So in that lucky ejaculate, one fine day we find 2 slip wobbling sperm. So please, don't write the person as azoospermic, because nowadays patients are very litigation conscious. And the most important person is 2 or 3 of your competitors across the corner only will blame you. कि देखो आपने तो sperm use किया, आपको azoospermic बना दिया. So what my request is, we write a little political report that no motile or non-motile sperm seen in the wet sample, nor the centrifuge pellet. Kindly repeat the analysis to confirm the findings. So you are sure on both the sides. Because who knows, in the next ejaculate, your lab itself will find a sperm and your old report will be contradictory. Correct? And if you find it, an occasional motile sperm found in the centrifuge pellet, but no motile sperm was found in the fresh ejaculate. So this is just a request to all of you, because one doctor had a very nasty time challenging this thing in front of the others. That's it.
Thank you. Yes, Dr.
Sir, in obstructive azoospermia, your experience with the transrectal ultrasound in diagnosing the location of the obstruction, and whether you have tried with the transurethral resection of the ejaculated duct obstruction, and whether you prefer that or whether directly TSI you prefer, sir.
First of all, I have advised trust maybe in 10 cases. In none of them there was any positive finding noted. They say that if there is obstruction, the size dilatation should be more than 1.5 centimeter. But I have never noticed, and nobody has reported that. I really doubt about the reliability of the trust done by the local radiologist. That is one thing. Second thing, what was the second question?
Transurethral resection of the ejaculated duct obstruction, if you have done any cases, and what was the response?
No experience for this. Anybody, any take on from the audience?
Sir, just want to ask that is there any role of like automatic sperm analyzer or benefit pros and cons of regarding?
Madam, first your answer.
The sperm analyzer which is available now across the country, which is costing 1 lakh plus GST, they are making it the holy grail for sperm analysis. That it is going to be a replacement for your embryologist and your technician and all that. So we called them on 2 different occasions, and on both the times there was a gross difference between the motility provided by them and provided by the technician. Second time, what they did was they replaced the kit 3 times. Now mind you, one kit costs 300 rupees plus GST. So you are wasting 900 rupees for a test which you are going to charge the patient 300 or 400 bucks. So if you don't have huge volumes, then please don't invest in that 1 lakh plus GST wala machine. In my humble opinion, it's not useful. If you want to invest, then the 8 to 10 lakhs, the fully functional CASA machine. But again, all these machines, the only advantage that you get is the kinetics of the motility, which just has a theoretical research value, no clinical value. So if your technician is doing a good job, please don't replace the technician. Rather than hire one more technician than going for a computerized machine, especially the one which costs 1 lakh plus GST.
Yes, madam.
Morning, sir. I wanted to ask if there's a role of letrozole. I'm Dr. Taswin. I wanted to ask the role of letrozole in male infertility.
Okay. So as madam, please.
In obese male, where the estrogen is in excess, we see the T by E ratio. If it is less than 10, it indicates the estrogen is more, so we have to give anti-estrogens for 3 months. 3 months. And
has to flow.
And another question is, in our history, sometimes when we look back of patients with male infertility, we often find that these patients have had surgery in their childhood, especially inguinal hernias. Anybody who has an experience with this, is there any correlation of inguinal hernias in childhood surgeries with, they come with severe oaths or azoospermia in their adulthood? I've seen about 5-6 patients till now, so I just wanted to know your experience.
The vas can get
Yeah. If the vascularity to the vas was impaired at the time of surgery, it is possible.
Yeah, that is possible. Especially if it's done, in a government setup, nothing to do with that, not so.
And the role of scrotal ultrasound when it comes to male infertility.
Varicocele, you have a patient with severe oligoacinospermia, then other than all the sugars and thyroids and
What about for testes atrophies? Is there any cutoff that we say that the retrieval rate may be less? Because there are a lot of patients with secondary, coming in with secondary testicular failures.
If the FSH level is more than 20, the chances are that at micro TC you might get a 10 to 20% retrieval rate.
Yes, so do we always correlate with the ultrasound of the scrotum? Also
not really. If the size is small, if the size is genuinely small, you do a scrotal ultrasound, but then that's not going to help you. Right? Scrotal ultrasound is perfect to diagnose hydrocele and more importantly varicocele. Yes. We've got a series of patients of varicocele operated on this technique. I must acknowledge Dr. Mahesh Jariwala from Ahmedabad. You have a patient who's got a grade 1 varicocele. Grade 2, grade 3 is a no-brainer, you need to operate. But grade 1 varicocele also, what he was very vehement about is that these are the guys who get affected. The sperm count, the motility, and especially the DNA damage is far more in men with grade 1 varicocele as well. And we ourselves have now done laparoscopic surgeries for them. A few of them have conceived on their own, trust me. Dr. Sachin Patel is also here, he's also had an experience. Dr. Amle, any experience about laparoscopic varicocele? Yeah, 2 cases. So that has worked, and at IVF, at ICSI, the success rates are much better.
So you need to say any varicocele should be operated.
If you've done everything and it's not worked and the patient is compliant for surgery, do that because
they do come and ask you for surgery because in Google that's the first thing that pops up.
So laparoscopy varicocele surgery is a very easy surgery to do. I'm not getting into the litigation part or the medical legal part. We have our surgeon stand by. I do the surgery. The surgeon is there just seeing the surgery. But then it's a very easy surgery done in 20-25 minutes. If it's a unilateral varicocele, do unilateral. It's a bilateral, do bilateral. But the results are much better after the surgery.
Do you advise semen freezing before doing a varicocele surgery?
Always. If you have a patient who has a varicocele or even a severe oligoacinospermia, you always go semen freezing. It doesn't cost anything because you really don't know what is going to be the factor. Yeah.
So coming back to your question, role of ultrasound. So what happens? It's like we become quite lazy in doing PS examination, prospective examination. So similarly, I am quite hesitant to examine the male, I am telling you.
Okay.
It's not right. Ideally, you should examine and because to judge the size of the testes is not difficult. Yes. To palpate this vas is also not difficult. But somehow,
You somehow don't do it, and being females, I think the stigma is more.
So we send for, in compromised semen, we send for ultrasound. At least we get idea about the size of the testes and varicocele and all those things.
And with a gloved finger, with a gloved hand touch me, it's very difficult to make out even a grade 2 varicocele, especially when we've not been trained to do that.
Yes, that's good. Thank you.
Cutoff is 7.7. Madam is suggested 4 point something. You said
4.5 centimeters.
4 point. I think 7.75 ml.
Yes.
So less than
4.5 centimeters.
4.5 centimeter diameter.
Maybe I may be wrong.
So I have a doubt. So in case of hypogonadotrophic hypogonadism, we are starting the gonadotrophins and the patient is responding. Probably pregnancy is achieved. Then how to maintain the therapy? Should the patient be on stop? Because in some literature it is given as
patient has come to you for fertility. His lifestyle is not getting affected.
Because sterilization, all these things.
At the age of 30, where is the question of sterilization? It's already done, right? You're not talking about a child, you're talking about... So, I'm sorry.
So it's like a full-grown adult who's coming to you, and on a sperm analysis you found a severe oligoasthenospermia or a azoospermia, but this guy is completely built, right? So once the pregnancy is achieved, there is no role. I mean, it's like, debating something like if you have a patient who's borderline PCO or a mild to moderate PCO, once she's got conceived, would you continue metformin for the life?
No.
So similarly for the male, because 3 times a week HCG injection, the logic is not appropriate.
Thank you.
Once pregnancy is achieved, you can continue testosterone for the other aspects, sexual drive, virility and all that.
Not in pregnancy.
No, not in pregnancy. After that.
Thank you. I think we break for the lunch, I think. And further.
We break for lunch and 2:30 we start off. Dr. K.C. Avri, one of the senior most embryologists, is going to be taking the first post-law session, 2:30 sharp. It's exactly 1 hour for lunch. Thank you so much.
Because I want to put my 3 topics into one. Because ultimately, otherwise they would have just overlapping each other. So 10 minutes, I have put them into a pool of 30 minutes. And at the same time, slides have also been restricted because each topic will incorporate slides to the tune of 50 to 60. So it was a little challenge for me to filter out the slides and present the best ones to you. Okay? Fine. So before we just come to it, when we are dealing with embryology, what we say as the fusion of the 2 cells of the body, the largest and the most sensitive cell, that's the oocyte, and the smallest and the most motile, that's the sperm. And both of them just post-fusion do not stop over there. They have got a procedure to do what we call it as subsequent viability. So thereby lies in the challenge that what we need to get is a viable, transferable embryo or a blastocyst, either at the end of day 3 or at the end of day 5, which is totally non-traumatized, into a healthy receptive uterus, followed by a post-luteal support, which of course is not the embryologist's purview, but the success of an embryology in a laboratory is to see that he or she should not be happy by just having the fertilization or just having the embryo or just having the blastocyst. The ultimate test is pregnancy and a take-home baby rate, which unfortunately 99.9% of us don't do. It's very difficult to follow the take-home baby rates. So what we are having is, we are just happy with at least a cardiac activity which is seen, which will definitely ensure us that there is a live fetus. Now, in order to mimic the things, vivo to vitro, it's very difficult for us to maintain. So, the complete embryology scenario is divided into what we call it as your embryology laboratory, which needs a great amount of precision to be incorporated or to be looked into. Right from the construction, the maintenance, the equipment selection. So the thing is, when do we panic? Because as long as everything goes fine, we are consoled. Kuch nahi hai, it's going smooth, but suddenly when there is a dip, we start the blame game. And usually what the blame games are? Blame the media, blame the incubator, blame the embryologist, blame the lab. But unfortunately, I have not seen anybody say blame the gynecologist for providing suboptimal samples. But the embryologists say that. That's the reason. No.
My daughter never says they oocytes are
That's your family frequency matching each other. So what I think I have only 30 minutes. So what I would suggest to you is that your embryology work is a diversified work between 2 aspects. There is the wall in between, the clinical aspect and the embryological aspect. And many a times when each doesn't know the other, I fool you, you fool me. That thing goes on. And at the end of day 5, and how many embryos? Pathetic. Because the embryologist is scared. If he tells from day 1, unfortunately he'll be finding losing his job.
Simple as that. So he just keeps from everything is good, good, good. Now the thing is, why? Because today, enforcements and guidelines have been set up. So my humble request to all of you, whosoever with the intentions of setting a lab is from today, please look out for a junior embryologist or a fresher. Because setting a lab today is child's play. Let me be very frank. Everything is available at the drop of a hat. Initially, we had to literally board our souls out for this, for the media, for the disposable, for the infrastructure, etc., etc. Now, what is important over here is that we have to follow this embryological time scale. Now, many a times when people tell me, sir, 4 cell wala embryos bahut acha, main kya karu? I was telling what is the age. Now, age is what? The time when the embryo develops from the either insemination or injection. So, at the back of your mind, you should be having this notion and concept that fertilization is 18 to 20 hours, first cleavage is 25 to 27 hours, 38 to 42 4 cell, 48 to 52 6 cell plus modulation, compaction, 3 stages of blastocyst, cavitation, expanding, expanded. If this falls in your slot, then your procedures are perfect. So according to an embryologist, whosoever even is a visiting mode, he or she should be having at the back of the mind that what an ideal cycle for an embryologist is 12 to 16 OCCs, out of which 80% should be metaphase 2, and from those metaphase 2, 85% grade 1 embryos, when transferred atraumatically, well-receptive endometrium, the lady has a 40% chance of implantation. That should be always at the background. Otherwise, you collect more and then you blame the system. Agree. Many a times systems are to be blamed because what happens is with the advancing technology, we have become too complacent. We just think that things will never go wrong. And remember, the costlier the lab, the heavier the gadgets, doesn't mean towering your results. It's a big misconception. So don't make your lab a storehouse of all the latest developmental gadgets and the next day you publish it, the first lab in this area to have this, oh my gosh, my results have gone up. So many times we ask them, equipment ke pehle kya hai? No, equipment ke pehle tha, lekin abhi bahut badh gaya hai. Abhi now what that bahut is, we really don't know. Correct? So what happens is it doesn't take time for the castle to crumble. Now, this is important. Gametes culture can still develop to perfection, be ideal on the time scale, but still they could be underprotected. That's very important. So many times we say, excellent gamete, perfect, flawless, no fragmentation. Why the hell the concealment is not taking place? So, quality selection interpretation is challenging. So apart from general morphology, we are still short of any other criteria. The reason is, we don't have any test, small biological, biochemical or genetic to raise the potential of a gamete. So till today, ideal sperm, ideal oocyte, ideal embryo, ideal blastocyst is an enigma. We cannot say with impunity that this is the best one. Anyway, so what happens when we are setting a lab? We have to take care of all these agents which are known as the epigenetic agents. Now what are these? They relate to or arise from non-genetic influences. Now, if I was to talk about this air quality and blah blah blah, 15 years back, everybody would have laughed at me. ये क्या बात करते हैं? हवा से क्या कुछ फर्क नहीं होता है? ये हमारे लैब में तो ऐसा रिजल्ट आता है. But as time goes by, there is not a single conference which doesn't have 40% of lectures devoted to this. So apart from this, these are all your contaminants, physical, chemical, biological, and energy, which hover around us, but which are not detected. So many a times, it's like a blind man looking for a black cat in a dark room. The problem really lies in front of us, but unfortunately we are not able to tackle it. So what we do? We have to follow guidelines. And in guidelines, it is total quality management. There are guidelines stated over here. And we follow these 3 steps: control, assurance, and standard laboratory practice. Because remember, we have a tendency of just following or copying the overseas stuff. ESHRE guideline, this guideline, that guideline, but many a times we fail to improvise ourselves what is wrong in our scenario, in our locality, in our lab, in our place. There are so many conditions which might not be adhering to both the places. We might be a little different, so we have to adjust as per our conditions. So the first thing is that people try to build a lab. Everybody, it's in everybody's aura that, oh, people, pardon my saying so, I have seen 3 types of categories who want to build a lab. You are genuinely interested in infertility, I want a lab. I definitely head a big organization, so I ought to have a lab. And my neighbor has a lab, so I want to have a lab. So these are the 3, I would say, factors which motivates you in getting into a laboratory. But building a lab is not all that easy. The trouble is, we have to mimic the in vivo and vitro conditions. We have to harvest the cell from the body, acclimatize them, culture them, procreate them, without having any minimal stress, which is not detected by us. That's the logic. That's the reason many a times, best ones don't give result, and the worst ones appearing morphology give us the best result. Be it the sperm or be it the embryos. So initially what was there? Labs used to be set up in any residential complexes. The drawing room used to become a pickup room, the kitchen slab used to become embryology lab, but now the conditions are different since the guidelines have come. The reason is why? Because what we have is a sick building phenomenon. Means there can be certain problem hovering in that area or the locality which is just preventing you from getting success. So most important is this: inadequate ventilation, chemical contaminants, indoor sources, outdoor sources, and it's very difficult for us to pinpoint any one of them. So location is of prime location. I'll give you an example. In EUTDC standard in Europe, labs are like big tall buildings, complete institutions. They are built outside the outskirts of a city, in clean, pristine environment, just like this resort is. And at the same time, there is a guarantee taken that for the next 5 years, within 1.5 kilometer radius, no construction work is going to come up. This is called restrictions. And how it is built? Earthquake-proof building, fire-resistant material, escapes. Now in big virology labs, even it is aerodynamically shaped to prevent the oncoming current of the severe winds. You get my point, because cell lab doesn't mean only embryology. It means virology and bacteriology covered, and all the consensus which we are drawn are from these labs only. So when we say about selection of the materials, initially we were using anything and everything. Now we have to be sure that the materials which we use are least embryotoxic. So tiling, wood-based furniture is out because varnishes, polishes, formaldehydes. Gypsum, asbestos sheets as false ceilings, not possible because they absorb and saturate the moisture. PVC, carpeting, linoleum, no, because the adhesive which we stick releases VOCs. Paints release VOC. Liquid floor polishing, wooden mattresses, no, nothing. So selection of materials. Now today the best one what we select is, reason why? Because in the longer run, these things slowly release their toxicity into the air. Now this makes air one of the most important and challenging criteria when you are setting your lab. Because there are two. You have an ambient air outside and you have the laboratory air inside. Now outside air is environmental air, which is usually by normal pollutants, carbon dioxide, carbon monoxide, sulfur dioxide, automobile exhaust, and fossil fuel burning. Whereas the laboratory air is toxic. Why? Because it has chemicals. And believe me, the lab air is more saturated. Why? Temperature. Now all these VOCs, COCs have got a very light evaporation and boiling point, so they evaporate in the air faster. But in the lab they are prevented because the temperature is cold, so there is saturation. That's why no scents, perfumes, aftershaves, deodorants in the laboratory. Now what an irony. Incubator provides optimal temperature of 37 for all gametes to activate. But what's the lab temperature? 27. So in order to maintain the equipment which supports the cell, we have to compromise with the temperature. Now why are we keeping the lab temperature cold? Why can't we keep it at 37? Any guess? No, the reason is the equipments which we use are exothermic equipments. Now incubators and all, they will function well. There is a temperature flux of at least 6 to 7 degrees. That's why you see your X-ray machines, your scan machines, supercomputers all in AC rooms. So the first thing towards our new barrel incubator is temperature difference. Immediately there is a temperature flux difference, it will show the reading. So this is reason why we have to be very precise about the temperature and the in-house ambient circulating air. Now air, as we know, ambient air is this. This is an ideal criteria, but at no place only these criteria are there. There is a lot of saturated, inbred, or I could say intruded pollutants in the air as such. And we are using our outside air. We are not generating our endogenous spatial air for the laboratory. Because air saturated with VOCs and embryotoxic substances can compromise with embryogenesis, implantation, and subsequent conception. So this is what exactly the air characterization may be. Your lab air, howsoever excellent it might be, if you take a photochromatic graph, you will find all these agents present in it. Okay? And a new incubator has more than 100 times the concentration of toxic gases. Just like you buy a new refrigerator or a new cupboard, the aroma of that, I would say, so the smell induces you, oh, it's a brand new, kali liya, kari kharida, kahan se kharida, you know, all that blah 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 when we try to show off to our fellow colleagues. Okay, this is the new piece which I bought. What is the smell of? It is the smell of the VOCs of the paints which slowly evaporate down the line. Okay, now the same thing happens. So what we are going to do? That's why what we call it as, another thing is the burning technology. So whenever you have the lab set today, you can't use it for at least 2 to 3 weeks. And that time is known as the burnout period, during which you will be running all the equipments verbatim per se so that they get rid of that in-house saturated VOCs and the COCs. So coming next was a room, what we call it as, an ideal environment. So this was catering to the clean room technology. Now these are the parameters which a clean room technology ought to be having. I won't be talking, I think you can just glance it for yourself, or I don't know, you may be given this PPT as such subsequently. So the best one is, of course this is a little costly, the modular room. These are the benefits. Because what is the biggest hurdle? Daily cleaning. There is virgin cleaning once you set your lab. There is routine cleaning, there is daily cleaning. There are 3 categories of cleaning pattern in a laboratory. Now this is what we discussed of, the burning period. What does it do? Burning supposedly burns off the embryotoxic volatile organic compounds or the VOCs. Now, it's an example. Inside a newly painted and a confined door space, the VOCs can be 10 times higher than the outside. Got it? It's like, imagine we buy a rubber slipper. How many days you will still get that aroma of that rubber or the smell of that rubber? If all the VOCs in the rubber slowly evaporates. So this inevitably we call as a burning period. Now absence of burning in the incubators results in exposure of embryos to the VOCs, thereby compromising their progression. That's the reason even in your lab sterilization, formaldehyde fumigation is an absolute no. Formaldehyde fumigation is like cyanide to a cell. So what we are utilizing there also, it will be just coming in the subsequent slides. So what we care for? Techniques is available, technologies are available, but in IVF when you go for technology, it is willpower versus willpower. And I'm sure those who are heavy in pockets, they can afford it. But remember one thing, these things are not promising you a result through the stratosphere. Ultimately, at the end of the day, these are the best gametes what you are given to handle. The way in which they are handled, the person behind handling, the dexterity and the skill. Skill of what? Not only the embryologist. The whole team of ART comprising of gynecologists or infertility specialists, embryologists, anesthesiologists, sonologists, pathologists. Correct? So this is a pooled effort as such. So in high places, big centers, corporates, we have got the way in which air is handled. Now AHU is a centralized air handling unit which is extremely expensive, and the whole system can be classified as HVAC, heating, ventilation and air conditioning. So before you set your lab, before you even plan out First thing is make arrangement for the provision of HVAC. Correct? Or in a simplified version, in case this expensive gadget is not affordable, of course it doesn't suit anybody's pocket. And remember, in setting up of a lab, please cut the coat of your size. Because initially everybody gets into a hype, the expenses shoot up, recovery becomes difficult, the frustration sets in, and this ultimately leads to suboptimal working practice. Cost cutting comes in only when, because at the end of the day, it is economics that matters. Howsoever people say, "नहीं मैं तो खाली charity के लिए करता हूँ," अबे सब लोग charity के लिए करेगा तो कमाएगा कौन? Somehow that concept is also there. Fine. So this is now much advantageous, a positive pressure. So if your lab is over here, there is a small room, what we call as a utility room, into which the positive pressure modules are there. They pump in air, as a result of which what happens is that any problem inside regarding air is flushed out and there is no entry point for them once again. The resultant saturated air is recycled back. Now this recycling is extremely important. Why? An embryo incubator, how much percent carbon dioxide it has? 6 or 5, either of the two. And how much ambient carbon dioxide is there in the air?
0.03%. 0.03%.
103%? Okay, fine. Now remember, every time you open the door of the incubator, 5% carbon dioxide is pumped into the laboratory, which has an area of 15 by 15 by 15. So there is saturation. Believe me, myself also has undergone this trauma where the positive pressure was not there. Working for half an hour is okay, but more than 1 hour, it really leads to stress situation. So what we need is, we need to recycle this out. So this is known as an air exchange. So any laboratory should have a possible or a very good air exchange facility of at least 10 exchanges per hour. And this is generated by this. Here the air comes in, here the air is sucked out, there is an outlet. So the same air is not recirculated. There is always a replenishing. On paper this looks nonsensical, humbug. But when it comes to actual involvement with your results, because believe me, I had worked in places years ago. One was in Dehradun and one was in Jagdalpur. Going there was itself a trauma. We had to undergo to such that Maoist infested places. But labs were damn simple. Believe me, no high-tech facility. But the embryos which were produced now, fantastic, crystal clear. This tells us that air quality does have an impact, howsoever we are not ready to believe it. Why are we not ready to believe it? Because we are not ready to invest. And why we are not ready to invest? Patient ही नहीं है मेरे पास. Patient नहीं है तो भैया lab क्यों डालना? You know, that's a rebound question which comes to you. So then we come to, as far as VOCs are concerned, we come to cleaning solutions. Please use cleaning solutions which do not give out any organic toxic fumes or residues. So no phenyl, no Lysol, howsoever excellent in the odor capacity they might be. Now this is what your contact, what we are doing is contact cleaning. Whether it is 10 seconds or 20 seconds or 30 seconds. This is the elimination capacity of many of very good agents. Now, much in the market is silver, dihydrogen citrate, because it deactivates the structural metabolic protein in the bacteria or the virus, whatever it is. This lifebuoy with silver, that's the reason now silver is impregnated more and more into any detergent things. Another thing, effect of light. Don't make your laboratory a wedding hall. Selected lights at selected places. The bulb should also be having a low UV content. I always advise people selected spots with a dimmer facility. Because remember, our human embryo is in total darkness till it comes out, delivery post. Whereas when we are doing embryology, these are all the procedures where we need light. Now light also has spectrum, the visible, the infrared, and the ultraviolet, both have rich band. This is a little safe zone. though some people say that harsh light penetrates and deactivates the DNA component, but the real trauma is it can affect the quality of the culture area. So many times we have seen people who do close culture, thinking that they have put oil so they can suffice everything. But no, you are compromising everything. Agree. The closed culture is like a triloid box. It prevents the entry of external environmental hazards. But temperature can drop down. Subsequently, pH can also drop down. And if you keep in the incubator, the time of recovery is more prolonged than had it been an open culture, because oil creates an extra barrier. So these are unknown things which we many a times tend to overlook. Preparation of 7 to 8 dishes all in one slot. Preparation of the dishes when the laminar flow is on. What will happen? Air is cold, laminar flow will pump in the cold air, so the quality of the material, the quality of the droplets will compromise. This is very important, especially during vitrification, where you need your solutions, the warming solution, the vitrification solution, and even that the quantity is important. Though they write 300 microliters, what do David Gardners of today do? Sir, मैं तो 2 ड्रॉप में तुम्हारा पूरा कर दूंगा, तुम्हारा किट 6 महीना चलेगा. But यहाँ eggs compromise हो उसका क्या? Because osmolarity is extremely sensitive. The moisture which a droplet of 7 microliters loses is not directly proportional to the moisture which a 300 microliter media loses. So all these things have to be kept into consideration. Now, technologies. Technologies are galloping, but it doesn't mean that they are all useful to us. Many a times they are just an added buffet dish on the buffet table of the tests which we are giving to the poor infertile patient who is always under financial, mental and physical stress. So I would prefer these things to be a little worthwhile. Time-lapse, vitrification, witnessing, genetics, and of course, last but not the least, even AI is now on the doorstep. But what was ironical? What's the opposite of natural? Artificial. So when given a choice between natural and artificial, what would you choose? Natural. But here there is damn intelligence over there. So now what would you choose? So this is what has brought us into a quandary as such. It is still in an infertile condition. Some swear by it, some are not ready by it. Now, in time-lapse, what were the limitations? Now you say 4-cell embryo at the right stage. Perfect, fine. You know, but the implantation potential will lie on the time at which the first division into a 2-cell took place from a zygote. If your embryo cleaves at the right time, then the subsequent viability is excellent. Now, unfortunately, we in our labs can't do that because we are doing this limited time lapse. Whereas an actual time lapse will monitor the whole sequence from A to Z, but at a cost. But still, it is not guaranteeing any positivity. Mark that. Fine, then, in a cohort, all embryos don't live at the same time. Microscopic intracellular inclusions go unnoticed. In progressive development, the grading can alter within minutes, which you must have seen. When you prepare the cleavage dishes at 4 p.m., it may be 6-cell plus. When you do the ET at 7 p.m., it is 10-cell plus or early compaction. These are the signs of perfect viability. Enhanced trauma can be there if subjected to multiple observations. We have a tendency. आधे घंटे के बाद निकाल के देखो कितना प्रोग्रेस हुआ, कितना प्रोग्रेस हुआ. Now suppose you are transferring a blastocyst, you found out, oh, what damn, it is starting to hatch. It's not gonna pop out immediately. It's gonna stay there, it's gonna regress, it's gonna come out. So what do? We keep on observing them at a few minutes, which is equally lethal to the trauma. Because the blast implantation potential is 60% compared to a day 3 embryo, which is at 40%. But the sensitivity is sky high. And the trouble is, in a developing embryo, you can see the progression. 4 to 6, 6 to 8, 8 to modulation. In a blast, what can you see? Just an expansion. Or the thinning of the trophectolome or the compacting of the inner cell mass. Now this time lapse was there. It's like a stepping stone towards further development of other non-invasive ways of saying. Because another thing is, 30 minutes completed? 28 left, oh shit, I'm going to go fast. Anyway, so for ideal embryo selection, these are the parameters which you should monitor fast. Okay? Now came vitrification, because in thawing, remember, you recover, you check whether it is surviving, or you check subsequently whether it's viable. So in any freeze and thawed embryo, what we used to do, if an ET is tomorrow, we used to thaw it today evening, tomorrow see the progression, then we confirm it's a viable embryo. Fine? This was the differentiation between vitrification and slow freezing. These are the advantages. In vitrification, still, there exists a risk of toxicity of hyper-concentrated propanediol, which will be noted in second to third filial generations down the line. Till that time, we are unclear. Advantages, we all know, safe and fast. Then came genetics. EGD, this, that, biopsies, blah, 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 blah. List is endless. Fine. It is to be done in case of patients having a family history, age factor, which you gynecologists should be more aware of, and when to see for the subsequent symptoms. These are the congenital anomalies, the single common gene disorders which are more prevalent. But there can be errors. Now let's see, I'm doing a biopsy of this blastocyst. I'm doing from this area. It is 2 cells out of 5, 2 are normal, some are abnormal. I'm doing from this area, I'm getting this biopsy in which all are fantastic. I'm doing from this area in which all will come negative. Now what's the choice for this? We don't have an option. So these are the human errors which can creep in. Witnessing, most important. Sample mixing is never ever allowed. Even at 0.1%, it is not tolerable. Cryo-labeling, why it is done? To ensure, of course, as I tell you, all technologies come at a price. And still in this also, it's the person behind the technology who holds the key to success. Remember, even a robot, it needs programming by the human first, before we go into it. So some technology and saying, many people say, oh, you are not cool if you are not having this technology. Because promotional techniques are great. We get mesmerized by it. So what I would say is that these are mere add-ons. They are never ensuring a fertility or an implantation or a pregnancy. They are optimizing the chances of a gamete getting fertilized. Now, there is remote patient monitoring, digital therapeutics, technology in mental health, Internet of Things, and this is what the last, artificial intelligence. But a cautious rail. Please, we are being successful? No. There is a big enigma in implantation. There is a big enigma as far as fertilization is concerned. So these are the two medical marvels for which we have no control. We just have to assume and presume and subject our gametes to maximum optimization. I think this should be the last one. Otherwise, I'm sorry to say, I have to really compress the proceedings in a very short time. Otherwise, each topic would run into hours together. So intricate is the issue.
Sir, thank you very much, sir. It's a really wonderful. I'm really speechless to see the amount of material you put in the website.
So that's the reason I had 4 fly sites, so I compacted them into each. That was the logic of 3-4 slides into one. I can't show everything to all.
We have presentation in the laptop, no?
I have given it to yesterday.
It's very good. Sir, sir, I would like to ask you, which is the ideal disinfectant solution for the cleaning the lab, as per your opinion?
See, to be very frank, way back, because the first sperm I saw was 21st March 1991. That was under the auspices of Dr. Ramavedya. Dr. Rupin Shah was also quite a young lad by that time. So he had made me see at a clinic in Santa Cruz. And then we were trained by people from Australia, Sydney IVF people. I mean, sorry, they were Melbourne IVF, MIVF. The first center with Dr. Manish Bankar started with the Australian concern. So they had told us, because at that time the technology was still at a grassroots level. They said, okay, you can safely use 70% isopropyl alcohol and 20% sterilium and distilled water. If you have it, nothing like it. People today on the citing of alcohol, oh shit, alcohol, VOCs बढ़ जाएगा. That's typical textbook knowledge. Usually we always say, na, "Arey, you bifurcate the sperm with a mini syringe, needle is so small, you traumatize the sperm." We ask them, "You do ICSI? Arey, ICSI तो 15 साल से करता है. You know the diameter of an ICSI injecting needle? It is 20 times thinner than that." So these things, if you have it now, they are perfect. Then there is a huge, I would say, media available for the cleaning agents, but they are costly, sir. They are very costly. You cannot utilize for the whole lab as such. Maybe you can select some and just use for your clean laminar airflow with limited use. But in some agents, I have found them, they leave a little whitish residue at the end of the day, which is very difficult to remove it out. And in an urgency, people try to scrape it off the laminar flow table or from the inside of the incubator. And what do they do? In the overwhelming scraping, they scrape off the buffing of the stainless steel. You got my point. So that's a contra-con damage what they do.
People are talking about 7% neutral detergent cleaning.
Detergent, so no, it's bad, sir. Detergent basically is bad. Now what previously we used to get 7x or Lax Bro. That was a detergent used in microbiological labs. But in microbiology, at the end of the, you are going to throw the petri dish develops fungus into the dustbin. Now you can't afford it. We have to be responsible for each and every oocyte which we recover. That's why we were taught in 4 well dishes with labeling, so you can monitor each oocyte at the end of the day till 5 days.
Sir, I must be sure this question must be asked to you 10,000 times by 10,000 gynecologists. There is always a debate regarding ICSI for all and IVF for all, or ICSI for all and
indication wise.
So just wanted to know your opinion if the sperm count is bang on.
I will definitely 101%, like 120% I will go for IVF. Exactly. And that's it what is today till I am practicing everywhere with fantastic success, because you all know, in your heart of hearts we all know that IVF embryo is the best. It's nature's selection, how the damn can you debate on it? If you are getting excellent M2s and your fertilization rate in ICSI is 80 to 85%, then your culture conditions are as similar as the intrauterine conditions. Because in ICSI, fort rates will be 95% because you are physically and manually putting the sperm in the egg, right? Now in IVF, all the eggs won't be of the same maturity. So IVF percentage fertilization is 80 to 85%. But the cleavage rate in IVF from those zygotes should be 95%. Whereas the cleavage rate in those injected is comparatively less. Many a times you see deterioration, degeneration, fatty degeneration, nuclear degeneration of zygotes. Now this happens, I was listening to the morning talks in poor quality eggs, in very less ovarian reserve. Till you harvest, they look beautiful. But once you inject and keep it, within 1 hour they shrink. Because as long as they are inside, the tons of hormones which we have pumped in are maintaining the integrity. The moment they are plucked off, that supply is cut off and they start degenerating because they are not getting that much worth of the nourishment, whatever it is you call it as. And even in such cases, when you grade a zygote, many times you just see an expulsion of a polar body, you say metaphase to hash khatam. No, you have to judge the size of the polar body. You have to see the ratio of expansion. If a polar body is big, already there is aneuploid. There is not even a worthwhile doing ICSI. So every cell has a stage and a grade. It can be stage 1, but grade 3, just like in embryos.
Sir, as a clinician, all of us, this question always keep ringing in the brains of the clinician. Being a clinician, we always want to learn. When everybody says the oocyte quality is not good, can embryologist guide us modification in our stimulation protocol, modification in the drugs by just looking certain characteristic, morphological characteristic of those sites?
Very true. This can be easily achieved provided the embryologist has a fantastic knowledge of endocrinology of male and female reproduction. That's the first thing. Right? Because if I don't know, what am I going to preach? Right? So we just ask the because we are fed with some basal parameters. Now believe me, as an embryologist, what I do is still today judge the quality of the shape of the things to come just from the color of the aspirate. The first tube comes which is straw yellow colored fluid. I am happy, clean peripheral fluid, because one leading follicle, it will give you a aspirate of 4.5 cc. But one comes clear, second comes clear, third comes clear, there's an alarm bell. I used to shout at the person who was doing the pickup, the boss, she is going empty. So no granulosa cell, absolutely clear, straw yellow color like urine, maybe the HCG has failed. Or granulosa cells, but no OCC, or OCC but no egg inside, empty follicle. Or the slimy, the follicular fluid is still in the proteinaceous condition, sticky, just like an Alpenlibe chocolate, the red one with the white stripes. It is proteinaceous. It has not culminated, or the HCG action has not taken place properly. 99.9% you will get metaphase 1 oocytes. Now this could be a reason of poor drug selection, dose selection, poor patient recruitment, because what used to happen in our times prior to each cycle of our gynacs, and we all used to sit together and discuss a case. इसमें ये हो सकता है, इसमें ये मिल सकता है. अभी तो क्या, there is no discussion. I come into your lab, I don't know what the hell it is, नहीं मिला, 1, 2, 3, 4 finish. Just like a person who बैंड वाला आता है ना, शादी के टाइम पे बजा के 2 मिनट में चला जाता है, that's the thing. I collect the packet at the end of the day. Thank you sir very much. Next day you phone भाई embryos ही नहीं बने, eggs नहीं करते sir. Then next thing you call somebody else. हाँ ये मीडिया ना, कहाँ से रिजल्ट मिलेगा सर, तो ये मीडिया ट्राई करो. So you know it's a lack of knowledge sir.
So in other words sir, for example, to make it still more simple, higher dose of gonadotropin, suboptimal dose of gonadotropin, more LH activity, suboptimal LH activity, agonist trigger, SCG trigger, antagonist suppression, agonist suppression.
Sir, आप मेरी परीक्षा ले.
No sir. No sir. Just really
I tell you.
So now these are the things.
Yeah,
Can you differentiate? Okay, the agonist
no,
sites are looking like.
We were differentiating from the patient's conditions. Okay, she is a poor ovarian reserve, she is a PCOS, where there is a huge number, but next day at the back of my mind, I will be shocked about fertilization will be hardly 10 to 15%. So all these things were made known to us. But the trigger and all, it's a later on thing which has developed, say, 4 to 5 years back. Prior to that, which was not much into debate because we used to standardize, they follow the long protocol. That was the best of it. So we used to prime our cycle judging from the day of the ET and then you go back.
So last question. Have you noticed any difference in the progesterone? Because nowadays a lot of people are using progesterone prime protocol. So have you noticed personally any difference in the oocyte quality?
Since you are very frank, even I am very frank, since that time this has been introduced, my work is comparatively less. Because since COVID, my work was literally now it is mostly into teaching and troubleshooting and person who set up the labs in the first batch just to be present over there to see what is going wrong, what is right, and to help motivate them, and number 2 to train the junior embryologists. That's my motive. I don't want to stick with any gynecologist for years together thinking कि नहीं उसका छोड़ेगा तो मेरा bank balance कम हो जाएगा, वैसा कुछ नहीं है. Then my love is for simply for teaching.
Anybody like to comment on that?
Sir, I want to ask one question. Sir, excellent.
Please speak.
I can hear you, no problem.
Yeah. Sir, I wanted to know if
Speak
you have
loudly,
done
please.
2 or 3 or 4 pickups. If you have done 2, 3 or 4 pickups
Mike,
and
please.
2, 3 trays and dishes were normal, but suddenly you find infection in the 4th one. So how do you treat that?
Is it infection post sperm addition or prior to that?
No, post
ICSI. Post ICSI, so that means...
Yeah, day 3 when you're searching, as you said,
yeah,
then visiting embryologists.
Now see, that's the reason I always tell people not to do single pickup in a day. Because then you are not able to pinpoint what the problem is. Now as you very rightly said, I'm doing 3 cases, but in the 3rd case I found an infection.
Yes.
Right?
Yes.
So there may be a little difficulty or maybe a embryologist's mistake whereby the contamination has come in, or maybe the sperm with which he injected that the preparation was suboptimal.
She was a case of PCO, so could be a longer time.
No. उसके साथ उससे कोई relation नहीं है. Because see, there are contamination, is inbred contamination and peripheral contamination.
Yes.
Now 90% when in IVF we used to see contamination was, where in case of sperm preparation by the juniors or the freshers who in a hurry scurry, they don't try to take it from above the pellet. So this comes in. Now the sad part is we used to see this contamination on the day of the ET, because the incubation time is 48 hours.
Yes.
So this is typically of a UTI. Now if you see infection as threads,
Yes.
this is aerial fungi contamination. That means your lab health is poor.
Okay.
So during the denudation or whatever it is, it has saturated, the airborne spore saturated into the media, and we are giving them 7-star treatment with perfect temperature, incubation media, so they grow with a bang.
So
You got my point.
why not the other 2 or 3 which we did together?
Maybe the problem was not there, or maybe,
No, you can't.
no, but then the sperm parameter, see, whenever you recruit any parameter for the sperm, you should do analysis, a trial wash, and a 24-hour survival. That will tell you the health of the seminal plasma also. Because if you see contamination in the 24-hour sperm survival, that means that sperm is infested with higher colony-forming units of bacteria. You got my point. Now the same which you are going to inseminate in IVF is going to remain there for 24 hours prior to ovulation. So there are chances of multiplying it over there. Or maybe, or there was a case in which a fellow of mine, I'm just taking 1 minute of your time, sir, because this is an important parameter, I'll tell you. He said, okay, my last IVF batch went complete failure. I said, why? They all developed contamination. Now, that was too strange. The first thing I asked him, were you changing your denudation pipette between 2 patients? He said, no, but I wash it. Well, how the hell do you mean wash it? The guy rinse it. And well, rinsing doesn't remove the bacterial content. And luck didn't favor him on that day. The first dish which he denuded itself was contaminated. So 1, 2, 3, 4. So just for the sake of saving 700 to 800 rupees of a flexipet, the whole patient cycles got screwed up. So many a times, I would say 90% of the time, is the misnomer of the embryologist, sorry to say. Otherwise, it cannot happen that 2 dishes escape and the 3rd dish inculcates. Or maybe your oocytes, when they were harvested, there was a contamination in that lag phase. That also could be there. Maybe the blood was not removed, the blood clots were adhering to the cumulus, so the cumulus dissection was not done proper. That also can be there. For a take-home baby rate, there are 155 parameters, out of which we are handling only 30. Gobi GIG. GIG means God is great. So I think it's like that.
Thank you, sir.
One question. Those who are starting in the IVF and the numbers are less, always all clinicians, or you can say it's a one tendency to cut the cost. So just I would like your comment. There are lot of people in their mind why all the disposables which are costly can be used by doing ETO sterilization. It cannot be. I know. But sir, I want your comment because they keep asking this question.
Very true. So thank you for this. I tell you, for one IUI semen wash, median disposable cost is hardly 250 rupees. For an IVF ICSI procedure, one person, median disposable hovers around 12,000 to 14,000. Peripherals are extra. Now, why are you bothered about the disposables? That's a very good question he asked. Of course, I have a whole PPT for that, but it's not within the purview of the time. All our disposables are plastic styrene. When you have spare time and you have one disposable to spare, go and just burn one disposable. You will find fantastic colored fumes, like how we used to do in chemistry labs, organic spotting. Remember? Now this will give out, or it will leach its chemical property when it is incubated in the 37 degrees. But when these disposables are manufactured, care is taken to say that even when they are kept in the media, even when they are kept in the incubator, the amount of toxicity leaching into the media is as good as negligible. That means the reprotoxicity is literally 0. So there are huge tests. Unfortunately, I don't have the slide over here. I could have shown you the details of tests. Most important is the CE marking, the 24-hour sperm survival, the mouse embryo toxicity tests. So once, you believe me, the plastics in which they are wrapped, they are also QA/QC controlled. Right? So that's the reason they always write, once open, unsterile. You must have seen in many places. And you expect them to be gas ETO sterilized. People do it, I know sir. I have seen people utilize the same holding ICSI pipette for the entire batch. Let's be very frank, I don't have any skeletons in my cupboard. I can blare it out, of course, without the names. That's the thing. So please, as far as, see, there you don't complain about the results. Disposables is the one in which you are harvesting the goddamn life which has progressed from day 0 to day 5. That's the logic. Believe me, carbon dioxide gas also, why do we keep an online Cora filter? Because if you do a spectrophotometric analysis of the carbon dioxide in your CO2 cylinder, you will be amazed to find more than 40 to 60 various elements showing their peaks in the chromatography. So that's why the online. Now people say, "Our HEPA filter to hai." HEPA filter will not filter out VOCs. VOCs, COCs will be filtered out only by activated carbon, potassium permanganate, and alumina silica. That too under pressure. In 1 or 2 labs I had seen, they had kept petri plates in corner, जैसे वे चूहे मारने की दवा रखते हैं वैसे, और ऊपर से वो अपना पाउडर डाला था इसमें, activator. So this is to disinfect the air. बोला अरे you are atomizing the whole lab with microparticles. This takes place, absorption takes place when air under a certain psi pressure is forced through those activated carbon through the inlet and through the outlet. You got my point?
Yes.
And coming to the concept of your incubator, when we are using tri-gas, some advocate tri-gas premix, some advocate 3 cylinders. Now in a premix, you are not sure about the company, even though they give you a certification. But the thing is availability. There are so many doctors who have taken up the big tri-gases only to find that their locality or in their area, nitrous is not available at all. So it's like that, sir.
So I have 2 questions.
Yeah.
Is it important to use a VOC meter in your lab? And the second one is, how frequently do you advise a lab culture?
You use your quality control gadgets, provided they themselves are properly accredited. They themselves should be calibrated. Otherwise, if you buy it, we don't service them regularly, we don't calibrate them regularly. So VOC ideally is needed, but many a times we get carried away by the small handheld types of button display, khali digital display aata hai, ya to LCD display aata hai, they are not in. Instead, if you really want a thorough, authenticated QA/QC at the lab health to be done, do it once in 6 months, depending upon your workload, depending upon your footfalls in the lab, and depending upon the peripheral environment in which your lab is situated. That's very important.
And if you have an AHU, is a lab gut mandatory as well?
No, AHU you don't have a lab. But AHU is, remember, people just think AHU means what a small thing through which, remember, in the AHU ducting, there is a big motor at the end of it. Then in the ducting, there are 11 partitions. Drop air filter, moist air filter, HEPA filter, cooler filter, and all have to function in synchronicity. Plus, when the AHU pumps air, it has to see that it encompasses your complete room thoroughly, each nook and corner, and at the same time the return blower sucks it back again. We don't have that QA/QC. We've set it, fill it, shut it, forget it. And our mentality is what, once I buy an equipment, it should last me a lifetime. चल तो रहा है ना, अरे भाई चल तो रहा है, लेकिन उसका फिल्टर का कैपेसिटी देखो, हालत देखो, choked filters, there's so many problems to it.
What about the lab culture, sir? If the report comes as some organism, what is your take on that?
See, no lab is 100% clean.
Yes.
No lab. And if somebody tells you, he's a bad liar. But certain areas, like your laminar flow table, insides of your incubator, they should be clean. Unfortunately, nowadays we have got the incubators which are contra-constant recycle. But please don't use them frequently, because the more frequently you use, the temperature goes high to 120 and you stand a chance of the sensors getting damaged. Ideally, these are 24/7 running gadgets. So even in a foreign country, they contract on once a year. When we 5 batch हुए, batch के पहले करना contract on, दबा दो button, वो जाएगा 120 तक. So this is done.
Sir, humidified versus non-humidified tabletop incubator, what is your take?
So that is a debate for the sake of a debate. Let me be very frank about it. See, humidified now, once you are...
You believe in single sentence. You believe in humidified...
First tell me what is humidified. It has got the air, it has got the moisture influx. Now you are doing a closed culture. You are putting it oil. So there is no way moisture is going to affect it. But moisture is essential when you equilibrate your media in a box incubator. That's very important. Because a collective atmosphere of carbon dioxide, temperature and humidity is ideal for the Henderson-Hasselbalch equation to take place to equilibrate on media. And then subsequently when you use it, if you are using oil, I don't find the need for it. But see, there are pluses and minuses, and the questions to pluses and minuses are more confusing than the goddamn question itself. It's like that, sir. See, all our equipments which we use are standardized, perfect to the core. It is only we, by our extra knowledge, try to mismatch them, or we try to figure them as such. Okay? Fine?
Thank you, sir.
Expiry of CO2 cylinder.
Expiry of the cylinder? Means जब भी गैस खत्म होगा तभी?
Earlier they used to say कि बाबा it's a 6 months expiry. ICMR say earlier used to say you should replace CO2 every 3 years.
See, I tell you a standardized. You buy a jumbo. The jumbo in your CO2, I mean in your embryology lab, will last for more than 9 months. It depends upon your frequency of closing, opening, and it depends upon, that's another good question, it's a very intricate topic. It depends upon your gas delivery system. How close your cylinder is to your lab. Because many times we have the utility room in far goddamn 50 meters away, through the ducting, piping, the elbows, the T's and the joints and metallic pipes. This is where the contamination and the reduction comes in, because there can be minor fractures or cracks to which the carbon dioxide will leak. Or what I would suggest is, ये तुम्हारा incubator, ये तुम्हारा cylinder, overall, just the charging line is 1 feet or 2 feet, it will function there. If you are storing it for a very long time as a backup, then one fine day when you really need it, you will find it array to khali ho gaya. So that's the thing. Otherwise, I have not found this question as very expiry date as such.
No, there is a separate gas act in Indian Constitution, and where they have mentioned it should be certified, all cylinders will be certified.
One of the gas manufacturer told me earlier it was 3 years. Now it has come down to 6 months.
Itna? So he's not having trust in his own goddamn product.
Second thing, what he told justified कि बाबा you should check the pressure also.
That is very necessary. By checking of pressure, see, because every cylinder you will have a dual gauge. Two. One will show the tank pressure and one will show the flow pressure. So when the cylinder is full, it will always show 2000. And whatever the PSI mentioned on your incubator, you have to regulate the modular toggle switch according to that. So 1000 to 750 will take months, but 750 to 250 will crash out within 3 weeks. So that's an alarm sign कि 750 तक आ गया है, मेरे पास डुप्लीकेट सिलेंडर रेडी है क्या? अभी वो डुप्लीकेट सिलेंडर अगर आपने बहुत टाइम से पहले लिया है, तो उसका भी प्रॉब्लम आ सकता है. This is what we call the expiry period. Because one doctor in another place bought a cylinder, dry gas. You know how much he paid for this? 50,000 bucks for one goddamn 15 liter, and that too is assuring in 2 महीने से ज़्यादा नहीं चलेगा. अरे, मतलब मेरा केस महीने में 5 होता है. You know, it's like that. So sometimes, you know, technology just puts a little bit of an awe factor in front of you, and you think, oh my gosh, I would never do it without. अभी आप खरीद लेते हो, अभी आपका रिजल्ट आया ना का अभी दूसरों को बताने के लिए बोलते हैं, beautiful machine.
So if the AHU has a potassium permanganate filter, should we have it's fitted with potassium permanganate filter for VOC control? Should we have additionally Coda filter also?
Well, to be very frank, I always advocate a small movable Coda filter because it takes care of the circulating air present in the lab as such. But if your AHU has perfect set categories, I will find the extra need. See, otherwise there are multiple add-ons, man. You keep on adding things, and at the end of the day, when you do a calculation and when you see the patient inflow, you will think I was happy with my scopies and surgeries.
So what do you suggest, sir, with the fresh air change or with the closed?
To be very frank, a small lab, privately owned doctor lab, or maybe 2 or 3 doctors pulled together, positive pressure, return blower, 1 Coda filter, and when you select the site should be clean. Of course, today we have no guarantee that building is perfectly standard, and after 6 months there is another building coming next to the close to you that we have no control over it.
Thank you.
Thank you, sir. That was a brilliant session. Dr. Alba Chawda, Bhavnagar, Gujarat.
Good afternoon, everyone, and welcome all of you. Thank you, sir, both sir, Sachin sir and Koredia sir for giving me such an opportunity. The topic given to me because I started my IVF journey in 2012 where I was only the IVF consultant. At that time we are working in Bhavnagar is such a remote place. So freelancing embryologists coming to our center. And after struggling 3 to 4 years, literally in 2015, I feel that I want to become embryologist. So finally, at present, I am working as a consultant as well as embryologist. So that's why I personally feel that if you are doing a good job as a consultant, then as well as at least certain things every IVF consultant should know about the embryology. So what happens now? No, someone can fool you. Sorry for embryologists, but at least we should have this kind of the knowledge. And I had seen when I was in my teaching experience or when I was in my learning experience that literally I remember that time. Because at that time what we do the pickup, we do the stimulation at our center, do pick up and transfer at somewhere else in Ahmedabad or like that. So really on day 3, he showed me this is grade 1 embryo. At that time I was not knowing about the grading of embryos and everything like that. So it was I remember 3-4 cell means on the day 3 at 70 to 75 hours he showed me 3 to 4 cell and he said it's a grade 1 embryo. Transferred and everything has done. Now when I do a retrospective study, this is the wrong thing. So at least basic things every IVF consultant should know. So let's see. So simply, so as a clinician, apart from clinical embryologist, we should also require basic knowledge. So when we look this, so when the results came not up to our mark, we have to look all the criteria from the beginning. So as a clinician, patient comes to us and they are why my cycle failed, simply. So we cannot blame on our lab condition is bad, our embryologist has done bad job, my environment has been. So we have to see from very beginning, what the patient selection we had done, pre-IVF preparation had been properly done or not, efficacy and storage of gonadotrophins injections because it is done by our staff. We usually don't look into that. Trigger timings and the dose, ovum pickup techniques, lab air quality, culture conditions, embryo transfer techniques and the post-luteal support. So these are the very basic stuffs that we have to see from very beginning. So lab air quality, already master had tell everything, so I don't have to go much, but as simply someone has asked the question, I personally prefer that though we bought VOC meter and pH meter, everything, but that must be calibrated at frequent intervals. So we cannot just what and we do the everything by ourselves. So this is my personal point of view. Yearly means we have to take the air quality control, engineer will come and every 3 months or every 6 months they do all the equipments calibration, they do they measures the VOC, they measures the particles, they measures the CO2. I want to share my one experience of that. I feel that means when I do the culture and all kind of that, sometimes it is happening that embryos are forming, everything is going good, but the result not come up to my patient. So at that time, my CO2 incubator is always showing 6%. That we had set, and finally the result come out is the CO2 actually was 8%. So this is happening with 8% because in CO2 what we usually do now, we only do the calibration of the media, and the culture we do in the planner, means in the tri-gas incubator. So for the calibration what I had done in the CO2 incubator was not in proper condition. So these are the things, so that's why we have, this is very important to check the all air qualities, means calibration of all the media, all our equipments, that is very important. So lab air quality plays a very important role.
Like some AHU or as well as we put the podas under like towers. So for that, filters also to be changed at regular intervals. Like sometimes we feel that it's a waste of money. Everything is showing good. But if you have the workload, that filter has to be changed at every 3 to 4 months. So VOC to be take care of, lab temperature usually to be take care of, regular cleaning of AC filters. As someone has asked now, the infection has been coming. For that I had one time call to the sir also for that. I also facing this kind of the problem that on the day 2, day 3, some infection growth coming into the culture dishes. Some dishes were there, in some dishes, so at that time, everything, because at my center I am the embryologist, I am the consultant. So I have to see what the problem is going on, because on my side I am doing that. I have checked everything. So like at that time, like sir is coming like a God to me. Thank you for that, sir. So like that, the problem where sir has asked me everything. So what silly things I also know, because we have planar incubator. So sir has asked me, you are changing like everything we had ruled out, 1 mark. And then suddenly he asked me, you are filling water in that humidifier bottle. Are you boiling it? So like I said, no, we are using double distilled water in our humidifier bottle. So why we are like doing the boiling and all kind of that? Sir said, no, it has to be like autoclave, that water to be filled in. And like when I had learned, when I had done by my embryology training, no one had told me that bottle you are filling in humidifier, that it should be autoclaved or should be boiling at a proper temperature for this kind of. Just I had done and all the problems solved. Like I was literally troubling since 1 month in my lab, and no one embryologist, like I had called so many embryologists, very well-known embryologists, and all engineers of all like Trivector and everything. No one has shorted. Everyone is giving change your culture, change your this, change your this. We had changed everything, but the ultimate result, the only problem was water in that humidifier bottle is the culprit. And second important thought is like AC filter. That is also play very important role. So that is also should be cleaned and checked at every 6-month interval. So these are very practical things, and you will not find this kind of things in any books. So this is very important. So incubators, as I told you, 37 degrees at temperature, proper cleaning is very important. Gas flow and concentration of the CO2 to be adjusted according to your media. So like someone like company people is coming and tell our media is good, our media is good. But don't do like that. Do discussion with your embryologist, and whatever the media, like particular media has particular CO2 concentration. So like this people is coming and tell you use our media. So never do this kind of things. Regular interval changing of CO2 filters is also very important. Previous day of ovum pickup, also check the calibration of the media. Ideally minimum should be done 8 hours prior. Sometimes freelancing embryologist is coming. So we don't know where at what time calibration of the media has been done. So this is also very important. Oocyte retrieval should be done at a perfect timing. Culture condition, again single step versus sequential media, that is debatable. Two main buffering system is sodium bicarbonate media and Hippies media. So at least as a clinician we should know Hippies media required 37 degree. So this can be like cultured at 3 hours prior is okay. But if you like culture all the media, FOIT media, CLIO media, that is to be calibrated minimum 6 to 8 hours prior. That is important. That is to be keep our eye on that. pH indicators is very important. So like whenever any culture culture media is kept in your refrigerator or in the CO2, so you have to check the colors also. If the color is changing to yellow, it shows the contamination. Dark pink color says drop in the CO2 layer. Raised CO2 take care of the CO2 layers means door open and closing is very important. So these are the different types of the media, that's all you are knowing. Then comes to the morphology, so we should also have to ask, or we can ask the embryologist to just take the photographs. So whether they cannot blame, like it's not good kind, like OCC morphology, whether mature, immature or the post-mature. Oocyte maturity, that I think the RY is going to take on this. So again, technique, IVF versus ICSI, I in favor of according to the, depends on the condition, because at my center I am doing like 50-50, I cannot say that, but 50 to 60% I am doing IVF and 40% ICSI. And I feel IVF is always the best over ICSI. Well, this all will be taken care. Sir, I think I am going to stop because these are the very basic steps of IVF and the ICSI that the RY is going to take. Okay, thank you.
Thank you, Dr.
Questions we take after Arva's session is over.
Arva is my daughter.
Hello.
I believe she is the youngest embryologist whom I know who started doing ICSI at a younger age. I think what age you started? First ICSI you did on? 20 years. 20 years. Now she is, it's worth watching when she is doing ICSI, like playing with the football and stick, just like that. Anyway.
Okay. Hi everyone. Majority of the topic has been covered, so I'm planning to just go through the general embryology protocol that we follow. We begin with the step-by-step procedure. Once the patient has been recruited, the stimulation begins. Then when the trigger is given, we count it as day -2 because the day of pickup is known as day 0. So we will start from preparation that starts on day -1. On day -1, first we have to incubate the media based on the number of follicles that are expected. We keep a check on the disposables that will be used on the next day, and we see if something is missing or probably just ready a whole list of disposables that will be used. Paperwork, of course, is prepared. Consent forms, lab records, everything is prepared. Reports and investigations of the patient and documents. And lastly, we check the functioning of the equipments, because at the on the day of pickup we don't want any malfunctioning of the equipment, so it's better to just run a thorough check whether all the equipments are functioning or not. On day 0, which is the day of pickup, we prepare the dishes. Okay, the dishes that contain media, the ones which will be used during the scanning, during the pickup, oocyte retrieval. The first person who comes in the lab will incubate the tubes in the hot block at least 30 minutes to 1 hour prior to the pickup, so that they attain the temperature of 37 degrees. We turn on the laminar flow again at least an hour prior. We keep the disposables ready, take the signature, consent, all those formalities are done. Once the pickup begins, it's done in a petri dish, in a tissue culture dish rather. The fluid is scanned and we look for good OCCs in the fluid. Those are collected, they are thoroughly rinsed, and they are placed in a nutrient-rich medium, be it hippies or culture medium, depends on your center. Depends on the personal choice of the embryologist. Then once the sample is collected, we process it. Again, washes according to the count, motility, preferred method, swim up density, whatever is selected. These are the points that I've already covered. So the gassing of consumables, that's a very important step I've noticed. It's preferred to bring all the disposables that are going to be used at 37 degree, so that there's no shock to the gametes when you're incubating them. Rest all points have been covered in this. So once we get the follicular fluid, we scan it in the scanning dish, it's washed, we incubate it. There's a minimum incubation period of 2 to 3 hours that I follow at our center. 2 to 3 hours of incubation before I proceed for ICSI or IVF. Meanwhile, the sample is processed, and after that, we opt for IVF or ICSI. Now, here is just an image representation of the embryo culture right from day 0, when the IVF or ICSI is done, pronuclear stage up till expanded blastocyst stage. As you can see, it's numbered 1 day, 1.5, 2, 3, 4, 5, and 5.5 to 6, which is the completely expanded blastocyst stage. A very important topic that I would like to cover today is the grading of embryos. How do we select the best quality embryos? So right from the beginning, this is the chart that we follow. The morphokinetics are followed such that once after IVF or ICSI, whatever is done, preferably during 18 to 19 hours, we have to check for the pronuclei. There should be symmetry and even number of NPBs and the positioning of the polar bodies. 25 to 26 hours approx after insemination or ICSI, the embryo should be at least 2 cells with equal blastomere and no fragmentation. 42 to 44 hours, it should be at least 4 or more than 4 cells with less than 20% fragmentation. The lesser the fragmentation preferred, but still the criteria goes at least up to 20% fragmentation is alright, and of course no multinucleation. From between 66 to 68 hours after insemination, the embryo should be at least 8 cell or more than 8 cell with again the fragmentation less than 20% and no multinucleated blastomere. 106 to 108 hours after insemination, the blastocele cavity should be visibly full, the ICM numerous and tightly packed, and the trophectoderm cells should be numerous and cohesive. As you can see, I have written the class 1, 2, 3, 4. The embryos, you usually hear your embryologist say, right, that the embryos were class 1, class 2. So this is the general chart. You can have a look at it. Like I said, the fragmentation lesser is more preferable, so less than 10% is generally considered class 1, and the criteria remains the same. On the left hand side, you can see the classification of the blastocyst. What is a good grade blastocyst? And the number 1 to number 6 is the expansion of the blastocyst, the size. And the A and A to C is the first A in the grading. Suppose if somebody says the blastocyst is 4AA. So the first A stands for the inner cell mass, and the second alphabet, be it A, B or C, stands for the trophectoderm cells. As you can read, I've written the distinguishing factors which we can place the blastocyst accordingly based on its size. Now this I've just made a diagrammatic representation of how we load the embryos for transfer. As you can see, that's the tip of the catheter. Air, the first thing we take is air, then media with embryos, and then a little bit of air before we proceed for transfer of the embryos. Then there's vitrification and thawing. We only prefer vitrifying class 1 embryos according to the scoring chart that I just showed. And once thawing is done, usually we culture up to 80 hours, sometimes blastocyst, mostly 80 hours post-thaw, and at 80 hours we do the transfer. And the grading is again done before transfer so that we know that they have survived and they have further grown properly. Semen analysis was already covered earlier. I've just written the materials used and the general criteria that we follow. You can have a look. This is the WHO reference criteria that's used. This is again for the vitrification of sperms and thawing. As you can see, the count and motility is noted, and 1:1 volume is the one that we usually use of the cryoprotectant for freezing. And this is the protocol that I used. I've mentioned it. Now there are some other points. There's one topic that I want to cover, cost analysis. So I have prepared a sheet of the general cost that we bear, the disposables cost at our center. So whenever anybody tells you that a certain disposable we cannot do without it, we need this certain disposable, that's not true. Apart from a few consumables, most of the consumables are replaceable. So बोलते हैं ना जुगाड़, there's always an option. There's no particular reason that you have to buy this dish or you have to buy this pipette or something like that. I mean, everything it can be managed without it. So the cost that I'm going to give you regarding the procedures that we do, it's done in the most economical, yet in a way in which we don't compromise at all. It's done in a very proper way. So generally, IUI, the cost is around 775. That includes the material cost, everything, right from the consumables, the media, and everything. The ICSI cost is around 2573. I think already Casey sir has covered quite a lot of it. So just an estimate. Suppose if there's a frozen embryo transfer, around 5852 is the cost. So whoever wants to know in detail about the costing of the materials can meet me later. I can take that. But for now, that's it. Thank you.
We invite questions regarding them.
Can we have Casey sir and Dr. Chawla on the stage, please, to take the questions? So before questions, just one comment. When I started my IVF journey, I used to do stimulation as we all do, stimulation myself and pick up and transfer at somebody else's place. And the embryologist there would always tell me that it's a fantastic grade AA blastocyst. And for the first 10 or so transfers, nothing happened, okay? And trust me, I was so dumb that I never even bothered seeing the embryos ke kaise dikhte hain. Then one of the conferences I attended where I realized that we need to see the blasts. So I changed, and that caused that embryologist a lot of, heartburn. So there are anybody who's embarking on their IVF journey, I would strongly recommend having an atlas of embryology. It's a fantastic book. Okay, I think it's Dr. Kamini Rao's. It's a series of 3 books. Wherein one book is only the atlas. Usko pura ragad dalo. And before doing the transfer, you yourself change and enter into the IVF lab and select what embryos you want to. And have a dialogue with your embryologist. And after that, trust me, the pregnancy rates just jumped. The 11th patient became pregnant. So that was a huge thing for me.
Please have the question.
Sir, 24 hours sperm viability you said testing. So are they washed sperms or semen as such or semen plus media?
No, they have to be totally watched from capacitated. Now, with reference to your question, let me add one more thing. That many a times when we do IUIs, what we are in the habit case, suppose there are 2 IUIs on a day, we wait for both the samples to come, right? And we think of processing them together. Now remember one thing, the longer the time the sperm are exposed in the seminal plasma, the faster is the decrease in their fertilization capacity. So if a sperm sample is collected and if the sample is made lie on the table for more than half an hour, the fertilizing capacity of the sperm dips to near 0. In spite of them being swimming fast, motility fast, blah 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 blah, everything possible. But the fertilizing potential is a biochemical or non-biological entity which we can't monitor. So remember this. Eliminate the seminal plasma as quickly as possible. Yeah,
when we incubate for...
No, don't any. When you keep this 24 hours sperm survival, the aspirate which you take, just keep it on the laminar flow in a sterile tube. Because if you incubate it, there will be more agitation of the sperm, they will be hyperactivated, they will burn their energy fast and they will become non-motile.
Only under laminar flow?
Under the laminar flow.
Then should we use UV light for room air sterilization when there are no embryos or gametes in the lab?
But irrespective, they will be in the incubator. So even if you use UV light outside, which is exactly not advisable, the only thing UV light is used on the laminar flow, because what it does is it doesn't kill the bacteria, it breaks the DNA, thymine range, which makes them incapacitating of duplicating further. And it range decreases with the area. So when you put the light on, suppose you have a pickup at 8 o'clock, the embryologist comes in, he will first switch on the UV light, nothing on the table, 20 minutes, switch it off, put the airflow, the procedure starts.
during OPU, we use disposable gowns and drapes and other things on it. Is that say harmful?
Depending how well they are sterile.
They are disposable. Yeah.
No, disposable ones, so why should you bother for? You mean the plastic toxicity you mean?
Yeah.
I don't think so much, because sorry to say, many a times when we are also given changing, you open the drum, they used to always come moist, and moisture is the biggest contamination. So the contamination breeds from the moist autoclave boxes only. They should be crisp, dry, ideally speaking.
How the media are calibrated?
No need to, because many a times these media bottles, when we get, they are already perfect condition. We just need to equilibrate them properly. Many times people have a habit of buying some local pH meter and putting the probe in and say media ka pH barabar nahi hai. But nobody calibrates the goddamn pH meter, which already is many a time substandard. So if you incubate it or equilibrate it at the right time, with the right pH, with the right CO2, for a perfect time, the pH is mostly proper. The only thing which differs, which we should not worry about, is the height of the laboratory. Many times when the labs are at great heights, like in China and Tibet, there are certain labs which are at very great height. The pH, the CO2 is 12%, because it depends, height and the air pressure depends upon the perfusion of the gas in the media. Now we don't want to worry about it, because hardly any lab is more than 500 meters above.
So my question is, when we do ICSI or IVF, then we keep the dish in trigas incubator or whatever CO2 incubator.
It's post-insemination or post-injection.
Post, correct. We see at 12 hours.
12?
18 hours, sorry.
18 to 20 hours,
yeah.
Correct.
Then as per Arwa's discussion, she told ki we should see at 66 hours. Then how should we thaw at 80 hours? I was not getting that point.
See, usually now, everybody's flow pattern differs a little bit.
No, I will tell you.
The most important thing what we see is the fertilization, which
whenever embryologists come, they see, ma'am, aisa hai, but exactly how should we?
See, normally in our lab, we transfer embryo of 80 hours, and there are specific reasons for that, why we have selected that protocol. Because it takes the best of both. The problem with the cleavage stage, so we in our lab, we freeze all class 1 embryos only in cleavage stage. Sometimes as per the convenience, may freeze at 64 hours, sometimes 68 hours before end of the day 3, C finishes. Now when we want to transfer the embryo, we thaw the embryo and we extend till 80 hours. The age of the embryo completes the 80 hours. That is a compaction stage of the embryo. There are specific reasons for why we have preferred the compaction. You want me to discuss that?
No, sir, sorry to disturb. Means if you are even vitrifying the embryos at 64 or 60 whatever hours, still you are extending that and thawing it.
Because you want to transfer 80 hours embryo only.
Okay.
That is our belief and our, protocol.
Because she has written thawing at 80 hours, so I got
not thawing. Thawing is in the topic of thawing, I've written that we transfer the embryos at 80 hours, irrespective of whenever we are frozen, be it 40, 48, 60, whatever hours. Whenever it's frozen, accordingly we calculate and bring it to 80 hours. So our transfer is always at 80 hours.
So why
And the 0 hours starts from the time of ICSI.
Why 80 hours? Why not 120 hours or something? Why do you select that?
First, this is
Yeah, but I just draw your attention to that whenever you do IVF or ICSI, one golden rule you have to follow is, once you pick up the OCCs, you have to incubate them for at least 45 minutes to 1 hour. That is process called post-pickup incubation. This is very essential for them to reach a consensus of proper pH, advanced maturation, and acclimatization to the lab environment. Many a times we have seen immediately post-pickup you start denuding, because what we are compromising is the spindle quality. We are displacing the spindle because spindle is extremely sensitive to mechanical stress, osmotic stress, and the temperature gradient. So post-pickup incubation, whether you do IVF or ICSI, is of utmost importance.
That is true.
At least a minimum of an hour after the pickup.
Dr. Chandrakant Thakkar, Gandhidham Touch. Husband is having a HIV positive and wife is HIV negative, how we have to proceed for the preparation of that IUI?
See, we had processed many HIV positive samples also, but the titer of the male was comparatively less. Okay, so and at the same time, we can never give a guarantee to a couple that the child will be completely HIV free. There are techniques in the WHO manual also which ensures you can process a sample. It is like you can wash the sample thrice because these patients will not be compromised in the semen sample. The semen sample turns by the sperm fantastic motility, etc., etc. So what we do is we wash the sample thrice, take the aspirate, incubate the aspirate at 50 degrees for 5 minutes. Agreed, you may lose some motility, but you will be heat deactivating the virus. But please don't do it at home. It needs a special skill and guidance. So what happens is that when you inseminate them, many a times when I was there, I used to tell my superiors, now in the child you better check. But they were also saying, kafi ho gaye HIV bhej do, usko ghar bhej do. Because today, in spite of the patient giving you an assurance, sir, don't worry, even if my child comes positive, I will not blame you. But if the child comes positive, they'll definitely come back with a lawyer at your doorstep. So it's a little difficult for us to literally compromise, or I would say authenticate our communication. It will be totally zero. So there are techniques available for HIV sperm processing, but with a pinch of salt.
Can we offer them IUI with donor sperm?
Donor sperm, now the word spreads fear in everybody now. So I cannot comment on to it, but there could be a reason. See, the trouble is in these guidelines, they go, I expect us to go to a lawyer and sign an affidavit, but the couple who is not ready to disclose the secret to their own parents, how the hell are they going to disclose the secret to a lawyer and a third party? Yeah, I'm infertile, find the affidavit for me. So there are certain emotionally bound lacunae. It is very difficult for us to, it's very easy because we are on the other side of the table, so we don't find that more traumatic as such.
Thank you, sir.
I want to know whether it is
Please
better
introduce yourself.
Dr. Radhika from Chennai. I want to know whether it's better if we can freeze a day 3 embryo and when we are doing an FET, thaw it at that time and take it to the blast, or to freeze a blast itself, or it doesn't make a difference.
In 2 centers in Bombay where I was practicing slow freezing a couple of years ago, the same technique was used by 2 doctors. First of all, a day 3 embryo is very conducive to be frozen.
Frozen, yeah.
Number 3, the recovery of day 3 is much more better than the recovery of a frozen blastocyst. And unless and until you are not sure of the recovery, now as I told you, if I was to transfer tomorrow, I will freeze it today. Correct? So I come to know the progress. So if I say that the freeze record shows compaction frozen, thawed compaction, culture it for 2 days, get a lovely blast, you get it. Many people follow this because they are sure of the viability and the integrity.
I'm happy with this, but my embryologist is not happy. He asked me to take it to the blast. But I'm more, I feel more comfortable.
Today, sorry to say, with due regards and respect to all the embryologists, no, they just want that typical piecemeal, instantaneous result and the procedure to be taken place. They don't want it to be carried on further. So
it's like break journey. You always prefer break journey if you have convenience. Rather than the single stretch journey, if you break a cleavage stage and then extend next time, it's always better because you give a better chance of adverse culture condition which might be prevalent at the time.
So as justifying her statement that initially, as Dr. Dalal's statement also, there was no communication between the embryologist and the gynecologist as far as the quality of the embryos. So many times, many gynecologists who have just started their labs, and they tell me, my embryologist is not even allowing me to check the vitrified embryo prior to thawing. He said, no, madam, you will disturb it, you will traumatize it, don't see. But that means there is something hanky-panky going on. Unless and until you are not dead sure about the quality, what's the problem? You just display. Today you have got image capturing cameras, you have got 3D cameras, you capture a photograph and see it for the rest. So it's all like that. There is a great distance between the cup and the lip.
Next.
Sir, according to new ART guidelines, we need to have 2 incubators. So we need to have 2 incubators. So mine being a new setup, I'm right now having Hira cell incubator and I'm getting good blast rate. So further, should I invest in the second incubator in Hira cell only, or should I buy a Trigas
Well, to be very frank, the cost factor is quite the same in both. And prior to the introduction of these bench tops, people were always using box incubators and they were getting fantastic results, no doubts about it. But the thing is, well, a new technology is taken up by the storm and we have been fed up in mind in such a way, it's like you are economizing the space, because in a box incubator, the only drawback is you are cultivating 40 to 30 dishes, imagine maximum. So for any dish you open the incubator. Nowadays in the current bench tops, there is a single isolated chamber, means my specific room, like a coupe in a first class railway cabin, it's only to myself. So you don't traumatize it from day 3 to day 5. That's the only logic. Otherwise, basically everything is the same.
Thank you, sir. Hello, that's Dr. Rachna from Thane. So just a clarification from the understanding, we can freeze at any stage, day 2, day 3, day 4.
No, day 4. I think day 4 is a little dicey, because day 4 is a stage, what we call it is a compaction stage. And in this time, all the blastomeres amalgamate together. So all the physiological, more biological activities are intense on day 4. It is only when that, if you see a day 4 embryo, now you feel, what a grothous thing, just throw it away. It's a very shapeless, ugly looking thing, because from that ugly looking thing start the cavitation phase. So ideally speaking, people are avoiding the day 4 as such. So and even early blastocyst cavitation is also avoided. So day 3 or 4.5, you can start it.
Even 2 p.m. also.
Yes, 2 p.m. also we had frozen. I myself had frozen. And ultimately it culminates further.
And also sometimes if it has hatched out a little, can that be frozen?
No, part hatching cannot be frozen. Either you completely let it out, but the hatched embryo or a hatched blastocyst is one of the most delicate and the sensitive cell. So there is a lot of pluses and minuses with it. It's a luck factor, to be very frank.
Okay. So how do you process the viscous sample? You said semen sample should not be kept for more than 20 minutes.
Yes, so even if a viscous sample is there, you break the viscosity by forcing it out through a 20 gauge needle 15 to 20 times.
The tuberculin?
Tuberculin, and you fix a 20 gauge needle. So 90% of the time the viscosity will be broken. In spite if it's a harsh viscosity, at least like a spin bar kit drawing into at least 6 centimeters length, add some incubated media and do that, it will be done.
No role of that trypsin or bromose?
To be very frank, as far as any ART is concerned, I am against addition of any exogenous chemical into it.
Thank you, sir.
Sir, can we do sperm function test for semen analysis if you are doing yourself? HOS test.
So HOS test now is comparatively a little outdated because it is just dealing with the membrane integrity. So the sperms which curve, it ensures you that the membrane integrity is intact, and in any cell if the membrane integrity is intact, the functionality of the cell is not compromised.
And eosine test?
Eosine is the same as such. The sperm which take up the stain have a fractured membrane, the sperm which do not take up the stain, the viability is there. So a non-motile sperm which is colorless is alive, it is not dead. But a non-motile sperm which is stained is of course dead because the membrane is cracked, the stain has penetrated into the membrane.
And suppose the sample is viscous, so can you put the sperm flushing media? And sometimes the sample is still viscous after half an hour.
If you are doing analysis, don't do anything, just wait till how long it takes to liquefy.
Not for that, IUI.
Procedure, yeah, you have to manually liquefy it.
Sir, what is the permissible duration for which the prepared semen sample can be kept before doing IVF or ICSI?
Excellent question. Now, where I used to work, we used to have a number of walk-in samples from doctors. Some were saying that मेरे को 12 बजे के अंदर ही sample चाहिए. Fine. The patient used to come by 10. Some used to say that no, we were at Kemp's Corner. The patient used to come from Thane. I am taking the sample to Thane because the gynec wants to inseminate over there. And the place where I used to work itself, the gynec used to consult in the evening. So she used to do the insemination at 7 p.m. So prepared samples at 11 o'clock, put on the laminar flow under sterile condition, 4-5 hours is ideal. But if the opportunity is there to do an instant insemination, go ahead.
So better to process the semen sample and keep it?
Yes, of course. Process sample, please never ever expose the sample in the original naive stage for a longer time.
Important thing is never keep process sample at 37 degree.
Yeah, you will further
switch up in room temperature.
Sir, what is the ideal time between denudation and ICSI? You are denuding the sample, and
So
what
I think you seem to be having a visiting embryologist at your place. Okay, fine. So the ideal time is See, what happens during denudation, let's first start. We are manually stripping the eggs. So we are causing a little bit of trauma. We are inducing it to highs or a higher luminance where it is time conscious, concentration conscious. So after you denude, allow that gamete to acclimatize to again to the normal condition. So post denudation, incubate your denuded oocytes for at least half an hour in the culture media. I know your embryologist will swear at me if you go and tell the same thing to him or her, but that's the patent reason.
Okay. And the minimum time between thawing the embryos and transferring it?
Thawing the embryo, as I said, I always used to thaw it one day in advance because I want to see the viability. The trouble is when your embryologist insists करें आज का आज ही कर दो मैं आपको बताऊंगा नहीं बार मत करो expose मत करो उसका ही कुछ problem है. He is considering his own interest. If you have a fantastic recovered one, what's the problem in showing you? And what's the problem in checking the viability? Your cell grade should expand or increase. That's the logic. For a blastocyst, you can't do it overnight. For a blastocyst, at least 3 hours incubation, post-thaw transfer should be done. Because what you will see is an expansion state. The trophectodome will thin. And the ideal characteristic of a blastocyst is the thinning of the trophectodome, the better your blast.
If it is a day 3 embryo, sir?
2 questions.
Day 3 embryos are fine. Modular. Day 3 is something like 6 to 7 cells and proliferates into a 10 plus, which will show compaction. See, everything is easy as long as the others are doing it. And a poor workman blames his tools. Remember that. At least 3 hours. At least 3 hours. Even cleavage stage, if you are thawing in the morning, transfer in the afternoon or evening.
Last question.
Yeah. I'm Dr. Madhuben from Tamil Nadu, sir. You said you are doing around 60% IVF and only 40 AC. So what is your selection criteria? Why?
IVF versus XC.
My criteria is the sperm seed. A lab, I will be responsible first is for the semen sample. Correct? Post-wash motility survival rate and the linearity and the kinetics. Plus the number of OCCs which I get. Now, the OCC you cannot judge in IVF on the same day of the pickup because sometimes the OCCs which well spread cumulus also turn out to be nasty. So it is your general outlook. The number which you get, the well spread up cumulus, just like a sunny side bullseye fried egg with a beautifully spread white across it. That is the only criteria. Otherwise, rest is for the gynaec to decide. And according to the E2 levels also, that's very important because one graphene follicle synchronizes to 190 to 220 picograms of estradiol.
Thank you so much. Thank you. Because very interesting session. Next upcoming Dr. 80 or in between, when changing the, I will answer this question because otherwise for tea time will be late. And I have suggested little change in the program because this is a beautiful venue. Suppose if we keep continuing, then by the time we finish it will be night. So what I am thinking, we should have 1 hour break, maybe after 5 o'clock or 5:30 to 6:30 something, and then रात को खींचेंगे फिर. Right? Am I? Oh, you all agree? So at least have feel of the venue. Let's see. Okay. Okay. So the because okay, let me finish this question. Why we are doing 80 hours transfer? There are 2 reasons. The problem with the cleavage stage embryo, till itself everything is fine, and the moment it becomes compacted, the embryo is resistant to grow further, and there is degeneration and all starts happening. Because paternal genome activation occurs after that only. So if you transfer day 3 good embryo, that does not mean because the adequate paternal genome activation is not there. So I want to have paternal genome activation. I want to make sure that the embryo which has grown up to day 3 perfectly is really perfect, and it remains perfect even after paternal genome activation. So I want to extend. That's one reason. Second reason, why blast is preferred. Of course, the euploidy rate of the blastose is better because 70% of the cleavage stage embryos are normally aneuploidy, and which is approximately 45 to 50% of the blastocysts are aneuploidy. So that's why implantation rate of the blastocyst is better. The problem with the blastocyst, in the journey from cleavage stage to blastocyst stage, in culture, that's very harsh road, I would say. Up to day 3 is a smooth road, day 3 to day 5 is a harsh road. So embryos which are not euploid, or embryo which are, of course they will go, most of them will go. But there are some concern that some of the embryos which get degenerated were actually good embryo and could have survived if or could have given pregnancy rate. That's apprehension in blastocyst. And 25% of the cycle, when you are extending from cleavage stage to blastocyst stage, there is complete degeneration of all the embryos. So I am little skeptical to do blast transfer for everybody. So how can I get the best of both? The third problem, why we prefer the blastocyst transfer. After 4 days of exposure of endometrium to the progesterone, the uterus become calm down, become acquire the patience, the contractility decreases. So that is the reason in at the time of blastocyst transfer, normally uterine irritability does not affect, uterus is normally not irritable. So to take the advantage of all these 3 factors, we transfer 80 hours. So after paternal genome activation, 4 days of progesterone exposure is there, and little better euploidy rate can be expected. So these are the reasons why we transfer at 80 hours.
Sir, is it also to account for the free and the...
Sorry, can you give the mic?
So do you also transfer at 80 hours for Dr. Sachin Nair?
Last.
At what stage?
Very few people does at 80 hours themselves.
At what stage you are feeling day 3 or day 5? Day 5.
So do you use embryo glue, and do you find any adherent placenta at the time of delivery? In the cases you have used embryo glue.
Embryo glue I have not used any time. Some as an experimental purpose, as I was discussing yesterday, in couple of cases we have used. Thank you, Kersi sir.
Thank you, sir.
Thank you, sir. As experimental way, in couple of cases we have used spent culture media as a transfer medium while doing embryo transfer.
So that 80 hours also, why you are doing it is because of that pre-receptive, post-receptive,
No.
also trying to take it
No. See,
nothing to do.
the embryonic endometrial age coincides that. The already progesterone is started.
Yeah.
So when we are throwing embryo of 68 hours, the endometrial age is 68 hours. When we are extending, by the time 80 hours, it will become 80 hours. Because progesterone is continuing. Na? Patient keeps taking progesterone continuously. Okay, so we are moving on to the very interesting topic. Oh, primary member and appropriate authority. We wish you were our appropriate authority. Grant our permission immediately. Over to you.
Thank you so much, Dr. Koradia. I must just start by saying that Dr. Koradia is the person who has handheld me towards on this path of IVF. You know, at every place, right from buying my equipments to small things, how to set up my lab and day-to-day stimulation work to day-to-day problems. He's been very approachable. I can hear he's there available for 80% of us is vouching that Dr. Koradia has been a great help, and we are very blessed, sir, to have you have you around on this earth, and I am thankful that we have been born on the same time span when you were born. so we could get such a good help. There are people sometimes who tell me कि मैम आपसे ये question पूछ के बड़ा अच्छा लगता है, you're very approachable. I keep telling them that I have got a wonderful mentor who is there always to save me. Thank you so much for what you have been. And thank you, Dr. Sachin. You've been the smaller copy of Dr. Koradia, and I wish there are 100 more copies of both of you. Thank you. So with that, I'll say that the topics were being allotted for the faculties. Sir had called me 8 times, and I was busy watching Rocket Boys at that time, and I was given this topic which I never wanted. But Sir said कि अब यही बचा है, अब तुमको इसी पे ही बोलना है. And immunotherapy जिसके बारे में मुझे कुछ नहीं पता था, but thankfully वो मुझे by default जो topic मिला वो पिछले 1.5-2 महीने में मैंने वही पढ़ा बस. So I would start with talking about. I'm sorry if I'm talking in Hindi in between. Just मुझे आप टोक दीजिएगा sir. Okay. So about ART laws and the new laws which we know that are started since last year. Before that, I just wanted to say one small sentence that it's just a small Bible. Most of us are so learned here, and it's just a Bible of 16 pages and 25 pages. That's it. That is the only thing which we have to read, and I would advise that even though all of us keep discussing about this is one thing which we don't read. Even I, despite being the appropriate authority of a state, I have read it a couple of times, but there are still things which we keep missing, and it is very handy, and everybody should have it in their own clinics. And with time, as PCP and DT people say that you have to keep that booklet in your clinics, similarly, there will be a time when you will be asked for this Bible also to be kept in your clinic. So it is always a good practice to have those 26 or 16, whatever number of pages are there, to be there in your clinics, and they'll be very handy. And the second thing which I wanted to say was that we got to learn we have to unlearn few practices which we were doing before 2022. So I'll start by saying that the bill which finally came out in December 21 was had become an act in December 21 was actually in the Parliament for 4 times, 2010, 14, 17 and one more time, and it never actually became an act because of the pressure of surrogacy thing that it turned into an act. Otherwise, it is not such an important thing that it would have turned into an act and we would have got few more liver years. But the world pressure was there. We should understand why this thing came over. It was the pressure from the world, different forums, on our country that why we are the surrogacy hub. That surrogacy thing somehow made us, it is a stigma in the other part of the world. I have done one of my courses at Singapore, and I can share you my personal experience that there was, in those 15 days, there was just one day, one lecture about this surrogacy thing, and they were orchestrating this whole surrogacy thing as if something very bad is happening in India. And I had to literally fight it out that why we are so against surrogacy. You are so open with prostitution at your places. There were people from Thailand and stuff. And you are looking down upon surrogacy. Why? I had to literally fight. They were very easy people, so they agreed with me immediately. But what I wanted to, it was just a small picture which told me that why the pressure on the government was there to finish off for surrogacy. Even though surrogacy is now still in India with certain after certain criteria, but still is pretty much to nil. as we will understand.
Dr. Anupama, you have only 6 minutes left.
Yes, sir. So don't worry, sir, I have only 5 slides and literally I have to speak on that. So that surrogacy thing, it is to be finished. It has to be implemented, that rule. That is why for that surrogacy we had to have this ART rule. So this ART rule came over, and the ART Regulation Act was enacted in January. Later on the rules came, and the rules were the ones who actually detail it. Earlier ICMR guidelines were the ones which are pretty much the same in the ART rules at present. And we need to know about the rule, but why? Because anyone who's practicing infertility has to comply those points which are there, and there are small things which we don't know that they are no longer eligible now. The most important, which I think most of us know, is that no sharing of gametes is allowed now. That is a very, very important thing. So commercial surrogacy is pretty much out, and the only thing by which the surrogacy is possible is only to those couples who don't have any child. Not through surrogacy, not through adoption, not by anything, and apart from that, they have to have a reason for surrogacy. And finally, they have to have their own gametes. So supposing there is a male who has whose age is 57 and the female age is 35, but they will not be able to, even if the female cannot procreate, but by anyhow she will not be eligible because that fellow has crossed the age. So there are so many things there. Age is one of the criteria. Other criteria are also there. So surrogacy is pretty much impossible now. And for surrogacy, for ART services, the age eligible is 21 till 50 for all the females. But for surrogacy, age is 35 to 45. So that is for the single women I am talking about. And for other females, it is 23 to 50, and the same age is for the men also. One of us, who's the new ones who have to apply, have to go through this website. That's very simple. And all of us should remember that once we've applied, and most of us will get approval very soon. There's one thing, Dr. Koradia, which I wanted to share was that at present, जो अंदर की बात है वो ये कि the pressure on the appropriate authorities is not to find out faults. At the present, the pressure which we have is just to finish this job, finish the certification. So none of us should be worried about it. If you follow those baseline criteria, the only thing which most of us are not doing is maintaining a grievance cell. Just maintain that also. One register is to be maintained. Otherwise, all of us will get through this initial certification. None of us will be exempted.
It's a great relief, Yeah.
Yes. Oh, okay. Acha, I'm supposed to. Okay, I'm so sorry. Okay. So, in these rules, I just wanted to say that initial rules which came over, there were 5 amendments after the rules. And what are those 5 amendments? One amendment says that the certificates do not, the affidavits, etc., which are to be made for the donors, it is not essential to be from metropolitan magistrate. It can be just simple notarized. That is one change. The second change was that 7 follicle thing is not very rigid. You can take it up till 15 follicles too, and aspirate as many as are there. It is not that you just cannot do it. The third amendment which came over was that in surrogacy there was one, something was fishy there when some people took it this way that the surrogates' gametes can be used. So they have given another clarification that no surrogates' gametes can be used. So no donor gametes for the surrogacy are allowed. The fourth amendment was how you can transfer those embryos from one lab to the other. And the last one is that andrologist, initially it was only MCH urology persons who can do the andrology work, the TISA and PISA which we were discussing today, but now they say that even the general surgeons can do, or the persons who have done DM in reproductive medicine or fellowships. So I know most of us have not done that. We are of that pre-era. So what Dr. Dalal was saying, that just keep a surgeon along with you, and then on paper it is the surgeon. Of course, you are having more experience, so you can do it yourselves. The policies will be made gradually by the state authorities. That's it. Okay, so the way of application, this is just that much. This is the gist which I made. If you want, you can click this picture. That finally, this is for our state, what all paperwork we should do. So that's the compilation which I have done. For self-cycle, these things are to be done. There are total 15 forms, and which form is required where, it is just written there. The ART bank forms are also there in this list. So ART bank has to maintain this form, and if ART bank is taking egg donation cycle, any donation cycle has to be routed through a bank. Everybody knows that. So even if your patient comes over with her sister as a donor, that is fine. It is rather a big relief for all of us, but that donor has to be sent to a ART bank and routed and come back to you. So that is the way you should go about the paperwork. The things which we should now adopt is stop sharing. We should prefer not just to attach to one ART bank. If you have a ART bank in your own setup, then it is fine, but otherwise, if possible, try to attach to 2-3 ART banks. That is a good practice. And all the third-party reproduction should be there through the banks only. We must remember the ages, which is very simple, 21 to 54 females mostly. Keep a grievance cell, and all of us who have done NABH thing in their hospital must be already having that, but other people who are not having, just a simple register to be maintained, and one form of grievance, one form is there in this. That grievance form is to be displayed in your setup. Just display one of the forms so that people are aware that they can address to someone if in case they are having any grievances. This is just a government's way to say that we do our things transparently. MTP registration is not must, but PNDT registration is a must in those list of prerequisites. PNDT registration is MTP का भी column है. There is a column for MTP too, but you can, if you don't do, you are a small setup and doing only IVF practice, you can always write that MTP registration not done because it is not applicable. You have to prepare a number of staff, the list. There is no restriction. Your embryologist could be an embryologist to other place also. He could be available at 10 places. But make sure the embryologist which is working at 10 places should be registered at those 10 places. If you are having your setup with 3 embryologists and you are registering only 2, so that is not done. You have to apply with other embryologists too. And similarly, it is true for gynecologists. If you are the drainage to 3 gynecologists, say supposing there is a neighborhood friendly doctor to you who is doing IUI practices till now, and she is not applied for level 1 clinic, and she wants to do level 1 work like IUI work at your setup. It is not okay. You cannot prepare the semen sample at your place and send it to them. Because you are eligible to prepare the semen sample because you are ART level 2 registered, but that person is not level 1 registered. So the only thing they can do is that they can come at your setup and do it. But make sure if that person is coming at your setup, you register them also as your co-gynecologist. So that is important. Of course, pathologist cannot prepare the sample now. Any gamete handling, no transfers are allowed. There is one more adaptation which I have done recently after reading all this, that discharge certificate is a must. So the thing which I have changed in my practice is that the discharge slip which I usually give to my IUA patients, IVF patients mostly get a big discharge, but IUA patients, we just write it one line, IUI done and that's it. So instead of that, give them a discharge certificate. I know that the patient is not admitted, but still they need to get a paper written or over there, discharge certificate. Whatever you are writing, just writing, give that in detail. Whatever pickup protocol, whatever you've done, just write it down. Make sure that I usually do the procedure, give the original, the pre-wash, post-wash count, I usually give it to the patient. So the only change which I have made is IUI record ke upar I have written discharge IUI record. So that's it. And you are giving the patient whatever record is made for her. You should give it to the patient.
Excuse me.
Okay. Pura, we have 1 minute left. Oh, okay. Okay, so I have to hurry now. Insurance, everybody knows that for donor the insurance is this much. The good thing which has come is posthumous collection, and important thing is that posthumous collection also requires the consent, pre-consent. So that is very, very important. Storage of embryos and gametes can be done for 10 years, and after that all of us have to discard. Most of us who are more than 10 years still having embryos, it is actually required by us that we should discard those embryos. It's a hard thing, I understand. It's very difficult to throw them out, but it is to be thrown. And single women can be availing ART services, but it has to be an Indian woman. The banks, when they are giving the details, make sure that they should write the Aadhaar number only 4 digits, not the full Aadhaar card, full Aadhaar number of the patient, because in that case you are revealing the identity. So that is a small last four. There are people who are doing first 2 and last 2. That is okay, but I have heard that the recent Aadhaar cards, the government itself has started giving last 4 only. So that is the standard practice probably. The donor semen is to have 6 months quarantine still in ICMR guidelines, but let me tell you that there are no guidelines as yet, and maybe the policies will be made later on. At present, there is nothing mentioned about quarantine. Home inseminations, etc. are not to be done. And donors, the semen sample freezing we can still do. For self-gamete, the freezing we can still do, self-cycles. The egg freezing as well as semen freezing. Okay, the last slide is this. If there is a husband of 56 years and embryos were frozen 2 years ago, can we transfer? No, we cannot. Wife is in coma for 3 years and husband wants gamete freezing. Can we? No, because the wife is in coma and she cannot give her consent. There are sad things, but they are the truth. Couple are divorced after IVF and the wife wants to go through embryo transfer as a single woman and the husband does not have any objection. Can they do it? No. They have to route through the code only and cannot go ahead. Can we give frozen semen sample for research? No. Again, we need to have consent. Can the level 1 clinics use gonadotrophins? There is no clear-cut answer, but if they have the facility of observation of, this is what I feel, that if they have facility of ultrasound monitoring, yes they can, otherwise they cannot. Can we take donors from ART banks, even if the banks haven't been registered? Because most of us, the banks which are at present, registration process has not yet been done. So can we use those ART banks? Yes, we can. If they were functioning pre this January 22, if they were functioning, they can still be used. It is okay to take samples routed from these banks. If there is a live-in couple, can they avail these services? No. Any same-sex couple, LGBT couples, no, they cannot take the ART services. Single woman asking, 47 years old, she's asking IVF with donor oocyte as well as donor sperm. Is it possible? It's a very tricky question. Single woman, 47 years old, yes, she's eligible according to the age. But 47 years may we understand that her eggs are not going to be that good. So, DO cycle is allowed? Yes, it is allowed. Donor sperm she can take? Yes, she can take. So, self-womb she can do it. But if she's saying that no, my uterus is also not good and she wants to go for surrogacy, she cannot, because the eggs are not hers and the sperms are not hers, so she cannot go for surrogacy. Wife is 42 years old, husband is 57, Son has committed suicide. Can we do an IVF? No, we cannot, because the son's age is, the father's age is 57. And can we do it because the wife age is 42, the eggs are not good? Can we use the DO? We cannot, because again the age of the husband is crossed, so we cannot do it. Surrogate has failed first time with one embryo. Can we reattempt? Yes, we can. 3 attempts are still allowed. Single women above 21 can use services. Yes, but not surrogacy. That is allowed after the age of 23. Can clinics store semen sample? Yes. Advertisement, is it not allowed? No. For your own setup you can, but for surrogacy you cannot advertise. Can the bank send us eggs on a stimulated donor? No. We have to stimulate those. That is important. Can any walk-in become an egg donor? Yes. Any lady, it is not mandatory that she has to be married. It is not mandatory that she has to have a child. Yes, she can become a donor if she is age more than 21. 21 to, what is the age for the donor? 21 to 35, I think. 35. I just checked the exact age for donor. 35. 23 to 35, yes. Can we do PISA, TISA, etc.? No, we all cannot do because we need a surgeon. Can husband's second wife or live in or this, they can do? No. Even in Muslims, if they have a second wife, they have to produce one more marriage certificate and only then they can do it. Lastly, if you have to apply for the transfer of the application, this is information which is still not available, but I got this information and so I've written. This is the email ID where you have to apply for the transfer of gametes. Thank you so much. And the only thing, last thing which I wanted to say was that in future, the confused paternities would be a very, very big thing for our harassment. And a lot of litigations are going to come another 10, 20 years down the line. So we have to be really wary of these third-party reproduction, and our paperwork should be very good. Thank you so much.
Thank you so much. I will tell you something. I was just going through the ART rules and regulation, and we wanted to start ART bank, which we have started. So there was some confusion somewhere. I want to have your consultation. I am ready to be your consultant.
It's always there. Yeah.
Definitely we will give this presentation to everybody.
I wanted to ask some...
Vitrified sites, why not? Yes, why not? So I think we break for the tea. We break for the tea. Maybe 10 minutes, and after that you would like to roam here for a couple of minutes and then come back, or you start immediately? You want break for a couple of minutes, maybe 30. Tomorrow morning, are you interested in walking to here? Can I tell them to arrange?
Yes, sir.
Tomorrow we are planning to start at 8 o'clock. 8:30 maximum 8:30. So before that you have to finish walk, taking bath, breakfast, and then come. Because tomorrow is short. Many people are leaving. So before 5 o'clock, 4:30 we have to wrap up. So we want to start early. Let's see today how it goes at what time. Meanwhile, let us utilize time. Keep asking questions till everything is set. Yes.
Downregulated FET, when you give depopuration for 3 months and start letrozole, so immediately after stopping letrozole, you start estrogen, or wait for a few days? Or
no, immediately.
Next day you can start. Only tetrage endometrium should be thin.
Yeah.
In embryo transfer, during embryo transfer, like at trigger,
progesterone at the time of starting?
In HRT cycle, if after endometrium is proliferated adequately as per your satisfaction, as per your cutoff, what you believe in the cutoff, I believe 7 millimeter, more than 7 millimeter in FET cycle. So once these criteria are reached and you are satisfied with the endometrium, and both sides ovaries is cool and calm, fission, there is no follicle, I don't go for any testing. Straight away I start progesterone. There is no point in testing for the progesterone because progesterone is going to be normal only, and because of the some lab error, suppose progesterone level comes wrongly elevated, unnecessarily you will end up into the confusion, cancelling the cycle and start searching and calling 10 of your friend or mentor, why this happened, what is the reason, what is the reason, what is the reason. So if it is not required, don't taste. This is about the down-regulated HRT cycle and HRT cycle. If it is stimulated cycle, we'll discuss. He is here, so I think let us start with the discussion. Dr. Pankaj Chakla here.
Sir, one question regarding to the previous question. 3-month down regulation in adenomyosis and endometriosis. But endometrium showing triple line pattern. Once your third dose of chlorpride is finished, then it is necessary to go for a withdrawal bleeding and immediately start because endometrium is triple line.
So what is harm? Suppose if you want to eat something and your stomach is partially full, is there any harm in eating? Stomach has to be empty before you start eating. No. It is not exposed to the progesterone. You are not worried.
Okay.
There is the beautiful thing about the estrogenization is there is no time line for estrogen exposure. The people, they have claimed that up to 8 weeks estrogen exposure is fine, good enough. Some say up to 28 days. Some say after 70 days of the exposure, the result starts declining little bit, which I believe. I normally do not allow estrogenization beyond 17-18 days. So what does that suggest? That suggests that estrogenization, there is no timeline. So suppose after 3 months of down regulation, if endometrium is proliferated, estrogen is coming from somewhere. You should be happy. No problem.
But my worry is that then once I finish my 3 doses and it's endometrium is triple line, now I starting estrogen my own. So it will increase the thickness if it is more than 11, 12, then it's worry if it is more than 12.
This rarely happens. In 9 million, see, you are okay to start progesterone after 9 days of the exposure of the estrogen.
Okay.
I don't think in 9 days the endometrium can grow 14 millimeter. This happens rarely. It happens, but it happens very rarely.
So directly start estrogen is good. No what for withdrawal bleeding. Okay.
And otherwise also I said that in case of adenomyosis and endometriosis, it is better to start with the low dose of estrogen. Not bombard right from the beginning. Normally in endometriosis, we are doing HRT cycle, whether it is down-regulated HRT cycle or normal HRT cycle. So you have adequate time to play. So you can afford to start with a smaller dose, then step up the dose if not proliferated. Unlike stimulated cycle or modified natural cycle, then where you have to, very precise and you have the fixed time to play.
Now, good afternoon to all. And now, after lunch and tea break, all are ready with lectures. Today, thanks for Dr. Rajesh sir and Dr. Sachin sir and all Verdict Gynec members. Because of all of you, we are gathered here to learn something new and new innovative ideas and new techniques and everything new in ARTP. Because our field is like that every day, something new. So I start my talk with ERA and pre-implantation genetic technique, that is PGTA. What is ERA? ERA is a molecular...
Sorry to interrupt you, Dr. Pankaj. Try to give maximum time for the discussion rather than going into too much of the theoretical aspect. That's my request.
Right. ERA is a molecular diagnostic test in which there is a microarray technology which identifies the endometrium in 3 different phases: receptive, post-receptive, or pre-receptive, by expression of 238 genes. That is the main base. And where it should be done, it should be in natural cycle. It is LH plus 7 day. You take the endometrial biopsy and send for the ERA test. In HRT, it is P plus 5 days. All you know everything. And what is the result? That is the important. Results comes in this way. Once your results come, either you in first figure, it is post-receptive, second figure is receptive, and third figure in between receptive and post-receptive. So what you need to change? In first result, you have to do your embryo transfer 1 day before, because your biopsy in post-receptive phase. In second phase, you are at exact time, so you are taken biopsy at the same level. That's fine. And also in third, you have to just early your transfer only 12 hours, 6 to 12 hours. If your result come in pre-receptive phase, then you make your personalized transfer 1 day after the ERA report. That is the result conclusion. And what is the benefit? It identified the window of implantation, especially in recurrent implantation failure, right? And what is the limitation for the biopsy is needed, invasive procedure, and main is that it is not in a same cycle. That's why result is confusing, or there is some limitation, right? And it is also expensive. These are some newer studies. One in July 2022 by author Fulham, that has done 7,052 patients with 17 studies, all randomized control studies. And what they conclude: personalized embryo transfer on the basis of ERA not found to be optimize the gestational outcome. So it is not optimized, right? Another recent study in 2022 by Sarah A. Aryan, what they have studied 2,784 patients. The live birth and ongoing pregnancy for ERA group was not significantly different compared to the non-ERA group. And another 2023 study by Sarah, ERA may not improve outcome in each and every patient seeking for fertility, but it is clear benefit for some specific population, especially in RIF cases and adenomyosis, where there is a maximum chance of window of implantation is disturbed. So these are some studies regarding the ERA. Now the second topic is PGT. PGS and PGT is a formerly known term. Now they have changed to PGS convert to PGTA. PGD convert to PGTM and PGTSR. What do you mean by PGTA? PGTA means pre-implantation genetics testing for aneuploidy. That techniques only identify the embryo that have aneuploidy, either numerical abnormality, either extra chromosome or missing chromosome. That is valid for PGTA. And what do you mean by PGTM, previously called PGD? That is applied when one or both the parents have any single monogenetic disorder. That is to identify the all embryos they are having single gene disorder, like sickle cell anemia, beta thalassemia, all blood related disorder, muscular dystrophy, everything. And third term is a PGT-SR. PGT-SR means testing for structural rearrangement for the chromosome, especially for chromosomal translocation, balance, unbalance, inversion, deletion, duplication, everything regarding that. Now, what are the indications for this PGS and PGD? Especially nowadays for PGS, women with advanced maternal age, more than 35. Couples previous history of recurrent pregnancy loss. Also previous repeated IVF failure. And male factor with severe male factor abnormality, and also patient undergoing chemotherapy. And what are indications for PGD? Couples with any family history of any genetic disorder, X-linked diseases, chromosomal translocation, autosomal diseases, autosomal recessive diseases, that all are indication for PGD. And what are the now benefits for the PGS? PGS increase implantation rate. That is most important one. decrease the abortion rate, and also there is a less abnormal pregnancies, and also it allows you single embryo transfer, so avoiding the chances of multiple pregnancy, decrease time to pregnancy, and also increase its cost effectiveness by cumulative cycle, not by single cycle. And how we are doing this PGTA, PGM, we have at present 3 types of biopsy: polar body biopsy, blastomere biopsy, and trophectoderm biopsy. Nowadays popular is a trophectoderm biopsy, right? These are some pros and cons already we have discussed. And now recent studies. 2019 camels showing this randomized trial with best euploid number with PGTA against the morphological score in a younger age. So what they have concluded, in young patient less than 35 years, infertile patient with at least 2 blastocyst transfer, PGTA blastocyst selection does not result in increased live birth rate. In young patient there is not so much difference. In 2022 studies by Dr. Lewis, regarding the PGTA, they have around 2,633 embryo transfer. There is no significant difference in reproductive outcome when using PGTA in general population. How it is advantageous for patient with advanced maternal age. And last 2018 study, it is Indian study by Dr. Firoza Parikh. They have some conclusion regarding PGT is a major diagnostic tool to prevent transmission of any non-genetic disorder. So it is very useful. It helps in a population who have a high risk babies, those who have a genetic problem. So PGT reduces the repeated failure IVF cycles, also early miscarriages, and also advanced maternal age, right? And also PGM protects the child from inherited any monogenetic disorder. So this is very useful. What Cochrane library says for PGTA in 2022, 28 September, currently available evidence is insufficient to support PGTA in a routine clinical practice. So evidence is from low to moderate for routine use of PGTA. And last in 2019 by fertility and sterility, PGTA did not improve overall pregnancy outcome in all women, especially increase ongoing pregnancy rate with in subgroup those who have advanced age 35 to 40 age. These are all the studies saying more or less similar. Now non-invasive PGT. This is a recent technique, no invasive or minimal invasive. What they are doing, this is a new approach collecting the cell-free DNA released from the implantation, pre-implantation embryos. That is we take cell-free DNA from spent culture medium, and also we aspirate fluid from blastocyst. And these are sent for the genetic testing and sequencing. So this will allow about the genetic study of that embryo. But what are the challenges? It includes lower detection rate of DNA, and also there is risk of DNA contamination with maternal cells. And this is the recent study in 2022 by Mazda Atomic. Cell-free DNA is fraction of genetic material found in a spent culture media and can be isolated and sequenced, and that result is highly co-coordinate with invasive PGTA in many difference. Means result is more or less similar to invasive PGTA, so it's a good thing. Also, what are the advantages in non-invasive? So laser is not required, that is good. Also neither highly trained workforce, means highly trained embryologist is not required in non-invasive, and also it is cost effective, and also non-invasive it's also useful because you are not damaging embryo anytime, so it will give good result. So, and however mosaicism is prevalent in NIPTA, so further research is needed to determine the origin of cell-free DNA. So for non-invasive, all protocols must be standardized, unified before it will be for implementation in clinical use. These are the pictures. For first is the polar body, cleavage test and trophectoderm biopsy, and second figure showing span culture media and blastocyst fluid is aspirated. And conclusion, for recurrent pregnancy loss and recurrent IVF failure, advanced maternal age, severe male infertility, in that case PGTA is useful, it is recommended. And for great improvement in non-invasive PGTA, the spent media have been reported and it is 80 to 95% cone coordinates with trophectoderm biopsy. So it is useful, and PGTM is specially indicated for monogenetic defects, and NGS in genetic technology is also good for nowadays. Thank you, thank you.
Thank you. Dr. Pankaj, what is TERA test? RNA, I'm talking about TERA. Have you heard TERA? TERA is a test. It's error test only, but it's different company. Which company they are doing? Anderson. There is a company named Anderson. There they are calling it TERA test, which is so it is similarly a little bit. I think 28,000 or 27,000. I think.
In ERA test, first they have developed there at time 238 expression of the genes studied. Now so many studies that genes and numbers are increased till 800 genes they have identified. But it's have some limitation also. Nowadays ERA is not supported by all studies. It is helpful in each and every patient.
So you started doing non-invasive.
Non-invasive. In ERA, my experience is I have done, I think, 100 patients in ERA studies, and then from that I have concluded my design for ERA. If previously ERA said that it is post-receptive, and then I do the transfer one day before. Some said some report is pre-receptive. Then after 100 patients, I learn everything, and then once I record documentation with hours. I have transferred my embryo at 120 hours or 120 hours. I have documented. Then fail, then I go for a one day after 144 hours. Again fail, then I again change. So according to that, within 2 to 3 cycles, I got the result.
So the very interesting thing to note, if you look at the implant.
If everything other is good, embryo good, endometrium lining is good, or no any other factor, then you have to choose your personalized window of transfer. There may be something wrong. If all things are good, then you have to change the protocol. But if you have evidence, then it will be helpful.
Yeah.
If you don't know the previous cycle, what I have done, then it is not useful.
So the important and interesting thing to note, whatever abnormal error test, if you notice, 27%, 25 to 27% reports are where window of implantation is disturbed, and majority of them are pre-receptive. You hardly get a report where error is post-receptive. So in most of the cases where window of implantation is disturbed, requires more progesterone than our calculations. So normally whenever there is a recurrent. And second fact to be kept in mind is if window of implantation, there is a deviation between embryo endometrial synchrony for up to one and a half day, there is hardly any difference in the result. There is hardly any difference in the result. So you have already play of one and a half day. Third fact to be kept in mind, the blastocyst compensate for little altered window of implantation. Fourth fact to be understood, when there is you are preparing the endometrium where the estrogen you use in a lower dose, serum estradiol E2 level is low, the window of implantation is still wider. Fifth, when you are using a modified natural cycle or stimulated cycle, window of implantation is quite friendly. So looking into these 5 facts, you should not worry too much about the altered window of implantation, and I think you should not rush for the error test for every patient, or I mean whenever, quite frequently. So what I do, if first transfer fails, second transfer I give progesterone at least 12 hours more. At least 12 hours more than calculation. Some other thing works.
In HRT cycle, window of implantation is narrow, most probably 24 hours. I think, I personally feel. If we go for said that in MNC cycle, letrozole, then it will be widened. So you have to play more with more hours. So it will be good.
Tera's cost is 20,000. Time endometrial receptivity assay Tera cost is 20,000.
So we calculated the cost of non-invasive PGS, non-invasive. What is the cost? First embryo, suppose if you include all disposables, media, plus embryologist charges also included, then first embryo we calculated, first embryo we charge how much? 19,500 if I am not mistaken. 19,500, how we charge from the patient. So we tell them, okay, we want to test the embryo. The first embryo cost 22,000. First embryo will cost you 22,000, and subsequent all embryos will cost 11,500. Am I right? Yeah. So this is how we charge, and which is actual, apart from embryologist, and we don't earn out of that because it is additional. We understand it is additional expenditure for the patient. Already patient is sad because of the repeated failure and all those things. So we should not charge anything extra. So this is almost cost to cost, you can say.
Hello sir. Sir, I wanted to share a very interesting thing. I thought it may benefit somebody. It may or may not, I don't know. So I had a patient who had 2 very nice blastocyst transfers failed. And I did not know because everything was perfect. So I thought I'll do ERA, but I convinced her for an endo trio. So I did ERA, EMA and ALICE testing.
Sorry?
ERA, EMA, which is endometrial microbial assay, and ALICE, the endo trio, which IgOmics say. So I happened to do that. And to our surprise, the ERA was receptive. ALICE, which is analysis of chronic endometritis, all pathogens, that was also negative. But in EMA, we got the report of decreased lactobacilli and increased Gardnerella vaginalis. And they had recommended that you give lactobacillus vaginal for 8 days, the one which is available, and also metronidazole. So I gave it full course, and then and I gave her oral also, and I requested them to do a free EMA again, repeat, so that we know whether it's okay. So they did a repeat EMA, and to my surprise, the report was the same. It was decreased lactobacilli, and then I discussed, and I don't know, I happen to have a doctor from Gujarat also. I've forgotten.
Yeah. I shared the same experience that
So,
I have done with this IgOmics with this EMA test. What they studied the endometrial microbiota, right? And they give with the same report once you taken this ERA biopsy, and with that they give the report. But in all the reports they have said there is decreased number of lactic acid, and so we have given every patient this lactobacillus. There is no need for this.
Time, I gave them again, they asked that it could be metronidazole resistant, so I gave them lactobacilli, and I gave them clindamycin. And I did not have the courage to do a third EMA, so I did the transfer, and luckily I got the result.
Thank you for saying that.
For this endometrial microflora, if you have a previous failure, either 1 and 2, it is better to give. For endometritis, you have to look for the evidence base and then give the antibiotic. For endometrial microbiota, I think it is supplementary for lactic bacilli. It should be given.
Many of us must be thinking, why you want to test for chronic endometritis is looking for the immunochemistry and plasma cells, presence of plasma cells, NCD count and all those things. Why not, rather than that, empirically give antibiotic to all patients? Before transfer, all patients antibiotic. You must be thinking, some of you must be thinking. But mind you, it's not a good idea. Because sometimes if in the absence of chronic endometritis or some evidence of infection, if you empirically give antibiotic, it is harmful. There is a research paper which says that it is harmful. So don't think of giving empirical antibiotic in unselected case routinely before all transfer. Please don't do.
Thank you.
Good evening, everybody. At the outset, I want to thank Dr. Rajesh sir for giving me this opportunity, actually for making me to read. Coming to my topic today is controlled ovarian stimulation in non-IVF cycles. I'll talk in two subheadings. One is basics and another is protocols. Coming to the definition, the controlled ovarian stimulation is nothing but stimulation with oral ovulation with or without gonadotropin for inducing ovulation in anovulatory infertile patients and superovulation in ovulatory patients. We have to aim at least 2 to 3 good quality follicles to get optimum success. At the same time, we have to avoid hyperstimulation. To maximize the success, we have to prevent premature LS surge and premature elevation of progesterone. We know that in follicular genesis, we have two phases. One is gonadotropin independent, that is up to antral stage, it is a gonadotropin independent phase. Once the antrum is formed, it is completely dependent on gonadotropin. Mainly the late follicular phase is more of a LH dependent than FSH dependency. Coming to the thresholds, we know in the previous cycle luteal phase, when the corpus luteum starts degenerating, the ovarian hormones, estrogen, progesterone and inhibin A will starts declining. When hormones declines, the FSH from pituitary starts producing. With the increasing level of FSH, the FSH responsive follicles in the antral pole starts growing. Because of this luteofollicular transition, about 10 antral follicles are recruited in a normal healthy individuals. Once when the FSH increases, follicles also starts growing. But with the increased amount of estrogen secreted from the follicle, FSH again after the window period it starts declining. With the decline of FSH, the follicles which have intense amount of receptors, FSH receptors, dense receptor follicles only will continue to grow. You can see in the picture, the other follicles will start atretic. What is FSH threshold? It is the minimum level of FSH needed for the growth of the follicle beyond the antral stage, because beyond the antral stage only it is gonadotropin dependent. What is the window? The time duration for which the FSH is above the threshold is known as the window period. We can't say a single serum level for FSH threshold like LH threshold, because the follicle of different stages of growth have different threshold. Example, some follicle may be 6 mm size, some follicle may be 4 mm size. It is easy to stimulate the larger size of antral follicle like 6 and 8 mm rather than 2 mm. So different stages of follicle will have different FSH threshold. We can't say single serum level for FSH threshold. This is what happening in the natural cycle. Coming to the stimulated cycle, you can see in the graph that when you stimulate, the FSH is elevated well above the threshold. Even in mild stimulation, what we adopt in non-IVF cycles also, the FSH levels are high above the threshold. When you give letrozole and clomiphene citrate in the initial folliculogenesis period, the FSH level will go elevated above the threshold. But if you want many follicles to grow up to pre-ovulatory stage, you have to extend the window by giving extended letrozole or sequential
therapy with oral ovulogers followed by gonadotropin. This is the basic for stimulation in non-IVF cycles.
Madam, I would request you to restrict your presentation to 5 slides only, and only relevant points, so that we can have more time in further, because this is very interesting topic you have selected. So a lot of questions will be there.
Okay, sir. Why LH is needed in the stimulation? LH is necessary for both the granulosa cell growth as well as steroidogenesis. So in the following conditions, you have to add LH for proper growth of the follicles. In hypo elderly patients, hypo response to RFSH in case of IVF, and even in PCO, you have to add LH. Coming to the threshold, the minimum level of LH is at least 0.8 to 1.2. Below this level will cause impaired follicular growth and maturation. Above this level, that is above the ceiling level, will cause follicular atresia. Coming to the drugs, the oral ovulogers, we know clomiphene citrate will block the estrogen feedback and increases both LH and FSH, though FSH will be more. In case of letrozole, because of the aromatase inhibition, only the FSH will be elevated rather than LH. Coming to the gonadotropins, we have urinary and recombinant. In the urinary, the HPHMG is 95%, the LH activity is driven from HCG, and corifolitrofin alpha is long acting, one injection is enough for 7 days. And coming to the rec FSH and LH, the ovarian hyperstimulation is little more. Many trials have proved that HPHMG is comparable and non-inferior to rec FSH. And a few words about low dose HCG. It has a many number of N-acetyl and O-acetylation sites. So HCG is more potent and more half-life and steroidogenic than LH, and very cheap also. So the main failure in non-IVF cycle is premature elevation of LH and premature luteinization. So we have to decrease the LSH by antagonist, and agonist of course not very much useful in non-IVF cycles. And of course the newer one is relgolex, the newer oral antagonist. How will you prevent the premature luteinization? Not only by adding antagonist, you have to add LH whenever necessary in the stimulation protocols, because in both granulosa cells and theca cells, progesterone is formed, but the granulosa cell is under the influence of both FSH and LH, more of FSH. But theca cell is only LH dependent. So the progesterone formed in the theca cell is converted to androgen by 17-hydroxylase, but progesterone formed in granulosa cell, the 17-alpha hydroxylase is deficient. So this progesterone will go to theca cell and converted to androgen. So in a normal cycles, this equilibrium is maintained. But if you bombard with only FSH, the progesterone will keep on mounting, and it will not be able to convert it to androgen in granulosa cell. So it starts escaping into the blood, causes premature elevation of progesterone. So we all know the dual trigger is more complementary and more successful in IUI cycles rather than HCG alone trigger. You will have minimum number of luteinized unruptured follicles, and follicle not ruptured, the problem won't come. Another excuse me, next presentation also mine only. That protocols. Protocols and COS.
So meanwhile we can have a question till she sets up. The trials are going on, Indian trials are going on. It's not still available.
As of now, the oral antagonist for us is medroxyprogesterone acetate. That is the PQS protocol. So till the time the doctor just this thing, there was a lot of questions in the audience regarding the PQS protocol and why we would be wanting it. Is anybody going to take the PQS protocol?
Dr. Vijay Pawar was there. PPOS protocol. You are going to speak? No.
No, okay. So
okay. Dr. PK Vijay Kumar PK was going to speak on PPOS protocol, but he has not come. So I will take that responsibility. No problem. Yeah, why not?
Sir, actually protocols lecture is mine. Basic is for Dr. Anupama. We exchange, we combine together. I send both the lectures.
Okay, till then we can discuss projection protocol. So how the idea of progesterone prime protocol came? First they started dual stimulation protocol, and what they observed.
When we start progesterone on day 6, the estrogen level is already somewhat higher by that time.
Sorry.
So you said that earlier you were not convinced with the thing that if E2 level is more than 70, then the progesterone, if given along with it, might initiate the LH surge. So now here the estrogen level definitely by day 6 is around 200, 400 something. So then we are adding progesterone at that time. That does not cause any harm towards this LH.
So initial first study, the author thought, hypothesized that this should happen. Yes, we will initiate the LH surge. So it was his thinking, which was not proven. And as I said, it is not only about the estradiol level which initiates the LH surge. It is a signal given by a estrogenized follicle harboring mature oocytes.
It is when you give nitrates with HMG.
You are starting with CC
Now,
with HMG
now,
in this PPO cycle.
Since couple of cases, I have started doing that.
CC plus HMG.
CC with HMG, because both are complementary to each other. CC and medroxyprogesterone.
So CC for first 5 days along with HMG, HMG will continue, and after 5 days you start with this. Okay.
CC, yeah, very important question. Initially I started with 100 milligram. Then after starting 100 milligram, some of my donor either oocytes were very bad, or in some of them there was a premature rupture of the follicle. Then really I was surprised why this happened. Then I went into the research paper on using oral ovulogen in IVF cycle. So I studied deeply, and then I realized that if you use a higher dose of clomiphene in IVF cycle with higher dose of gonadotropin, the LH level during the follicular phase is quite high, maybe in 8, 10, 12, 14. So once the follicle becomes mature, it easily initiates the LH surge and there is a premature ovulation somehow. So because we are not doing extensively hormonal testing, so sometimes I may be wrong also. It's a guesswork. It's a logic, guesswork, endocrinological knowledge. We combine everything because mine is not a research institute. So then I change over. I went through the study where oral ovulation was used with gonadotropin in IVF cycle. They had used 50 milligram only. So now I started using 50 milligram because ultimately then I started researching. Anupama, can you help? Anybody can help? I wanted to understand what is the minimum dose of clomiphene which can block the pituitary. All were milder protocol and gonadotropin was not more than 150. There I did not face any problem. The moment I started using CC 100 milligram with higher dose of gonadotropin, 20 to 25, somehow I was not happy with the follicular.
That's why you have shifted to PCOS in the later. What is the dose of medroxyprogesterone? How do you make 4 milligram medroxyprogesterone?
No, original study 4 milligram.
You
I
use
use 10 milligram.
10 milligram. The last progesterone on the day of menstruation in the morning.
Another beauty of progesterone, after if you are in progesterone trial protocol, you are free to give together, no problem. Unlike antagonist. When you give antagonist, you should have at least 8 hours gap between last dose of antagonist and agonist trigger. But in progesterone trial protocol, no problem. Suppose patient is taken just now progesterone, after 1 hour also you can give the trigger. Ready? Okay, madam. Where is madam? Please enter.
Coming to the protocols, you all know the nomogram for starting. This will be useful for the beginners. When the weight goes up and the antifollicles are low, you have to start with the maximum dose, and weight is less and antifollicles are more with the less dose. The individualized COS is according to the causes. A word about the starting dose for normal responders 75 to 150 international units, high responders 37.5 to 75, and poor we can go up to 225. Coming to the hypogonadism, this is a gonadotropin deficiency situation where no role for oral ovulogens, only exogenous gonadotropin replacement necessary, only HCG trigger, no agonist trigger, no role for antagonist. Of course, luteal phase support is needed with the progesterone and HCG. The word about here is the minimum dose you have to start with 150. You can go up to 600 according to the scan, and the duration may be needed is long, 15 to 20 days compared to routine situations. Coming to the protocols of PCO, the protocol displayed here is from Dr. P.N. Chakravarti's book. It is practiced in IRM Calcutta. It is according to the clinical appearance and clinical features of the patient. If the patient is more insulin resistant, less insulin resistant with less hyperandrogenic features and occasional oligo or amenorrhea, you can start with this protocol. These patients are very much responsive to oral ovulogens. So you can give letrozole or clomiphene citrate for 5 days, and you can add only 1 dose of gonadotropin. And if doesn't work out, you can go for 2 doses of gonadotropin with day 3 for recruitment of the follicle and day 8 for further development of the follicles. If everything fails within 3 to 4 cycles, you can add gonadotropins with the sequential protocol. The gonadotropin you can give on alternate days or daily doses. In case of clomiphene or letrozole routine dose resistant, you can go for this modified therapy instead of gonadotropin therapy in C and D conditions. What is start protocols? You are giving oral ovulogens for 5 days, and with a gap of 5 to 7 days you do scan. If no dominant follicle, again give 5 days. And after 5 to 7 days gap, you do ultrasound. If no dominant follicle, you can give again 5 days. But each time you have to increment the dose. Initially 2.5 mg, then 5 mg like that. The maximum dose, the letrozole is 12 mg per day, and CC is maximum 250 mg. The word in this protocol is, we are starting oral ovulation in the absence of dominant follicle, very remote from menstrual period. Usually what we used to do, after 20 days, no follicle means we will give a progesterone withdrawal and again start with the higher doses after periods. But here you are giving in the same menstrual period itself with the incrementing dose. The same protocol we can follow for random start letrozole. When a patient comes with a period of amenorrhea, 2 months or 1.5 months, you do scan. If the ovaries are silent and endometrium is still, you can straight away start with letrozole instead of giving progesterone withdrawal. But if the endometrium is thick, definitely she has to get withdrawal period, then only start stimulation. In case of extended letrozole, it is 2.5 milligram, we know very well, for 10 days. If you have a fear of the follicle growing, you do ultrasound in between on 7 days, after 6 days or 7 days, then you continue. Beyond 15 mm follicle, you should not give letrozole because follicle has to secrete estrogen. No need to fear about thin endometrium in letrozole because after beyond 15 mm follicle itself will secrete estrogen and you will get nice endometrium. If at all, if you don't get endometrium, you can give estrogen therapy TDS for 1 or 2 days. You will get nice endometrium. No problem in endometrium, unlike the CC. In CC, you will get a thin endometrium. It won't improve with estrogen therapy because of depletion of estrogen receptors in endometrium. In step-up escalating dose, day 2, 3, 4 and 5, each day 1 tablet, 2 tablet, 3 tablet, you are increasing the tablet. The tablet dose is 2.5 milligram. The normal single dose is day 3, single dose of letrozole, 20 milligram and do follicular study. The normal luteal phase CC is, you are giving a CC 50 to 100 milligram for 5 days. Immediately the next day after progesterone withdrawal, the metoxyprogesterone acetate for 5 days. The advantage in this is you won't get thin endometrium, the study says, because you are giving in the previous luteal phase. And because of the synergistic action, you can combine both letrozole and clomiphene citrate. Coming to the phenotype, PCO phenotype A and B, these patients are very obese, stocky and highly insulin resistant and highly hyperandrogenic patients. These patients are usually resistant to oral ovulogens, so you can consider gonadotropins in these patients right away. There are 3 protocols. In step down protocol, you start with the higher dose 2.5 and slowly you decrease the dose. They say monofollicular development is achieved in this case, but beware, you may get multifollicular development and OHSS because we don't know, even if we reduce the dose, which follicles will grow with the lower dose of FSH. So you may end up with multifollicular and OHSS. The preferred protocol is chronic low dose. You are slowly increasing the dose, initially 37.5 to 75. You do scan on 14th day, you increase the dose by 50% or add 37.5 IU REC-FSH and then again do scan after a week and then increase. And trigger after you get the size of pre-ovulatory follicle. In this protocol, the OHSS and multifollicular development is very less. This is the preferred one for PCOS. And in sequential, that is step up and step down, up to 14 millimeter follicle, you do the same way as chronic low dose. After you get 14 millimeter size, you reduce the dose by 50% to decrease the OHSS rate. If you get multiple follicles of more than 3 follicles, you have to ready to convert these patients to IVF or cancel the cycle. Coming to few words about the low dose HCG protocol, this is more useful in case of poor ovarian reserve. So you can add along with the routine induction tablets, you can give a low dose HCG from day 7 or 8 because the LH receptors will form only after 10 mm, 11 mm follicle size after the dominant follicle is reached. So you can give for 3-4 days low dose HCG and you have to dilute the 5000 units of HCG with the 50 ml NS and then you can give 1 to 1.5 cc in that. When you get the size, you can give trigger. According to that, you can go for either IVF or IVF. This is more useful in poor ovarian reserve because HCG is more potent than routine LH. It is very cheaper also for the patient. Antagonist, if you want, you can add to increase the success. A few words about the protocol for poor responder. As in the IVF cases, you can give testosterone gel for 2 months before starting stimulation. Then you can give 150 and up to 225 you can go. For IUI and endometriosis for stage 1 and 2 it is indicated, not for stage 3 and 4. Endometriosis stage 3 and 4 it is IVF. About unexplained infertility, the guideline says it is recommended to use clomiphene citrate with the IUI in the treatment of couples with unexplained infertility. The strength of evidence is strong for this. The alternate protocol is letrozole with the IUI. It is recommended that couples with unexplained infertility undergo a course of 3 to 4 cycles of oral ovulations with the IUI. For those unsuccessful with oral ovulations, IVF is recommended rather than with IUI with gonadotropins. This recommendation strength is also strong. So, to get maximum success in non-IVF protocols, as far as possible, you add LH to prevent premature luteinization, and to prevent premature LH surge, add antagonist in the protocol and adapt a dual trigger to maximize the success. Thank you.
Thank you. So we will take the questions for 15 minutes and then again we will have a short break. Some snacks are prepared and get ready. So we can have all. I was not very sorry. Otherwise we would have taken the same thing. Some diabetes there.
Actually, next topic is trigger only. After you give perifollicular flow of more than a PSC more than a 10 and perifollicular flow is 75% with RA of 0.4 and also size beyond 18 mm you can go for trigger.
I have one question.
Dual trigger actually when you give agonist it will increase both FSH and LH. Timing same like trigger only. Same together we can give.
So when you are using antagonist during a IUI protocol, what trigger you give and do you change anything in your luteal phase support for this patient?
No, you can even give any trigger you can give, but you are giving an agonist means you have to support with estrogen also. But if you are giving a
because you are giving antagonist, you have to support with estrogen.
No.
Trigger.
If you are giving agonist trigger, you have to support the luteal phase with the estrogen. If you are giving SCG, even progesterone itself is enough. But if you are giving dual trigger, no need to support with the estrogen also. Only progesterone is enough. Because you are giving SCG, no, to rescue the corpus luteum.
If we are using antagonist, agonist trigger will not work. We have to have HCG.
What?
Agonist will work.
Sorry.
जय को भूख लगी है
मैं सोचा मैं भी हो गया So I want to ask you people, how many of you agree that irrespective of the ideology in IUI cycle, gonadotropin gives the best result? Maybe 50%. Maybe 50%. I believe gonadotropin gives, maybe it may be a PCOS, maybe unexplained infertility, maybe mild male fertility. Best result you get is gonadotropin only. But the chances of multiple pregnancy is also there. It is not without the cost. Yes?
Indians are happy with multiple pregnancies.
Yeah. Okay. Second question I want to ask, madam, your opinion also and audience opinion also. Still, how many of you feel that in unexplained infertility, clomiphene is preferred clomiphene is a preferred drug for stimulation. Clomiphene, as compared to the letrozole. Sachin will not feel bad, don't worry.
Gonadotropins are better.
No, that is fine. I am comparing between letrozole and clomiphene. So, I would like to draw your attention on two facts. The typicality of the unexplained infertility. When there is a case of unexplained infertility, whether you use letrozole or clomiphene, there is a tendency of endometrium to remain thin only. And this thin endometrium, even after clomiphene in unexplained infertility, and this thin endometrium with letrozole in unexplained infertility does not compromise the result. This is proven.
Like we give clomiphene only for 5 days. That 5-day therapy of clomiphene will also suppress the LH surge.
After last tablet of the clomiphene, next 4 days you are protected.
But then LH surge can occur even later.
Later after, then it has to, it has to. Where is the Parim there?
In donor cycles, if you are not giving CC along with HMG, are you using medroxyprogesterone?
First 5 days CC.
Sir, सब में ऐसे कर रहे हैं आप?
अभी कर रहा हूँ.
अभी कर रहे हैं ना? पहले you were doing HMG only, then when do you start MPA? Medroxyprogesterone.
Day 6.
Day 6.
Stimulation day 6.
तो सर वो आपने बोला कि it starts its action after 5 days. So days, you said the progesterone starts its action after 5 days. So those 5 days are unprotected. No, he said na, CC is taking care of last 4 days. Last dose के बाद 4 दिन तक वो काम कर रहा है. तब तक प्रोजेस्टेरोन का असर आ जाए 4 दिन के बाद. तो अगर हम खाली सिर्फ ये MPA यूज कर रहे हैं with HMG, तो those 4 days are unprotected then.
Yeah, those 4 days.
After starting MPA.
Yeah, but the chances of, what is the chances of premature LSS? It is not as great as you are thinking. It is not as...
So that may be Ekika's thinking that's why you should start from day 2 or day 3. That's why Dr. Ekika was starting from day 2.
This study, they have clearly proven with this protocol, they have not found any premature LSS. They have not found premature ovulation.
So, but the oocytes are very sticky. That's what the neurologist says. Whenever
if you are not convinced, you can try both the protocol and you can see the result and decide yourself.
Thank you.
So basically her question is, I think that you
I
say the
understood.
progesterone effect comes after 4-5 days and you're already starting after
From the
6
5th
days.
day of the tablet, you are protected after progesterone.
I think it's from the first day, but you were saying
I'm telling you
effect comes
second.
after 6
Now
days.
I can tell you the reason. Madam, Dr. Neelam, I can tell you the reason now. What is, if you look at the pharmacokinetics of the medroxyprogesterone, yes, this is the reason. The peak serum level is attained within 4 hours only, once the medroxyprogesterone is taken. Now, it has been endocrinologically, they have studied that exactly what happens. One sided you say that progesterone initiates the LSR, on the other side you are giving progesterone. Still the LSR is not initiated. How it is a dual thing? So the explanation is the progesterone which is rising 50% above the average level during follicular phase, and that remains in that range, that changes the modulation of the LH frequency and all those things, pituitary level. But when the levels are supraphysiological, progesterone levels are supraphysiologically, it exactly acts at pituitary level like agonist. exhaust the pituitary LH storage of the pituitary gonadotroph. So there is no LH left at the pituitary. So where is LH? Not going to go.
So that means it
So
is not
those who
after
have,
6 days.
I think, who has read this study? Who has read this study? I think you were knowing. You. No, I'm talking about you. Fine. So this is exactly explanation. I will show you that slide in my presentation.
So that means it's not
So
after
basically
6
it
days,
is
it's
the
immediately.
pituitary storage of LH is exhausted by high serum level of the progesterone, so premature LH surge does not happen. That's the exact explanation.
So that means it comes within 4 hours, the supraphysiological levels are attained and it is effective. That's the answer. So why do we say that it becomes effective after 6 days? It becomes effective soon after
Complete pituitary shutdown, I mean down regulation, you can say, down regulation. Here down regulation is not required. Down regulation happens after 5 days of the menstrual progesterone.
Thank you, thank you.
Yeah, we can start.
Good afternoon, everybody. So the next talk is about trigger selection in non-IVF and IVF cycles. So just to revise again about the LH surge, what are the physiological events that take place? So once the granulosa cell becomes 11 to 12 millimeter size, it acquires LH receptors. So once the LH receptors are present on the granulosa cells, progesterone secretion becomes 3 times more. It is this progesterone which is produced in the granulosa cells which will cause a rise in the LH level. Also, it will increase the FSH level. So there is high LH, high FSH and progesterone in the mid-cycle. This will initiate the chain of events that take place in the mid-cycle. So the oocyte, which was arrested in the metaphase 1 of meiosis 1, there is resumption of the meiotic activity and the oocyte is converted into a secondary oocyte and the first polar body is expelled. So this completes the first meiotic division and now it is arrested in the second metaphase 2 of the second meiotic division. So that is what we get when we do the oocyte pickup. So it is M2 oocyte. So this change takes place when there is a rise in the LH. Nuclear maturation requires FSH and the cytoplasmic maturation requires LH. And the other changes will be expansion of the COC and detachment of the COC from the follicular wall. There is expansion of the follicle, there is increase in the fluid pressure, and finally there is rupture of the follicle and ovulation. So this is the physiology behind the mid-cycle LH surge and the final oocyte maturation. So this is what we mimic in the triggers that we give. So the triggers commercially available are HCG, GnRH agonist, dual triggers, combination of giving the FSH along with the HCG at the time of trigger, double triggers, and the research molecules kisspeptin and LH. So coming to the IUI cycles, they have compared if there is a natural LH surge against HCG trigger. So they found that the pregnancy rates did not change. But we cannot rely on a natural LH surge, hence we give a trigger in an IUI cycle. When to give the trigger? When the follicle is between 18 to 22 millimeter. Most of the studies have shown that between 19 to 22 millimeter the pregnancy rates are higher. And we have to give a trigger when there are only not more than 2 follicles 15 millimeter or more. Anything 3 and beyond, it is better to cancel because it will increase the multiple pregnancy rates. And also, if there are more than 5 follicles of 10 millimeter size in a TI or IUI cycle, it is better to cancel to prevent secondary OHSs. The triggers given in an IUI or a TI cycle can be HCG, GnRH agonist, or even a double trigger. HCG is a long-acting molecule, so action can be found even up to 10 days. But in a GnRH agonist trigger, we know that early luteolysis will occur, hence we will have to supplement with the intensive luteal phase support. And with a double trigger, again, it has the advantage of HCG. It was found that the pregnancy rates are higher with the dual trigger with the luteal phase support and with the double trigger, but this was not statistically significant. Hence, any trigger is okay in an IUI or TI cycle. Now coming to the IVF cycles, when to give the trigger? When the cohort, most of the follicles are between 16 to 22 millimeter, but better success rates with 19 to 22 millimeter. It was found that the genetic composition in the oocytes is better after 17 millimeter. The gene transcriptions are better after 17 millimeter. So it is better to give a trigger when the cohort, most of the follicles are between 19 to 22 millimeter. So coming to the commonly used triggers, HCG. This is analog of LH, and as I said, it is a long-acting molecule. Even 10% of the activity was found even up to day 10. Now, whether to give a urinary or a recombinant, they both don't have any difference in the oocyte retrieval rate, but urinary, the dose, either 5,000 or 10,000, there was no difference in the oocyte retrieval rate, but the OHSS was higher with 10,000 urinary HCG. And coming to recombinant, either 250 or 500 microgram, no difference in the oocyte retrieval, but the OHSS is higher with 500 microgram. The disadvantage of HCG to be avoided in the if there is high E2 of more than 4,000 picogram per ml to avoid OHSS, and also we don't have the advantage of the mid-cycle FSH rise. Hence, there was about a 16% lower M2s recovered when a HCG trigger was given than compared to a GnRH agonist trigger. And also, after a HCG trigger, the E2 levels are higher, so this high E2 may interfere with the implantation. Next, about the GnRH agonist trigger, it acts on the pituitary and increases the FSH and LH. So we have the advantage of FSH also here, and it was found that as FSH helps in the nuclear maturation of the oocyte, the number of M2s was 16% higher. Either we can use triptorelin or leuprolide, commonly used. The doses of triptorelin can be from 0.1 to 0.4 milligram, and leuprolide can be from 0.5 to 4 milligram. The advantage here is because it is short acting, there is early luteolysis, hence the chances of OHSS are less. And we can use when there is a high risk of OHSS, that is E2 more than 4,000 picogram per ml on the day of trigger, or we can even use in oocyte donors when we are planning a embryo biopsy or oocyte cryopreservation. Whether if we want to do a fresh transfer, in the presence, after we have given a GnRH agonist trigger, it was found that there were many failure rates after embryos were transferred after a GnRH agonist trigger, and then they found that it was because of the early luteolysis. So studies, they started supplementing HCG at the time of the oocyte retrieval and another dose at the time of the embryo transfer. This gave them equal success rates as a HCG trigger. We can even add E2 and progesterone, or we can add a HCG as a part of intensive luteal phase support. Next is the dual trigger here, and the importance in GnRH agonist trigger, if the LH level on the day of trigger is less than 0.5 units per liter, then we are likely to have a trigger failure, and some of the studies show that there may be a trigger failure. And to be more cautious, we can do the LH in the progesterone level 12 hours after the trigger, and if the LH is more than 15 units per liter and the progesterone is more than 3.5 nanogram per ml, we can be rest assured that the trigger has acted. Next, coming to the dual trigger, they added a low dose of HCG, 250 microgram, to the GnRH agonist trigger, and this gave them reassurance that there may not be any chances of trigger failure because the HCG is also there. The other advantage was it was acting as a luteal phase support, so they could go for a fresh transfer, but the chances of OHSS are there if the E2 is high at the day of trigger. Next, there are some studies where we can give FSH 300 to 450 units on the day of trigger along with HCG, which will, because HCG doesn't have a FSH backup, so we can even add FSH at the time of HCG trigger. This is another type of trigger. And the other one described is about the double trigger, not to be confused with the dual trigger. Here we give GnRH agonist 40 hours before the oocyte retrieval, and HCG trigger about 34 to 36 hours before the oocyte retrieval. Other molecules are recombinant LH and kisspeptin, which is only in the research. Thank you.
Thank you. That was very precise, informative. What what is your take on the agonist trigger? Because some studies I have seen, and maybe in few cases I use exclusive agonist trigger, no extraordinary luteal support. Still, the results are unaffected. This is what literature says. What is your take on this? Agonist trigger in IUI cycle. Only agonist trigger in IUI cycle.
In IUI cycles, we have just, it's almost like a natural cycle. We have only 1 or 2 follicles in that. So the amount of LH suppression is not much in an IUI cycle. So although there is early, the duration of action of GnRH agonist is short, only for about 24 hours, but the natural LH pulses are still intact. So even if you don't give an intensive luteal phase support in the IUI cycles, that because of the natural LH surges and the natural progesterone secretion from the corpus luteum is intact, so we need not worry even if we don't give a luteal phase support with a GnRH agonist trigger in PI and IUI cycles.
Sorry, I forgot to tell one more advantage of the clomiphene. If you give clomiphene, the LH, rising LH level during follicular stimulation is not suppressed even if you give antagonist. Is not suppressed. Even if you give antagonist, the LH level will keep like as if it is not given. That's another good thing about the clomiphene. Second question. What is your take on delayed trigger? Do you believe, suppose for some reason, if you need to delay the trigger once your trigger criteria are attained in IVF cycle, what do you think? Are you willing to do, or it is going to have more oocyte yield, the results are improvised, not improvised? What do you think?
So some studies are showing that delayed oocyte retrieval will increase the M2 yield, but there are chances of rupture of the follicles. I would give a backup another.
Yeah, you want to add something? Yeah, please.
The studies which I read about the trigger thing, when the criteria, standard criteria which we want to attain, if we are giving a trigger 1 day earlier, if we are giving on the same day, and if we are giving 1 day later, then they say that the blast formation is 1 blast less. After the total pickup, 1 blast less was the total output of giving a late trigger. Early trigger, it was probably 1.2 blast lesser. So there is a difference when you attain the criteria, that should be the time. Second thing was that in IVF cycle, if you are giving, say supposing your standard is 10-day stimulation, that is the time when you attain it, if supposing your criteria are met in another cycle, poor ovarian reserve or something, and your criteria are attained 2 days earlier, in that case, you have to trigger that patient earlier only. Because here, ultimately what is more important is the size rather than anything else. This is what the net crux was, that the size is the most important thing rather than anything else.
One more thing about this diminished ovarian reserve and early trigger. The another, apart from the size, the another reason, because aging HPO axis can give way and can have the premature LSR in elderly patient quite frequently. One, because of the aging HPO axis, and second, the gonadotropin consumption is higher in such patient. So that also helps in escaping the pituitary. So these are the reason why you need to give early trigger in diminished ovarian reserve.
So what should be the minimum days of stimulation in decreased ovarian? How early means how early we can give the trigger?
How early trigger can be given?
Suppose if the criteria is met by 6 days.
Ideally 8 days stimulation you should take. 8 days.
Maximum stimulation.
If you practically not say IFK, but if you review the literature, there is no such criteria. Once you reach the criteria for trigger, there should not be any problem, and the results are not different as per the literature. But there is some concern about the cytoplasmic maturity versus nuclear maturity. So if the stimulation days are lesser, few people believe that cytoplasm of the oocytes are not mature, is not mature.
In IUI cycle, I feel that if supposing you have attained a size of, with gonadotrophins also, if you have attained a size of 18 and the criteria of giving a trigger is met, but your lining is still not up to your satisfaction, it is okay to delay a day or two. In IUI cycles, you can stop.
In long
lining is also important.
In long agonist protocol, the beauty of the long agonist protocol, you can delay 2 days also, there is no problem. Unaffected results. The problem is the antagonist protocol. If you go beyond one day or 2 days more, then your endometrial embryo synchrony goes away. Then you cannot transfer fresh in that cycle.
So 1 day is allowed in antagonist cycle, not more than 1.
Yes.
So if there is a random cohort of follicle and supposedly the trigger criteria is met that we have 3 follicles more than 17 mm, but the majority of the cohort is in the range of 12 to 13 mm. So, should we give the trigger? Should we give what should be done?
So SRA guidelines, and I follow that. The majority of the follicle should be between 16 and 22 millimeter. That's the criteria. Majority of the follicles. Suppose 2 or 3 follicles has reached, and reached all follicles are below 15 millimeter. That's not a criteria to give trigger.
So the leading follicles, is it chances that the leading
That follicles
follicles
should be allowed to grow at least till 22 millimeter, 23 millimeter by the time the rest of the cohort reaches 15 millimeter.
Can I just add a couple of points about trigger? Of late, a lot of our colleagues are having a problem with HCG 5000 and HCG 10000. That despite giving HCG, the ruptures are not happening. So in cases of IUI, what I would now recommend is rather than giving a single HCG, either shift to Ovitrel or RUCO or give a dual trigger. That is going to ensure that your LH surge is going to happen and rupture is going to happen. That is one thing. Secondly, we are talking about 6-day stimulation, 7-day stimulation. The papers are there where they have said that minimum stimulation should be from 8 days to 12 days, not lesser than 8 days, not more than 12 days. The reduction in the duration of the follicular phase will commonly be seen if you started the stimulation on day 2. Instead of day 2, if you start from day 3, this event occurring, that in 6 days only your follicle trigger criteria has been met, that will never happen. So if maybe the patient was started from day 2, you might want to start from day 3 in the next cycle or henceforward. Yeah, that's one.
Patient's agonist cycle is better. If you're getting follicles done day 6, next cycle go for agonist.
No, so that is a completely different discussion only. We are not talking about the protocol to be used. We are talking about why is probably the reason that the follicle met the trigger criteria in 6 days. I agree with you. This is most likely a patient who is a poor responder. And as we had the discussion outside for poor responders, the best protocol probably is going to the agonist or the long agonist protocol. But sadly, a lot of our colleagues don't know the long agonist protocol. I mean, if we took a look at the entire IVF population in our country, 90% are only following one protocol, that is the short antagonist protocol. They don't know anything about the long agonist protocol, despite Rajesh sir teaching about it so many times on so many groups. So maybe if you have a patient who is a poor responder, trust me, the long agonist protocol is going to give wonders compared to a short antagonist protocol.
Second thing, what is your take on there are few people who believes in because the LS surge following agonist trigger is short lasting. It takes 4 hours to reach, and then within 20 hours it becomes almost nil or basal level, reaches to the basal level. So there are few people who are of belief that agonist should be given at 12-hourly interval so that multiple peaks and so that adequate LH is secreted, and that helps in better luteinization and the ovulation.
So we have tried with both the regimens. We give 0.2 mg on the day of the trigger and then 0.1 mg 12 hours later. or giving just point.
So the long agonist protocol, when you are starting the agonist on the day 21 of the previous cycle, so you are expecting the menses will come on the 28th day or the 30th day usually, normally how it comes, or maybe 1 or 2 days delayed. Suppose you want to delay this menses, so from day 21 can we start progesterone and delay it by a few days?
You continue long agonist, continue agonist till you want to start the
So even if she gets a menses, you continue the agonist and do not start the HMG?
No problem, that's the beauty of the long agonist.
But can progesterone also be a
Why you
not
want to
required?
add? Why you want to add?
So what's your view on stop protocol? This one is stop protocol where we add agonist from day 21, give it for 7 days or 10 days, for which usually down regulate. Then we start stimulation and again start agonist in the second half, like from day 5-6. What is your view for that?
Yeah. I have had strict objection for stop protocol because the earlier studies regarding the stop protocol had concluded two things. Following stop protocol, they observed when agonist was stopped once the stimulation was started, and versus the agonist was not stopped. What they observed in stop protocol, the estradiol level was lower as compared to the protocol where agonist was continued. So they said there is some positive effect of agonist on oocyte. There is some positive effect on oocyte, and because of that, the estradiol level is built up. So I have never used stop protocol. In last 1 year, I think some publications are there, and they have probably, I have forgotten the name of that protocol. They are using stop protocol. I think there is some modification of stop protocol. I have forgot exactly the details, but yes, new publication has come out. But I have not tried.
I just like to add upon what you said about the HCG dose. If you are using recombinant, you are absolutely right. But if you are using the urinary HCG, especially when it is IUI cycle, even if we have 1 or 2 or 3 follicles, the pharma company can throw a little light, but when they get a license to label it as 5,000 units, it can be anything from 1,500 to 6,000 units. So if somebody is of a brand, just may say 1,500 HCG has labeled as 5,000, you are thinking it's a single follicle, have given 5,000, it may not act.
But the physiology is if even if less than 1% of the receptors are occupied, the LH activity is attained.
No.
Even as low as 2,000 units of HCG is also producing good results.
Yeah, but see, if there are more follicles, or even if there is a single follicle, and if what you are saying is right, so if I am using a recombinant version, I may even use as low as what you are saying.
Urinary 2000
in urinary, when they label the drug, when they get the license to label the drug as 5,000 units or say 2,500 units, there is a huge range.
But we are not aware.
We are not aware.
I am listening to, I am
Sir,
for the first time.
Can you throw light on this? You would be better. See, there is, because I got this information from Dr. Padma Rekha Jirge ma'am in the MSR conference, which was the national state conference. And that is why she said that in IUI protocol, she started giving 10,000 to all, not because the requirement may be that much. That is because as per the license,
Anybody else is aware
permitted.
about this? Anybody else?
Yes, the same follicle.
No, forget what Padma Rekha madam has said. Have you read anywhere any publication regarding this?
Nilesh, can you comment?
Protein levels are available in between 80% to 110% in SCG.
How much?
Required proteins level, which is ratio of protein level in between 18% to 110%.
Huh.
So if you see the 18,
Are you talking about protein impurities?
So no, required proteins.
So when you are saying, my ulta question, I wouldn't know what you are saying. When you get a license to label it as 5,000 HCG, does it indicate that it contains 5,000 or it may contain something like 2,000 or 1,500 also?
18% will be the some products, some batches it may be 18%. In some batches it may be 80, and some batches it may be 110%.
So that's fine, 80 to 110% is acceptable.
Because but sir, those batches 18% is there, protein level. That time there is a chances of unrupture things.
No, it cannot be. Why? The minimum ovulatory dose of SEG is 3300. The ovulation, failure of ovulation, chances of failure of ovulation in 3300 and 5000 is very small. It's almost same. There are little difference.
Maybe at that time the weight, if the patient is obese and madam is saying that
So
the
that
weight
obese patient requires higher dose.
so maybe that would be the case.
Okay. The one bad thing about the SEG I am telling you. That's why I keep asking Anupama madam. She gives very good, fantastic result in IU. Okay. So, meanwhile, let us continue some discussion. Previous left, what was left. So I talked about the problem with the SCG trigger. There is a deficient, some window where there is a deficient progesterone secretion, and that needs to be covered either by giving, as Dr. Bhutma said, testosterone or single dose of SCG to be supplemented. So henceforward, please implement this strategy in your stimulation for UI. Okay. What another good thing about, the thing which is to be noted about the agonist trigger.
I'll directly go to the topic. The topic given is empty follicle syndrome and trigger failure. So we have given the trigger. We have discussed about the various options available for giving the trigger, and you give the trigger in IVF cycle. Started the pickup, and the embryologist says that the follicular fluid is clear. Okay, so that means there's some problem. So 2-3 tubes are taken for the screening for the oocytes, and you don't get any oocytes, and then you are really in a limbo. You don't know what to do, and so where we actually then first we do is the UPT. So in the lab you can do a urine pregnancy test on the follicular fluid, the UPT kit, and that will give you some. If the trigger is HCG, okay. So that and if the UPT comes negative on the card, then mostly you are dealing with the empty follicular syndrome. So that is just a preliminary idea. So what is the incidence? The incidence is around less than around 7%. So very, but in practice we have seen less than 1% incidence of EFS. Now, what are the different risk factors that are there? So the most commonly this is seen in cases of your diminished ovarian reserve. So if you see all the patients that are coming to your IVF clinic, around 1/3 to 2/3 cases maybe of cases of diminished ovarian reserve, elderly patients. So these are the high risk cases where you should anticipate that you may get a empty follicular syndrome. Yeah. So ovarian aging, or if you use a mini flare protocol, or if there is a previous incidence of a empty follicular syndrome. So if there is a previous history of EFS, around 15 to 20% of your cases, it can be a recurrent EFS. So very important to remember that recurrent EFS will occur in only maybe 15 to 20% of the cases. Rest of the cases, if you try another cycle of stimulation, you will surely get eggs. So around 80% of the cases of EFS, you are going to get oocytes in the next attempt. So there are different types of EFS. That is the genuine empty follicular syndrome. The second is false empty follicular syndrome, and borderline if it is in between. So what is genuine EFS? In genuine EFS, you have given the trigger on the right time, the dose, everything is right. You have given the good brand, good quality. HCG is given, and still you don't get the oocytes. Okay, and in the follicular fluid, you will not see the COCs. Okay, so you will see the fluid is clear. The cumulus complex is not seen. The granular cells, if they are present, they will not be seen in the fluid. That will your embryologist will tell you, and then maybe you will get an idea that you may be dealing with a case of genuine EFS. And the incidence of that is around 1/3. So around 37% of cases is what is the literature says. So 1/3 of your cases may be
related to genuine EFS, and the rest of them are going to be false EFS. So again, that means that when in your practice, the take home point is that 2/3 of your cases you attempt again, you will get some amount of oocyte. In borderline EFS, in the morning, somebody had asked about the cases where you see many follicles, around 20, 50 follicles you see, and when you do the pickup, you will get around 2 or 3 eggs. So borderline in between. You are supposed to get many eggs, and you didn't get it. So these are the 3 different types that are there. So where can this be possibility? So either there can be inadequate or absent LH surge. We all have in the morning, since we are discussing why the LH peak is necessary. It is necessary for the cumulus oocyte complex to come out, and also for the maturity of the eggs. So error in the administration of the trigger is one of the factor of EFS. The second is error in the timing of HCG. Very common, especially when you are given the trigger to for self administration. So if the patient has taken it at the wrong timing. So wrong timing is given, or error in the administration of the drug. So these are the 2 important things that can cause false EFS. That means there is no problem with the follicles or the eggs. It was a drug that is the problem. So that can occur, and manufacturing defect and low viability. So we had discussed about, sir had mentioned about the obesity and high BMI. The dose required is more, and especially this is again seen in cases of patients who are obese and who have done bariatric surgery, and the dose given is subcute. So always the HCG dose that we insist, if you to be on the safer side, give it on the intramuscular dose. So HCG generally should be given intramuscular, so that this issue of low viability does not arise. Manufacturing defect, cold chain maintenance, these are again very important aspect that one should keep in mind. The batch. Dr. Sachin had mentioned regarding a lot of patients suddenly having problems with some batches of HCG. So that's why it is very important that in our practice, now we are on WhatsApp, so we all know what batches are going, which batch is giving result, which batch is not giving result. So generally we have an idea, so this is what we should share with each other, so that we know what batches are of good quality. Now coming to the genuine empty follicular syndrome. So I have already discussed about the ovarian aging, diminished ovarian reserve, the oocyte apoptosis. Okay, so a lot of times we see there are 4 to 5 follicles on each side, and you do the pickup, you don't get any eggs. So many a times it is because of the poor quality of the eggs, the oocyte apoptosis occurs. So developmental defects are there. These problems do occur, and then another important is the receptor polymorphism. So receptor polymorphism is one of the problem, and now they have found that it can have some chromosomal defects also, pericentric invasion of chromosome 2. So mind you, all these will occur in only 1/3 of the cases. Maximum will be false CFS. Now to conclude the risk factors, you should always see the previous history, advanced age, ovarian resistance, obesity, longer duration of infertility. So the infertility duration is more than 8 to 10 years, then the chances of having EFS is more. High level of FSH on day 2. We had discussed that sometimes especially in the diminished ovarian reserve or the baseline FSH are high. That generally is seen in the low, poor ovarian reserve cases. So if that is the case, then again sometimes you will see a lot of cases of EFS. And then low E2 on the day of trigger, obviously, because that is another. So especially if the E2 is less than 300, you may want to cancel that cycle and go for a fresh cycle. So how will you diagnose these cases? Now you have found that you have done the pickup and you don't get any eggs. So the next step immediately is to send the HCG levels. So if the HCG levels are more than 40, now this is different labs and different papers are presented right from 10 15 milliliters to 40 milliliters. So the general consensus is around, if the HCG levels are more than 40, that means your trigger has been given, and that means those cases are of genuine EFS. You have given the HCG quality is good, but still the eggs are not there. So that is genuine case. If it is less than 40, then you are suspecting that it is a case of a false EFS. Okay, and the other is if you are given the agonist trigger. Now if you are given the agonist trigger, after 12 hours you do the LH level, which should be more than 15 milliinternationals per liter, or better than that is to do the progesterone level. If the progesterone levels are more than 3.5, that means your trigger has worked, but then it's a case of a genuine EFS. So These are the two criteria. So some centers do if you follow this protocol of doing LH levels after 12 hours, and if the levels are less, they give a supplementary dose of agonist or HCG trigger, repeat trigger. So this is how you diagnose. Now, how you manage these cases? So first is you have found the HCG levels are low, and it's a case of false CFS. If it's a case of false CFS, immediately give the repeat dose of dual trigger, or you can give HCG 10,000 units, or you can give recommended HCG of 250 microgram. That dose can be given. Now, when to do the repeat pickup? You can do 72 hours. That is what I have 36 hours is what I follow, or you can do it at 24 hours. So many centers do it at the routine 36 hours pickup. So that is one strategy. Second, now this cycle has failed, you have not got anything, and now you have posted the patient for another cycle. So what can be done in these cycles? So you have to prolong the days of stimulation. That is one strategy. Second is go for a dual trigger. That is very important. And you can also, after the trigger, if you are doing the pickup at around 34 hours, you can delay up to 36 hours to increase the chance of getting the eggs. So this is what is about the antifollicular syndrome. Thank you.
Thank you. Dr. Vijay. You say post-agonist trigger, 12 hours after the agonist, if you measure LH, and if LH is more than 15, and post-trigger, I'm talking, you said more than 3.5, that was a post-trigger, no?
Yes.
Can you revise the slide? Yeah. So agonist trigger 12 hours, post-trigger LH is more than 15, and progesterone is more than 3.5 is the threshold. And you said if this is the value and still you are getting empty follicle, it's a genuine empty follicle syndrome. You said that.
Means if the LH levels are high, that means your trigger has worked.
But the progesterone, if it is more than 3.5, that means trigger is working.
Right. Trigger is working.
But then if trigger is working, if luteinization is happening, then you don't expect empty follicle. Empty follicle you expect when LH level is optimum. You normally after this you expect the LH to be around 40, 45, 15 is the bare minimum. So what is more important is a progesterone level. Rather than LH. So if it is more than 3.5, that means chances of trigger failure are very, very less, very, very less. Those who are empty follicle syndrome, if you measure the progesterone level is normally low in case of genuine empty follicle syndrome. That is what I am trying to tell you. So another thing which I would like to highlight, you say that.
So these actually values are given. So suppose you are getting a patient, there is a history of EFS. Generally we don't do these things. The testing is we not generally this comes previous history of EFS is there. Now you want to know whether in this cycle you want to be doubly sure. So you can do this test, and if you are given, especially if you are given an agonist trigger, not dual trigger. So if it's an agonist trigger, and if sometimes the patient the agonist trigger may not work. So then you do the level. If the level is more, less than 15, then you can repeat immediately give another dose of agonist. So that is the basic thing. Otherwise, generally we don't do it. Generally, then we do at the time of HCG, at the time of pickup, if you see that 3 or 4 your tubes are coming empty, then you do the test on the kit. That is very simple, easily, immediately you will get to have some idea, and you send the beta HCG levels. And if the levels are less, then maybe your next trigger again and doing a repeat rescue cycle. You can say that after 36 hours you can do that.
My point of discussion are two. One, post agonist trigger or HCG trigger. If the progesterone level 12 hours after the trigger is optimum, by chance you have done the levels, yes, and you found a progesterone level adequate, there are minimum chances of trigger failure.
Absolutely.
LH is high, still trigger can fail. But if the progesterone is normal level, within normal level or higher, the trigger is less likely to fail. Number one.
Right.
The utility of progesterone level is where? Second point, I'm coming to that. You said that post empty follicle syndrome, there are few centers doing pickup after in trigger after 24 hours. Some do 36 hours.
Yes.
I have something to suggest. Here comes the importance of the progesterone level. Once the agonist trigger is failed, you don't tend to repeat the agonist. In that patient, you would like to give SCG trigger only. Do you agree? Once the agonist trigger is failed, you will give SCG trigger.
Right.
Now, post SCG trigger, whether to do OCR 24 hours after that trigger or 36 hours after trigger, this progesterone level helps us in taking decision. Suppose progesterone level was this, more than 3.5. After re-trigger, I would do after 24 hours. And if it was less than 3, then I would do after 36 hours. Do you agree? Anybody has to say anything against?
Actually, there are a lot of papers which have done pickup after 24 hours also and after 36 hours also. And
I agree. I totally agree.
Around 40% of them have successfully got 2 sets.
I totally agree. Nowhere, whatever strategy based I have said,
yes.
It's nowhere mentioned.
Yes,
it's nowhere mentioned.
It's a valid point.
Yeah. So empty follicle syndrome has occurred, and progesterone, it's a partial utilization. Maybe trigger has worked partially, and it is likely to, if you supplement LH activity in the form of SCG, then the process of trigger can be completed like that.
Sir, how can we find out it is a case of genuine EFS then? How will we find out it is a genuine EFS?
So if no, for defining genuine EFS, progesterone is not needed. What is genuine EFS? The trigger which you have given that has reached to the follicle, and still the ovidus, you did not
How
get
will
them
we assess it clinically that it is a case of genuine EFS when LH is high and progesterone is more than 3.5? Then what is the use of
I tell you,
trigger again? It is a case of genuine EFS.
this is a partial failure. If progesterone is more than 3.5, it is not a complete failure because partial failure. But it's a process. Probably this patient requires longer exposure of LH activity.
Then what is genuine? What will be the value of progesterone and LH in case of genuine EFS?
That is what I discussed. In case of, genuine EFS, it is not because of the fault of our staff or product. That is called genuine EFS. So genuine EFS is the product which we have used has reached to the follicle. That is genuine EFS. Now second, where the role of progesterone comes when you want to take decision, you want to do OCR 24 hours after the trigger or 36 hours after the trigger. There comes the role of progesterone.
If it's less than
If it is less than 3, that means when you re-trigger, the trigger has not at all affected. The trigger has not at all initiated the luteinization, it has not at all affected. So, after giving SCG trigger, it's a fresh start. So, you have to do it
But if it's
after
a case of genuine EFS, then we won't be able to retrieve the follicle even after giving the SCG trigger. If we trigger, we won't be able to.
No, who said that? If there is a problem with the LH receptor only, LH receptor and agonist is not active. SCG.
Progesterone will rise if agonist has acted. That is why progesterone has value is high. No?
I never said when progesterone level is high, it is a genuine failure. I never said that. I said it is a suboptimal LH activity, which has caused failure of oocyte retrieval, and still the progesterone level was optimal.
But this test has done at 12 hours of trigger, no sir? How will you know whether she will?
Please, I cannot hear. Please speak to the mic.
This test is done at 12 hours of trigger. So how will you know whether she will have oocytes or not? These tests are done at 12 hours of trigger, sir. So these are normal only.
These are absolutely normal. Then you started doing OCR and you didn't risk, there was an empty follicle. So this will help in deciding after next trigger you want to do OCR at 24 hours or 36 hours. This is not a prediction. See, prediction of the empty follicle is where post-agonist trigger, if the LH is less than 15 and progesterone is less than 3, then 101% without waiting, you should repeat the trigger. For sure.
Lot of centers.
Do you agree? Do you agree, Dr. Vijay?
Lot of centers are practicing this policy to prevent EFS. But if the incidence, if you say it is less than around 1% or maybe less than that in practice. This last 7 years, I have seen in my center only I think one genuine case of EFS and 2 or 3 cases we had of false EFS. Okay. So I am doing around 150 cycles a year, not much cycles, but last 7 that is the incidence. It will be very less. What the policy is, if you give the trigger again, like sir mentioned about if you give an agonist trigger, you give the HCG trigger, or I generally give dual trigger, so I don't have to bother what is happening. So after that, one episode of empty follicular syndrome, I have shifted completely to dual trigger. So give dual trigger. Doing these values, especially will be done, especially in cases where you are giving only agonist trigger and you want to make sure that agonist trigger is not failed. So only in case of agonist trigger, we are doing 12 hours. After that, do a progesterone level or LH. Better is to do a progesterone level.
Please come here. Whenever you want to ask the question, please come here.
Can I share one experience?
Yes.
My observation, once I had empty follicle doubt, that day I called you up and you suggested me to get a progesterone level done. This was many years ago. I think from last 2 years, I had made a habit of doing LH levels and as well as progesterone level. I do only one level at day 5 or 6 estrogen, and then on the trigger day, the progesterone level is done in my hospital, and after that, the next day when patient comes, that is my standard protocol. I always do her LH as well as progesterone. So I just wanted to share this, that my lab would never routinely, would never give progesterone of 3.5 or no empty follicles since then, last 2 years. And I've never seen a report of progesterone as high as 3.5. This is quite different. I'm just sharing my experience, but it is always higher than the day which was previous. Yes. It is never 3.5 in my mistake. And in FET cycles, again I do a lot of, in modified natural FET cycles, I again do a lot of progesterone. I see a lot of discussion on Verdict group about progesterone level and transfer. So I wanted to share this, that usually the day of trigger, the progesterone level is 0.25, 0.3, that is the usual range. Right. So whenever I find that the level is this less, I'm quite okay that my trigger is going to work and she'll rupture 36 hours later. But if the progesterone on that day is 0.9 or something, usually I call that patient next day and rupture is there, or I do her progesterone level and I find it around 1 plus 1.5 or something. It is never 3, and I take that this patient is going to rupture very soon. And most of the times she would rupture the same day whenever the progesterone level is that of around 0.8, 0.9.
You're talking about IVF cycle?
This I'm talking about FET cycle.
FET cycle, okay.
Yes. I'm just talking about the progesterone levels, how our thought process goes. The level of 3.5, which we are probably getting an impression that 3.5 is the cutoff, I want to say that it is maybe 1.1, 1.5 is also okay, but you should know the previous one. The rise should be there. It is usually not this high. And after 12 hours, my lab usually gives me a report of around 1.1, 1.5, that is the usual report that I get.
I totally agree with you, but there is some misunderstanding which I want to clear with you. Now let me explain you. Okay. So, with your permission.
Sir.
So when you give trigger, we have to understand the progesterone rise after natural LH surge, after agonist trigger.
So, sir, you said after HCG the progesterone is increasing 5 times.
After 24 hours.
After 24 hours.
Pre-trigger level.
That means in a fresh cycle, if we want to transfer, there's already so much progesterone. Again, we are giving gestone and all that. Is it like what? Where we have to?
मैं तो बोल के थक गया हूँ, आप लोग देते हैं. I never say it. I always say that when you are giving SCG trigger, don't start progesterone immediately. सब लोग लगे पड़े हैं.
उसी दिन करना है वो भी progesterone जैसे.
I never start. In my center, I never start progesterone if I have documented ovulation. If I have given SCG trigger, I never start progesterone 36 hours after trigger. Never in my life. I will not start. Because SCG, the progesterone is already supraphysiological. Progesterone is already supraphysiological. Now the counter argument you will do, डॉक्टर राजेश आप बोल रहे हैं कि हमने ऐसा नहीं करने का है, लेकिन हम तो ऐसा करते हैं फिर भी हमको रिजल्ट अच्छा मिलता है. एग्री मिलता है रिजल्ट अच्छा. क्यों? Because still regarding the progesterone level in luteal phase, what level is more and what level is least, it is not still defined. It is quite tolerant. The receptivity is quite tolerant about the progesterone level, serum progesterone level. In some study it has mentioned up to 100, some study up to 30. So even if you are giving a progesterone in a higher dose in FET cycle, till it tolerates the implant. Implantation window is, implantation window is tolerated. I am tolerating this higher progesterone level. But in case of fresh transfer, you cannot afford to do this. It will definitely change because in fresh transfer already window of implantation 1 or 2 days earlier, 1 day earlier, and if you give such a high dose of progesterone immediately, it is likely to change the implantation.
So when should we, after 48 hours, if in fresh transfer for progesterone?
I never start on the day of pickup.
On the day of pickup, no.
Okay. Within 48 hours I start progesterone.
Another important thing about the level of LH that has to be done at exactly 12 hours because the LH levels fall very fast. Progesterone levels, even if you do it 13 hours, 14 hours, it will be fine. So whatever time you have given the trigger, exactly after 12 hours you have to do. You can't do it too early or too late. You will get a wrong value of LH. So that's why more reliable is the progesterone compared to the LH. Thank you.
So the next topic is luteal phase support in non-IVF cycle. So we have passed the luteal phase. It is the phase from ovulation to the positive pregnancy test or to the ovulation. Or the menses. Now we all know that we require luteal phase support in fresh transfer and IVF cycles. But in a TI or a IUI cycle which resembles a natural cycle, do we need a luteal phase support? And if we need, which are the cycles which require support? To know that, we have to first define what is a luteal phase defect. There is no strict criteria to diagnose luteal phase defect. Several theories were proposed that since the luteal phase is from 11 to 17 days, anything less than or equal to 10 days luteal phase was taken as presuming that it was a luteal phase defect and luteal phase support was given. But this theory did not work because even 5% of the normal fertile women also have a luteal phase less than 10 days. So the next proposed was serum progesterone level mid-luteal phase less than 10 nanogram per ml. Again, we know that progesterone has a pulsatile secretion in the luteal phase. So whether it is taken in the trough or in the peak phase, the levels may go below 10, and again this theory was disproved. The next theory was about the endometrial biopsies, and again there was discrepancy between a fertile and a non-fertile cycles. There was an endometrial lag. So since we do not have a definite diagnosis for luteal phase defect, Now we have to define which cycles require luteal phase support. So finally, anything associated with defective folliculogenesis. If the follicle development was defective, then the granulosa cells produced less progesterone in the luteal phase. So these are the cycles which require support in a TIL and IUI cycles. So commonly we have the PCOS, endometriosis, we have the thyroid disorders, hyperprolactinemia, aging lady, obese, and stimulated cycles, that too with the gonadotropin stimulation cycles, we need a progesterone support. Stimulation cycles, it was found that CC does not require luteal phase support because it is a long-acting drug and it will continue to stimulate secretion of LH. All the others, especially the gonadotropin stimulated cycles of TI and IUI, require luteal phase support because they increase the estrogen levels and the progesterone levels in the luteal phase, which may suppress the LH pulses. Hence, they require support. Especially the progesterone after gonadotropin secretions is high in the first and the mid luteal phase. But after 8 to 10 days, even after a HCG trigger, there will be a luteal lag before the HCG secretion from the embryo begins. So this luteal lag gap has to be covered by the luteal phase support. So these were the cycles which required a support. Next, what type of support? There is again no consensus which drug can be used, which is the best drug. Oral dydrogesterone can be used, and oral micronized progesterones, vaginal gels, HCG can be used as a support. Now, when to start? As now discussed, we can most of the studies have started after 1 day or after 2 days after an IUI. I usually start 3 days after an IUI because the early phase there is enough progesterone support. We need not hurry with the progesterone starting, and then we can continue. Until when should we continue? So either we can stop once the pregnancy test comes positive because the HCG from the embryo will maintain the corpus luteum, or we can continue up to 8 to 10 weeks when the placenta takes over. So this is about the luteal phase support in non-IVF cycles.
Thank you. Dr. Would you agree? There are some papers also that in CCIOI cycle, if you provide luteal support, the results are better. I have come across this paper.
Most of the papers have shown that because CC is the recent guidelines about ASRM guidelines about luteal phase support shows that CC clearly does not require a luteal phase support.
Agree.
But if CC is combined with gonadotropins, the data is not complete.
Yeah. So normally simple rule we follow. If gonadotropin is used or IUI is done, luteal support will be provided. That simple rule we follow rather than getting
better to
confused.
start 2 to 3 days after the IUI.
Absolutely, I strongly favor that. Any other questions?
Even after letrozole and letrozole combined with gonadotropins, the data is not complete. This is the ASRM guideline.
Okay, thank you. So what is the next topic?
Good evening all. My half of topic has been covered by Dr. Anupama. Thank you very much. Will not go in much detail of pathophysiology of progesterone and why it is needed. In other conditions where it is needed, she has already mentioned. But why in ART? It is not optional in ART. It is mandatory in ART to give progesterone or a luteal phase support. Luteal phase support, it is one thing is progesterone and the other drugs which are mimicking action like progesterone, or a luteal phase support for recurrent implantation failure cases. In these three, we can divide luteal phase support. Why in ART cycles? There is abnormal luteal function after stimulation of IVF. There is suppression of LH due to continued down regulation by GnRH agonist. Then there is a lot of removal of granulosa cells at OM pickup. There are supraphysiological E2 and T4 in early luteal phase, and all of us know E2 and FSH. They are inversely proportional to the progesterone, all leading to progesterone deficiency. So, what options we are having as a luteal phase support? As all of us know, there is nothing new in saying progesterone, then progesterone plus estrogen, then HCG, then GnRH agonist, then prednisolone, aspirin, heparin, ascorbic acid, immunoglobulins. There is a lot of variety. So we cannot pump all these medicine in one patient or as an empirical, giving patient so many drugs. So we'll divide it into progesterone is mandatory, then progesterone and estrogen. Estrogen, if agonist cycle down regulation has been done, then estrogen has to be added. Then GnRH agonist in some few cases, prednisolone in cases which we suspect in immunological cause for implantation failure. Then aspirin, heparin, ascorbic acid and immunoglobulin, these are same group of drugs. So how progesterone acts? What is mode of action of progesterone? It improves endometrial receptivity, it promotes local vasodilatation and uterine musculature quiescence by inducing nitric oxide synthesis in deciduum. So the uterus remains quiescent. It also acts as immunological suppressant, blocking Th1 and inducing release of Th2 cytokines. There are two groups, natural progesterone and synthetic, that already has been discussed. So progesterone, there are a lot of controversies, a lot of pharma companies approaching you that they say that our oral progesterone is better, our vaginal gel is better, capsule is better, intramuscular progesterone is better, subcutaneous progesterone is better. So we'll discuss one by one. What are the advantages of intramuscular progesterone? It is effective, it is definitely means you are injected, blood levels will be achieved. But what are the disadvantages? Initially we used to have oil-based progesterone, those were painful, long thick needle we used to use. Then occasionally we observed sterile abscesses because sometimes we cannot call patients daily for progesterone injections. They say, "Amche the local doctor, shall we take over there?" So abscesses were found with such people. Then occasional allergic reactions were also observed due to oil vehicle. And there was a need of a trained person to administer it. These are the disadvantages of iron progesterones. In few cases, this is just a paper. I don't think anybody might have observed this. Just to mention, acute eosinophilic pneumonia was observed with IM administration of progesterone. If somebody has come across, please let me know. Then subcutaneous progesterone. Nowadays, aqua-based progesterones are available. It is water soluble and it is less painful. I think this is the drug which we are looking for. Aqua progesterone is better compliance. Then comes oral progesterone. Ineffective. There is a question mark because sometimes people say, patients they say it is very uncomfortable for us to put a vaginal, put it vaginally. That time you cannot say, don't take it. We have to give them, so we advise them, okay, you can take it orally also. It is a low bioavailability, then high rate of metabolites in the blood, high rate of side effect, that is somnolence, bloating, then gastrointestinal disturbances are observed with oral progesterones. Dose, mostly frequently it is 300 to 600 milligram or daily, spread over 2-3 doses. vaginal progesterone, it is definitely effective. Self-administration is possible compared to intramuscular. Then it is targeted delivery. It is directly acting at uterine level, uterus level. Might require multiple dosages. High uterine concentration of progesterone is observed. It minimizes the potential for adverse systemic reactions. Then vaginal gel or capsule form. Studies have observed that both results of both are same, but capsule form is less expensive than gel. So capsule form will prefer. The same thing we have discussed. Now progesterone is over. In which conditions we give heparin? In my practice, I give only progesterone as a support. If a patient is second cycle, repeat cycles means first cycle was failed, implantation failure was there, then you can consider of heparin. This is maybe a bold statement, but I don't give heparin for all the cases of IVF. So what is the mode of action of heparin? It has got anti-modulatory action, it has got anti-inflammatory action, it has got anticoagulant action. It results in adhesions of blastocysts to endometrium. See the action, mode of action, anti-modulatory, anti-inflammatory and anticoagulator. It has nothing to do with progesterone. So it is a luteal phase support which is of some other category. And the various studies have shown it is effective in RIF, not needed in all cases of IVF. Prednisolone, again, if you are thinking there is any cause, any etiology of immunological cause for implantation failure or failed IVF cycles, then you can add prednisolone. What is the mode of action? It decreases NK cells, cytokines and inflammation at the endometrial level. Dose is 10 milligram daily. Few people are giving is 5 milligram also. It's 5 to 10 milligram you can give. Then sildenafil mode of action is selective inhibition of cyclic GMP phosphodiesterase pathway that releases nitrous oxide, that causes vasodilatation, that causes increased thickness at the level of endometrium. Dose 25 to 75 milligram per day. E2, there is no effect. If only your there is no effect in antagonist protocol, you may not give if you are doing the antagonist cycle. Low dose aspirin, same again, platelet aggregation, then increase ovarian and endothelial blood flow. It acts as a TXA2 level. The dose is 100 milligram per day. SCG, big no, because action of SCG is mimicking, it helps to increase progesterone only, and progesterone is easily available, so there is no need to give SCG. Then these are research-based GnRH agonist in mid-luteal phase. In that, 3 doses of 1 milligram injection of leuproid subcutaneous is given on 6th, 7th and 8th day of the oocyte after oocyte retrieval. Then luteinizing hormone, these two, I don't think anybody is practicing. Just to mention, I have included this. Now take home message in luteal phase support is ovarian stimulation in IVF destroys luteal phase function, hormonal levels and endometrium behavior. So luteal phase supplementation with progesterone is mandatory. When to give, that everybody, Anupama madam also mentioned, from day of the egg pickup to the heartbeats are observed or cardiac activity is visible. Till that time you can continue. No need of estimating serum level every time. SCG, OHS series should not be used. Estrogen should be used with progesterone. Role of GnRH agonist controversial. Role of heparin and prednisolone in recurrent IVF failure or recurrent abortions. If IVF is done after recurrent abortion, then you can add heparin. Role of sildenafil in thin endometrial thickness only, not in all cases. No role of luteinizing hormone, aspirin, ascorbic acid. Thank you. ये थोड़ा उल्टा हो गया, पहले मॉनिटर दे दिया, अभी मॉनिटर कर रहा। Let me put some disclaimer. Just a minute. Monitoring IVF cycle, it is just like a surgery. Means it has got an individual approach. There is no generalized rule. No, you cannot put monitoring of IVF cycle that this is the only way one should do it. Surgery, as I am doing in some other way, Dr. Dalal may be performing other way, or somebody sitting over here may be doing another way. That is the way. That's how you should take at the monitoring of IVF cycle. So let's see what we mean by monitoring of IVF cycle and what are the methods of monitoring. We got only three options, so three methods for monitoring. One is ultrasound, very popular. Second is hormonal, and third is combining ultrasound and E2. It is little bit controversial. But third, I take it, I am strong believer of only ultrasound and ultrasound. But if my first case has failed, then second time I may think of supporting with hormonal levels with that. That's how I go ahead. I am not very much trained in power Doppler and imaging, so I will have to rely on some radiologists for that. So I developed myself monitoring with 2D sonography only. What are the objectives of monitoring? Prediction of ovarian response prior to stimulation. So what yield you are going to get, whether you are going to get 2 follicles, you are going to come across with OHS, that you should predict. Then monitor the effect of pituitary downregulation. Unless and until it has achieved, you cannot start your IVF cycle. Then evaluate dose of gonadotropins. It is very important. Then find the exact time to give trigger. Thanks to previous speakers, they have covered this topic. Then prevention of cycle cancellation. This should be the aims or objectives of monitoring IVF cycle. Then how to predict ovarian response, poor or hyper. Methods, again AFC, AMH. If antral follicle count is less than 6, then you should think, or you should keep in mind that long duration of stimulation will be required. That means instead of 10-11 doses, I am talking about antagonist cycle, 15-16 doses may be required. Higher dose of gonadotropins may be required, or you may require RFSH also. Less oocytes are retrieved in single digit. Increased risk of cycle cancellation before OP. Why this is important? If you previously tell your patient that you are going to get only 2-3 cycles, again we'll have to repeat. We are going to ovarian pooling. That will increase the confidence of your patient in you. If more than 16, these are higher responders, you have to be very careful that they should not land up in OHS. Now, counseling the patient has been done, you know how much yield you are going to get. You are going to start stimulation. How to confirm down regulation? Again with hormonal assays and transvaginal sonography. Transvaginal sonography, if there is, you should start. What are the criteria of down regulation has occurred? No residual cyst, number of small follicles. Remember 8 mm size, not 6, 7. Less than 4. If less than 4 follicles are there, down regulation has occurred. Endometrium thickness less than 6 mm. Then ovarian resistance index 0.9. If these criteria not match stimulation, you can think of postponing. Then selection protocols according to AFC, antral follicle count and AMH level. Then adjusting the dose according to the levels and the follicle, the yield. AFC less than 7, AMH less than 1.1, dose you will give 375 international units. Protocols, you got so many options of antagonist, flare protocol, agonist protocol, natural modified natural cycle protocol, or you can add growth hormones also. Average 7 to 14 follicles, enter follicle counts, AMH 1.5, 1.1 to 3.5, then dose you start with 225. Antagonist protocol is better. You can go for long protocol also. One thing is there that in all the three you can use antagonist protocol, then why not antagonist protocol for all? So it is very important how to monitor a dose of gonadotropins is adequate or not. We scan the patient on day 6, day 8, day 10. On that day, if it is I'm talking about my first cycle, it is not a failed cycle, so it is totally based on 2D ultrasound. On day 6 of stimulation, if less than 5 follicles are there, if follicular size is less than 5 millimeter, although if more than 4 follicles are also there, 6 follicles are there, but they are of size less than 5 millimeter, then increase the dose. E2 levels, that is added just to mention, less than 125. Then decrease the dose if more than 8 follicles of size. More than 8 follicles are there of size 10 millimeter, then decrease the dose. Lead follicle is more than 12 millimeter, decrease the dose, or E2 level more than 500 picogram. Similarly, day 8 stimulation, if less than 5 follicles are observed of size 10 millimeter, or if the standard thing is 2 millimeter per day growth is not observed, or E2 less than 250 picogram per day is not there, then increase the dose. And decrease the dose if more than 8 follicles are there, then E2 levels is more than 1000 picogram, or there is a 200% rise in 2 days. If on day 10, lead follicle is of less than 16 millimeter size, or growth is less than 2 millimeter per day, increase the dose. Remember, this is the 10th day, you got 3 days more. So in that, the changes can occur. And decrease the dose if lead follicle size is more than 20 millimeter on day 10 also. On that day, I'll suggest to give do P2, P4 levels also. And I'll see endometrium also. If it is early luteinizing changes are there, if follicle is of 20 millimeter size, then you can, or HCG, E2 plateau is there, then you can think of giving trigger on that day also. Prevention of OHSS by ultrasound. If PCO pattern is there, number of follicles are more than 20, then if follicle size is less, that means it is 10 to 12 millimeters, and number is also more, then you should not worry that that patient is going to land up in a OHS. If you are doing E2 levels, then if less than 3500 picogram, no hyperstimulation syndrome is observed. If 3500 to 5900, that means 3.5 to 6000, roughly you can take. 1.8% patients will land up with OHSS. If more than 6000, 38% patients will land up in ovarian hyperstimulation. Remember that do not trigger ovulation with the intention of fresh embryo transfer in women who have E2 levels more than 3500 picogram or more than 20 follicles on ultrasound. This we have discussed in detail. Then cycle cancellations. What are the indications when we cancel cycles? If follicular growth is delayed, that means ovarian stimulation more than 10 days and less than 3 follicles of more than 16 mm, cancel that cycle, don't go for pico. Unless and until it is a case of poor, very low AMH and 2-3 times you have tried and no follicles are observed in previous cycles and 1 or 2 also you are getting, that time you can think of doing own pickup. Hyperstimulation syndrome is suspected in each ovary contains more than 10 follicles, that is more than size of 16 millimeters. One follicle contains more than 100 levels, so 20 is more than 2000. So basal LH is elevated, that is LH is more than 10 international units. That times, or a premature LH surge occurs, that time you can think of avoiding cycle cancellation. Sorry, you can think of cancelling the cycle. Elevated serum P4 level more than 1.5 is detected prior to ovulation induction. That time you can think of cancelling the cycle. Thank you very much.
Thank you. We'll take up some questions.
If we are giving the re-trigger, should we repeat an anti and then follow
if we are giving a repeated trigger in case of EFS, genuine EFS, if the progesterone elevation is already there, is it better to give an anti followed by trigger because the processes of ovulation would have already started?
See, if you re-trigger, following, obviously you are going to give the SCG trigger. If you give antagonist, the antagonist action takes 6 to 8 hours. Right? Am I right?
Yes.
And if you give SCG trigger, the rise in SCG level is more faster than LS surge by agonist trigger. If you give agonist trigger, this rise is quite faster. So by the time antagonist starts acting, the already SCG level has crossed to a significant level. So I think it is not rational. That's what I feel. I never tried, never thought also. So that's why I started thinking when you asked the question.
Okay. And sometimes they give a report as empty cumulus, no? So should it be considered as EFS or is it different?
Yeah, empty cumulus, what happens when if trigger has failed, the cumulus is not able to get separated from the follicular wall. So there is no cumulus. The OCC is not even, the oocyte is, is not retrieved, and cumulus also is not retrieved because it is compact attached to the follicular wall.
The starting day of progesterone in FET at the lunar cycle means OD cycle.
Sorry?
Starting day of progesterone means when to start the progesterone in FET or to in the donor cycle. To the recipient. Progesterone, when will start the progesterone? In HRT, suppose in HRT cycle, yes. Ideal.
Okay, you mean to say when you think that endometrium is okay now.
Okay, now I want to start the progesterone.
Exactly, okay. So in fresh cycle, in non-ideal cycle, I keep cutoff 7 millimeter. In FET cycle, 7 millimeter. In non-ideal 6 millimeter. FET 7 millimeter. Fresh 8 millimeter.
Okay, and according to the hours of embryo, what should be the exposure of progesterone? Like suppose we are counting like in pre-reception.
Exactly same.
Okay.
Hours of the embryo is equal to hours post-trigger or hours of the progesterone exposure.
Okay. In both the or like then according to
if you want to deviate for some reason, for suppose your embryologist is not available or you have some function to go and something, then it is better to have 12 hours extra exposure of progesterone rather than less exposure. Dr. Kasturi, you wanted to say something?
So, empty follicles.
EFS, there is a lot of confusion with the talks because about genine EFS, we all have the doubt. So I want you to explain what is genine EFS, then I'll ask other questions.
Now you have teamed up with Dr. Bharati. Trap me. Okay. Sorry. So, as I said, the genuine empty follicle syndrome means the drug which is meant for initiating all the cascade of ovulation has reached to the site, but still that cascade reaction has not initiated. Am I right? So that's a genuine empty follicle syndrome. So there are certain levels, serum levels, which are expected for a trigger. For example, after SCG, let us talk about genuine this definition only. So how do we know? How do we know? We know by serum level. Still more precise way is measuring follicular fluid, because that is the perfect site of the action, right? So if the follicular fluid is available to us, better to measure in follicular fluid only, right? So if the follicular fluid estimation, if we do, and if the beta SCG is positive in follicular fluid, and if the agonist trigger, the LH kit test is positive, that means the agonist trigger has acted, the pituitary has released LH has reached to the follicle, and still that cascade has not been initiated. So this is genuine empty follicle syndrome. When you are aspirating, and after 6 or 7 follicle aspiration, you do not get any OCC. It's a genuine empty follicle syndrome. Now, please ask next question.
LH kit test in agonist trigger, post agonist trigger, if we are finding empty follicles, we should check for LH kit in follicular fluid. What is the reliability of LH kit? Many of times.
But that will give immediate answer. I mean, at some, rather than be remaining clueless, it will give some idea, because what happens and then simultaneously what we do, we take serum level also. But serum level takes time to, at the time progesterone also can. We take progesterone also.
Progesterone also from follicular fluid.
No, serum level.
Serum progesterone.
Serum progesterone, serum LH, if it is agonist trigger, follicular fluid, LH testing, urinary kit with urinary LH kit. If it is SCG trigger, UPT from the follicular fluid, serum progesterone level, serum beta SCG. And we wait for the report, and depending on the report, we decide, we re-trigger. But then when to do aspiration, that we decide based on the report.
In serum, LH will come high after agonist trigger, even after 36 hours. Because LH surge has already occurred, so only progesterone will come high, no? LH will not come high.
LH will not come high.
So there is no value of doing serum LH.
Serum LH value is there because it is, if LH is okay. So now empty follicle syndrome, there are 2 scenarios, as described by Peter Himalayan. You are expecting 12 hours after trigger 15-3. If it is less than 3, 15 and 3, you have to re-trigger immediately, don't aspirate. And if it is more than 3 progesterone and LH is more than 15, go ahead. And there is a middle way where SCG is 45 level and progesterone is 0.5. And on another side, the LH is less than 10 and progesterone is 6.5. So in both scenario, with calculated risk, you have to do aspiration and see and decide further. This is described by Peter Mayer. Now, this is before aspiration. Now, we are talking about after aspiration. After aspiration. So, after aspiration, we want to understand whether LH has reached or not. We have given agonist trigger. After 36 hours of the agonist trigger, there is hardly any LH, but LH is less than 10. Still, LH is less than 10. But it's not like that LH is 1 unit or 2 unit. Till at the time of ovulation, if you measure the LH is less than 10. Okay, so there is some role, at least. Around 10. Yeah, around 10. You are expecting around 10. But progesterone will guide you when to do, because next important question is after re-trigger when to do the pickup, 24 hours or 36 hours, that's a crucial question. And nowhere it is described, nowhere. You take any study, nowhere it is described when to aspirate after 24 hours after re-triggering and when to aspirate 36 hours after re-triggering. So this is a strategy which I adopt.
Sir, one question. Is there any effect of antagonist heterorelics on ohm quality? Means sometimes the size is achieved and before you start this thing, heterorelics, that time only you are given trigger and then you have done pickup. Is there any?
There are some concerns about the role, the effect of antagonist on side, because ultimately if you go to the basic of the action, the antagonist is cell cycle inhibitor. This word has been used, cell cycle inhibitor. So in early dividing cells, the structure where there is a division of the cells and cells are getting multiplied, their antagonist may have adverse effect. That's a concern. But practically, we use antagonist till last day. We trigger, we transfer fresh also. But if you go for why it is not affected much, because the half-life of the antagonist is somewhere around 20 hours, approximately 20 to 30 hours. So maybe the antagonist in circulation next 4 days maybe. So till 4 days that risk is there. But after 4 to 5 days that risk is not there.
Sir, in long economics protocol, which formulation is superior, depot or daily? For down regulation.
Down regulation, okay. If you use the depot, the good part of depot preparation, now a lot of companies, they have come up with the depot, and if you read on the package, it is written it can be stored in 25 degrees. Have you observed? How many of you have observed? It can be stored at room temperature. That's a good thing. So you are not worried about the losing potency. That's a good thing. The problem with the agonist report, if you use the agonist report in a full dose, your monotropin requirement is tremendous, I tell you. The stimulation, the follicle will not meet the trigger criteria before 13 days. So these are the problems with the long agonist long agonist report. So this is a problem with the agonist report. Third problem with the agonist report, there is a profound down regulation. So hypoestrogenic symptoms like body pain and all flushing and all those problems keep happening. This is not important. So to alleviate this, I recommend in stimulation cycle, use only 1/3 of Luprat depot. 1/3. The rest throw away. Because as per the study, 1/4 of Luprat depot is sufficient to cause the pituitary down regulation, and you can, after 14 days, you can very well start a stimulation. But if you observe the powdery or reconstituted solution of the Luprat depot, precisely it is really difficult to give 1/4 dose, because if you dilute with the 1 ml and at the end you get 0.7 ml only. You have observed that if you dilute Luprat depot, suppose you use 2 ml diluent, you get only 1.7 ml when you aspirate from the solution. So it is really difficult to precisely divide into 1/4. So normally we give 1/3 to 1/2 dose of Luprat depot when we want to stimulate. This is plus and minus of the Luprat depot. Now coming to the daily dose. The best part of the daily dose, you have flexibility. So when I give a daily dose, normally I give higher dose in the initial part. Mid-luteal phase, I give higher dose. Done a different way. But I normally give 1 milligram till the down regulation happens, and then straight away I'll make it 1.25, 1/4 dose. Straight away, 1/4 dose. And that is good enough to maintain the down regulation till the trigger. If you do not want to change the dose, then 0.4 ml is a good dose. Continue unchanged dose of Luprat depot daily injection. The problem with patient has to take the daily injection. That's the biggest problem. Here with depot, if it is taken next 28 days, you are not worried.
In point of oocyte quality, blastocyst formation and ongoing pregnancy rate, both are same?
Same. Okay. There is no difference. Even flare effect is also there. I have tried sometime Luprat depot used as a trigger. It serves both purpose. If you give Luprat depot, it acts as a trigger, and don't try. Just experimentally I have tried in front of the donor. Please do not try. So it really acts as a trigger because there is an initial flare effect, and following that there is a down regulation. So suppose if you want to transfer, start initiating the HRT cycle, down regulated HRT cycle, you after 14 days you get a really good picture of the ovary and you can start endometrial preparation. This is all experimental.
Sir, my second question is maybe common of all ART specialists. Which recombinant FS is better, original or biosimilar?
See, I always
in point of cost effectiveness.
I always prefer cost effective solution.
Sir, before that, please explain what is biosimilar. I really
Biosimilar.
What is biosimilar?
Biosimilar is what is except your Gonalef and Decalcon. What are the biosimilar?
Why do we call the rest of the biosimilar? What is the difference between the original and the biosimilar? What is the difference between maybe manufacturing or what is the...
That I don't know. And because that was not, I don't have to appear in any exams.
Biosimilar, generic, what do you use होता रहता है इसका actual implication?
If may
I will tell you the practically important point. So as
just answer a question. The reason it's called biosimilar is that recombinant is from a particular strain of the organism that they form. Biosimilar is biologically similar to that, but not exactly the same.
Yes.
So if you look at the literature, the efficacy of the biosimilar and original is same. There is no difference.
But in biosimilar, sometimes batch to batch variation will be there.
As per the study, no variation.
In point of
So I have never used, in my life maybe 3-4 cycles I have used Gonalef Like I have not seen only how it looks. Many of you have not seen how it looks. So this is a scenario with me. I use very normal injections.
When the progesterone level is when the progesterone level is more than 3.5, does it not reflect the number of follicles?
Take it, please.
If the progesterone level is high, if it is more than 3, does it not?
When?
In the in genuine.
Pair hours, you're talking about pair hours post period. It seems that मुझे इधर से छोड़ करके जाना है. या तो लगता है मैंने have blundered something great. Tell me.
No sir, if progesterone level is more than 3.5, then number of follicles could have been more, no sir. So it could have reflected the number of follicles which is secreting the progesterone will be more. In that situation also we can get a more amount of progesterone. So how could we apply then? The progesterone level is more than 3.5, then it may reflect the more number of follicles we got, no sir, in empty follicle syndrome. If the follicle number is more, then also we can get more amount of progesterone. So how could we account that if progesterone is more than 3.5, then?
The single corpus luteum secretes how much progesterone per day?
Not sure.
25 to 30 milligrams. So based on serum level, you cannot predict this progesterone has been secreted by how many follicles. There may be some follicle complete luteinized and there may be some follicle partial luteinized.
Okay, sir. A second question is, if the PCOS patient has having an empty follicle syndrome, there is no choice of SCG trigger. In that situation, can we change the formulation or a different dosage of same GnRH agonist trigger?
That's the only option left to us. In any case, we cannot use the SCG trigger. If at all after counseling with the patient, if patient agrees, we may use 3000 or 3300 unit with taking calculated risk, but then you have to sit with the patient, counsel the patient.
But we
I'm
can't.
telling you that nothing in PCOS, if there is empty follicle syndrome, nothing works. It is defect at the receptor level.
So regarding empty follicle syndrome, no, not my practical question.
मुझे बक्सो.
Does letrozole work in empty follicle syndrome?
The trials are underway. At the next Verdict conference, probably we will have some data. But on a sideways note, tomorrow I am going to be taking the presentation on everything about letrozole. Those who have attended that, yeah. And trust me, it's going to be in the morning only. And trust me, it's going to be a mind-blowing session. Okay, letrozole can be used in all these indications also. 7 indications. So let's see.
By tomorrow morning it will be 9. Because you will start thinking what more can be done with the letters.
Actually, I have not read male infertility.
So let's start discussion with
please continue.
Let's start discussion with the empty hall syndrome now.
You were going to ask some question about AFS. What was the question?
Yeah, it was regarding how to know that means it is a defective technique. Means you are not your surgeon who is doing home pickup. He is not properly done the home pickup. So how to differentiate in between that? Means in that case also he says no follicles are retrieved.
I don't think that the person who can be so incompetent that he or she gets empty follicle. The follicle FOI may be less. FOI may be less. So if less FOI, then that could be one reason, technical error, operator driven error. But empty follicle, I don't think so.
Okay.
He doesn't deserve to be
Doing
Regarding empty follicles, the other ovary should be punctured that ovary for a trial basis.
No, really, if you only 6 follicles should be punctured and wait after sending 1 or maximum 2 tubes. After 2 tubes, you wait, and both the tubes are empty. Then, if you are planning for re-triggering or something, because again you know what is the temperament of the patient, what type of the patient is. Because the moment you tell the patient will really spoil your mood. So what I do normally, whenever there is empty follicle syndrome, before going to explain the patient, I take a printout of empty follicles. पहले तो empty follicle syndrome जैसी कोई चीज है, वो patients who know ना, if you go speaking follicle नहीं मिला, I couldn't read out that I didn't get follicle. So patient will start thinking, doctor क्या बोल रहा है? कुछ समझ में नहीं आता आता नहीं है follicle निकालना. So take a printout of empty follicle syndrome, let them read.
After review also, you have a patient in house, you are dealing with this patient, you puncture right ovary, you collect 3 or 4 follicles, the embryologist score says 0, then the other ovary is there. Should you puncture one of the follicles?
No.
And confirm कि बाबा it's the same. Can it happen कि बाबा one ovary is not producing at all and other ovaries?
No. Many times it has happened in my place also. First tube, she will say no, there is no follicle, and second tube, she will say yes. Now you have retrieved. Because what happens, it takes some time to equilibrate the negative pressure in the tube with follicle and the collection tube. So sometime in first tube you may not get.
अपने को टेम्पटेशन आता है सर, दिख रहा है तो वो सिचुएशन क्या होता है?
डबल डालने का भी एक
और एक दिखा दो.
Now tell me what is our plan? Because couple of people, those who are non-residential registration, they have already left and they have requested me, please don't take lecture now, take tomorrow. And Sachin is saying, it seems that you all are tired.
Excuse me, sir.
Yes.
Sir, just wanted to discuss one case. So this was done just last one month ago. So this patient had already conceived in her first IVF with me and she has come back for her second pregnancy. So IVF was done for severe OATs. The E2 on the day of trigger was around 3,500, progesterone was around 1.2 I think. So I was not planning a fresh ET, so we gave decapeptyl 2 injections along with HCG 2000 units. On the day of pickup, she had around 12 follicles in the right ovary. The first 5 follicles were empty. So we tested the urine LH kit, which was positive. Urine HCG kit was negative. So I went ahead and aspirated another 4 follicles, out of which we got 2 oocytes. Then my embryologist told me that, madam, I can see some granulosa cells which are stuck to the oocytes. So maybe it is that the oocytes are not detached properly from the follicles. So for the left ovary, I have started flushing the follicles. I have flushed each follicle around 3 times I think. So we got around 6 oocytes from the left ovary.
Oh, that's good.
Yeah. So I think, out of 9, but only 4 were M2. I think 1 was M1 and remaining were GB. And on day 3, I think, we had one 8 A grade and one 6 C grade. So
So I don't even know what to call this. I didn't try the left ovary without flushing. So whatever I have done in left ovary, it was after flushing. So I don't know if I would have got oocytes without flushing. But just thought it might help somebody someday.
Maybe flushing I have never done.
What is flushing? It's with double lumen oocyte needle, sir. OPU needle, we push the saline and then we aspirate it back. Usually we do it for people who have less number of follicles. To increase the retrieval rate. This is something I usually do when somebody has very less number of follicles, like 1, 2, 3. So because we got 2 in one patient, one ovary, I wanted to try for the other ovary as well. She did get all the sites in the left ovary.
Basically, you put the needle, double lumen needle in.
Yes.
You first aspirate or you
aspirate,
first aspirate, then
flush, aspirate, flush, aspirate.
3 times.
Usually I do it twice, but because she didn't get in the right ovary, I did it thrice. And
each follicle.
So
each follicle.
we are now departing for dinner. After dinner, are planning to meet or tomorrow morning? Sorry? I am okay. My energy will never have at least 2 days is not going to be any time present. So we can do, I think, please listen. What I would suggest, after dinner, those who are not tired, you can sit and discuss, chit chat for a couple of minutes, we can do. And Sachin's talk we keep tomorrow morning. The only, we'll start at 8:30. 8:30. Okay?
So what time will it finish in the evening? Because most of us have our flights.
So 8:30 we will start. Myself and Sachin. Only thing tomorrow, all the speakers are requested to be very brief in presentation and have more time in discussion. Because once myself and Sachin, we cover our topics, after that practically very few questions will be left to be answered. So all other whatever topics are left, that more time can be utilized for discussion, and we finish our before maybe 4 o'clock or 5 o'clock, maybe before 4 o'clock, we finish.
Morning I had a presentation at 9 o'clock. I have to leave at 9:30.
Oh.
Can I do it at 8:15?
You take first.
8:15 I'll finish.
Great. So after that.